And now I hand over this session to all the chairperson. You may announce the speaker's name. Thank you so much, ladies and gentlemen.
Good morning, all. So first case presentation is by Dr. Shaukat Ali from Purnia.
Good morning, all the organizing committee members of Cardicon 2023 and all the delegates and chairpersons. My case presentation of 62-year male with a history of coronary artery disease with recent anterior wall MI, thrombolized outside with diabetes and hypertension, with pulse rate of 92 beats per minute and blood pressure of 148 by 86 millimeter of mercury. Chest and CVS are normal. This is the ECG at the time of presentation, which showing the slight ST elevation in 1 and AVL with slight ST elevation in V1 and V2 with QS in V1, V2 and ST depression in the 3 and AVF, suggestive of anterolateral wall ischemia. On echo, we found that LVEF was 35 to 40% with hypokinesia at the apex, apical and mid anterior wall and apical septum with concentric LVS. Angiogram done outside with showing left main ostial plaquing with LAD mid to 70 to 90% stenosis, diagonal ostium D2 with 95% stenosis and RCA distal 100% stenosis. I have taken this patient for the intervention, and this is showing allocranial view, and on allocranial view showing the RCA is severely tortuous, and distal part of RCA is 100%.
Can you discuss your plan? What was your strategy?
Yeah, sir. Plan was to revascularize all the 3 vessels. In the first sitting, I have planned for the revascularization of RCA, and after that bifurcation stenting of LAD and D1. LAT and D2. And
Why RCA?
sir, because sir, RCA was 100% occluded, and after successfully thrombolized, I have planned for the full revascularization of all the vessels.
But this is an anterior wall MI. Show us the
Sir, he was thrombolized successfully with this is the LAD and diagonal.
But ECG did not show inferior wall MI?
Yes, sir. Actually, ECG is settled down. ST elevation is settled down as compared to previously. V1, V2 is showing QS pattern with slight ST elevation in 1 and AVL. With Q wave in 1 and AVL. Yeah. Then revascularization of RCA, I have planned LAD and D2 bifurcation stenting with mini crush technique. Distal side of RCA is 100% occluded at the junction of PDA PLV. And after we have taken wire, but because of tortuosity, the JR not supported, and for that we have taken balloon anchoring technique from the RV branch and wired to the PDA. Which wire? This was a choice floppy wire. Yes, sir. And after POBA, we have got 90 to 95% stenosis in the distal RCA, and because of small territory, we have only done POBA in the case of RCA. Yes, sir.
Did you use nicotindil or any NTG to further?
Yes, sir. We have used Nicorandil for the after POBA, sir.
Is there any PA cranial view to see the distal PDA, PLB length? Because in this view, it cannot be clear that it's very small territory or not. Previous view with the wire, it is.
इतनी मेहनत की आपने, you did a wonderful job, so you should have stented it or at least residual lesion इतना नहीं छोड़ना था ना. इतना
Sir, because of a small territory in PA cranial view, and after that we have thought ki we will left after doing POVA, and if symptomatic we can do in further setting.
further sitting में कितना आएगा बेचारा, एक बार इतना मेहनत से. No, you should not leave residual stenosis. Okay, you don't stent, that's a different thing.
Then what size of stent should have been deployed?
2.5 and 15 will be enough actually in this setting.
No, but if you're not stenting, you should do a depth. You cannot leave a lesion like this.
PDA is always important because it supplies interventricular septum. LV,
तो कब बंद हो जाएगा पसीना? इतनी मेहनत की आपने. You did a very good, technique to cross the wire, anchoring and everything. And you should not leave lesions like this. और RCA की main method तो PDA ही होती है.
Yes, sir. After that, the plan was bifurcation stenting of LAD and D2.
In the same sitting or
Yes, sir, same sitting. In that case,
what was the echo-wise RCA territory?
echo-wise RCA territory was normal, sir. We have hypokinesia in anterior wall and septum
The
apex.
reason not to leave a residual lesion. And with that residual lesion, you are touching LAD. If something goes wrong with the LAD, then
It should be stented, sir, because at that time I have planned for revascularization of LAD and D2.
so again, like yesterday, these sessions are not only for showing your techniques, isn't it? These sessions are meant not only to show your techniques and tell people that you can do it, but at the same time, your clinical judgment has to be very important, very correct, isn't it?
Thank you, sir. LAD and D2 wired. After that, pre-dilatation of D2 done with a 210 balloon. Till the ostium and LAD of D2. After that pre-dilatation, a angiogram taken for the dissection. And sir, actually, this could be classified. It is independent lesion of LAD and diagonal, but because of significant stenosis in D2, we have planned the bifurcation stenting of LAD and D2 both. As per Medina classification, we can classify 0, 1, 1. मूव नहीं कर रहा है ये नेक्स्ट टाइम मूव कर प्लीज काइंडली मूव द स्लाइड नेक्स्ट स्लाइड pre-dilatation of LAD done with 2.25 and 15 balloon, and after that angiogram taken, and stent of size 2.520 and 2.7530 taken for the D2 and LAD, and mini crush technique was used. Stent of 2.5 20 inflated at the D2 with a slight protrusion in LED, and LED stent positioned across the D2 stent, and it is crushed through the LED stent. After that, angiogram shot taken, which is showing TME3 flow in both LED and D2, and after that pot taken with a 3/9 balloon in the LED, and rewired after rewiring D2.
What is the
Yes,
size
sir,
of this balloon?
Sir, 3/9, sir.
Okay, but this is not pot, it's extending
Actually,
to the...
slightly extending to the matlab distal to the D2, sir. Actually, very less protrusion of less margin in the proximal LED before D2, sir. That's why.
What should be when you are doing a mini crust? What should be the length of stent before the bifurcation? How much length of the stent should be there, and why it should be there?
Why the minimum size of the balloon is, what is the shortest balloon?
Shortest balloons are 8 size. 6 or 6.
There. So, but the recommendation is that at least 8 mm of stent should be above the bifurcation, so that, and when you are doing pot, then you should not cross the carina, isn't it?
Yes, sir.
If the whole purpose of doing a pot is defeated if you cross the carina. See, it's beyond the.
Slightly beyond the carinas.
Before the side balloon.
चलो, दिखाओ.
After that, kissing balloon dilatation done with 2.5 in the diagonal and 2.759 in the LED. Kissing dilatation done with slight protrusion of D2 balloon in the LED. For the
Which balloon will you dilate first?
sir, dilatation LED for the dilatation D2 balloon inflate first, then after LED balloon, sir.
What will be the pressure of the D2 balloon?
Sir, it should be same in the both branches.
पहले आपने dilate किया ना, so what will be the pressure?
We have used, sir, 14 to 16, and after that LED in 14 to 16.
It should be a high pressure.
Yeah, high pressure balloons.
But the final kissing should not be high pressure. You don't
Yes.
need to go high pressure.
Okay, sir.
है ना? But the diagonal when you are dilating, it has to be high pressure.
High pressure. After that, sir, sequential inflation and simultaneous deflation of D2 and LED. After that, the final angiogram shot showing TME3 flow with good inflation.
So you didn't do a final pot.
Yes, sir. Final pot was done with a 3/9 balloon, but it was not stored.
Okay.
This is the final angiogram shot, sir. Allocranial view. Thank you, sir.
But again, the same issue. Culprit only or total revascularization is the issue in this case. Pramod sir, we should have done only RCA and rest of the two stand in the next sitting or same sitting.
No, it's an old, it's not a recent MI. It's not a acute MI. You're not doing a primary. So in that situation, you should do the complete revascularization. In fact, now the recent studies have also advocated that you should do complete revascularization during index MI procedure itself. But not everybody agrees to that. But definitely you should do complete revascularization before the patient goes out of the hospital. That is is something which you must do, because there are ample studies which have shown that if you have not done complete revascularization, the MACE rate is higher in those patients in the coming months. So complete revascularization has to be done.
Very nice case, and final results was good.
Very good.
Sokat. So
Yes,
next speaker is Dr. Samsad.
Thank you.
Good morning, everyone. Can I have my slides? So basically, yesterday we presented a case of coronary intervention and SVG graft. Today we will move on to some structural intervention. So this is a story of a 45 years old male who had a history of persistent dyspnea. Most of the time he was being diagnosed with diagnosis of HFpEF, and he was treated accordingly. At multiple centers he was diagnosed with COPD. He was being treated with multiple inhalers, but he was not getting any kind of relief. Echo was done at multiple times, but echo was done in just in a view of whether he was having LV function normal or not. Shamshad PDA. Shamshad PDA. Yes. So we call it as reverse surfing over the tide. It is a story of retrograde PDA closer with the help of a handmade snare. So this is the summary. Now, when this patient presented to us, Pramod sir, he was there. He evaluated the patient. Patient went to his OPD, and on careful examination, we were able to find a continuous murmur, but he was maintaining a normal saturation at room air. And at this age, when he was evaluated earlier multiple times, most of us usually do not think that a PDA can present at the age of 50 years. A careful echo was done which revealed a small PDA which was around 5 mm with narrow pulmonary end, and left to right shunt was there. The pulmonary pressures were not too high. Mean pulmonary pressure when his cath cath was done, the systolic pressure was 60 and aortic systolic pressure was 130. Mean PAP which was calculated, it was 38 mmHg, and mean aortic pressure was 100. The before device closure, when the angiogram was done, it revealed a conical PDA type A as per the Krejchenko classification with very narrow pulmonary end. So now the PDA closure was planned. Initially, the conventional technique, what we do, we initially started, we tried to wire through PDA from the pulmonary end, what we usually do. This is the aortogram. So multiple attempts were made to cross that PDA antegradely through pulmonary artery. We tried it with the help of straight tip as well as a J-tip terumo wire over multipurpose as well as JR diagnostic catheter, but all of the attempts failed. It almost took more than 1 hour. We were unable to cross it antegradely. Then we planned that we have to close it. Then we proceeded to the retrograde approach. So through the retrograde approach, we crossed that PDA over the JR diagnostic catheter with a straight tip terumo wire. And then that straight terumo wire was exchanged with a J-tip exchange terumo wire after the crossing the JR diagnostic catheter. Then the issue was we have to snare that. At that time, it was the initial phase. When we started our cath lab at Medanta, it was hardly 3-4 months when we started our cath lab. So the snare, which usually required, we were not having. So we made a handmade snare with a long terumo wire, exchange and long terumo wire, and we passed it through the right femoral vein, and that the wire which was passed from the aortic end, we snared it towards the femoral venous end. Then catheter exchange was done, and after exchanging it with a catheter, antegrade stiff wire was placed over the multipurpose catheter, and plus catheter was in place. Then an 8 French delivery sheath, it was crossed over the stiff wire. Over this delivery sheath, a Amplaza duct occluded 9 PDA005 was deployed through the sheath. And after proper deployment and getting an aortic aortogram, when we found that we have adequately closed, then we deployed the device, and this was the final result. On follow-up further, there was significant symptomatic improvement in the patient. So the take-home message that whether the first question is that whether we should close a congenital defect at the age of 55 years or not. So the thing is that any PDA, when it is detected at any age, if there is no Eisenmengerization, it has to be closed because it is creating symptoms. At times, so usually I can say that more than 99% of the cases, Dr. Ashish is here, he has a large experience of structural intervention. So more than 99% of the cases, they can be closed antegradely, that the conventional route. But at times when we are unable to do it, then we have to go through the retrograde route. I remember it was in, I think, 2020, at IGIC when one structural intervention program was done. Then one patient, it has a PDA, it was a very small PDA. Actually, we were initially closing a VSD, but we were unable to close VSD. Then we also found an angiogram that there was a PDA also. So that might be leading to more symptoms. So with the VSD device, we closed that PDA, and that was done through the retrograde route because we already had an aortic route. And the device delivery, the important thing is that whenever we are going to deliver a PDA device, I am not talking about the VSD device. When we are going to deliver a PDA device, it should never be done, the delivery should never be done through the aortic end, because the wider margin, it should lie towards the aortic end, because the flow is from aorta to pulmonary. So every time we have to go through, you have to snare from the aortic end if we are going through the retrograde route, and then we have to deploy the device from the pulmonary end. Snare, it has to be there. Whenever you are doing structural intervention, you should have. Now we are having every kind of snare in our cath lab, but whenever these things are not available, you have to do something tricky. You have to make your own snare in your cath lab. Thank you.
Just one question, Samsad. When you have already hooked PDA from aorta, so is there any advantage of using a straight-tipped thermowire? Why not the normal J-tipped thermowire? That's what I want to know. Whether, because a straight-tipped thermowire, after that, when you are crossed aorta to pulmonary artery, then maneuvering with that straight-tipped wire will be difficult, or it may injure some tissues. So why not use the normal J-tipped wire? Because the already hooked PDA, so and very small hole is there. So the normal J-tipped thermowire also can go.
Yes, it can go. Actually, we were having that straight-tipped thermowire. We tried it multiple times. We are unable to do it from the J-tipped thermowire. So we were quite comfortable with the straight tip. Actually, the straight tip, we didn't pass it very long way. We just crossed that PDA and we moved forward our diagnostic JR catheter, and then we immediately exchange it.
Where you snared that straight tip wire? In the PA itself or in the RV?
No, we didn't snare straight tip. We just crossed our diagnostic JR catheter over that straight tip. We just passed on, hardly it was 5 to 6 mm. We crossed that our JR catheter. Then we exchanged it with a long J-tip thermowire.
Okay.
And we snared our J-tip, a long thermowire from the SVC.
Okay.
Good case, Dr.
Two
Shamshad.
observations.
But,
Sorry, you continue.
okay, so two comments that whenever, of course, because you had it on table, so you used a straight tip turbo wire. But we usually prefer to use a J-tip Teflon wire once the PDA is crossed antegradely. I mean, even if you have snared the thing, and then you have advanced the multipurpose into the descending aorta. Second thing is that whenever we improvise a snare, we try to use a BMW 300 centimeter wire. The advantages are that you can even, actually I find it better than the conventional snare, because conventional snare has a particular size. So for example, in an adult who has a dilated SVC or an SVC which is bigger than the snare loop, then the improvised snare, we can adjust the size of the loop right there according to the need. So bigger the vessel and safer the vessel to station the retrograde wire, and then making the loop size bigger according to the vessel or the chamber in which you want to catch it. So we find it better, and it saves a lot of money of the patient also.
Actually, the issue is that we have experience of using that long length BMW handmade snare. The maneuverability of handmade BMW snare is not that good as compared to that long length thermo snare which we make.
Yeah, that may be, yeah.
You have one observation to make.
Sometimes with when you use either Roadrunner or 018 or steel wires, because it is in the mid part, hard part, when you are catching it, at that time it can bend. So thermo will not acutely bend.
Yes.
You have snared from the SVC, right?
Yeah.
I don't prefer doing snaring from the SVC. The reason is that once you have done the snaring from the SVC, your wire has crossed through the tricuspid valve, and you don't know where the chordates are there and how it is crossing. So when you are passing the sheath from the venous side, then it can get stuck or it can damage the chordate. So one should be very careful. Try to snare it from the
RV.
Pulmonary artery.
P.
So when you are crossing to the PA from the venous side, you make sure that you are crossing without going into the chordae. It is clear crossing, and then snare it from the pulmonary artery. That will be the better approach.
Actually, if I would have been my gooseneck snare, then I would obviously preferred it snaring from PA, because it was a handmade snare, so it would have been very difficult to cross it towards the PA.
And what was the you recorded the PA pressures after the deployment of the device? Because you mentioned that it was 60 initially.
Yeah, after the deployment of the device, it was around 38-40. Just after deployment of the device, there was not that much very significant, because patient was also having grade 2 diastolic dysfunction too.
How will you confirm this is a dyspnea is due to this PDA?
Actually,
how will you decide to intervene in these type of dubious cases?
the issue was that patient was already on HFpEF therapy. He was not getting any relief. He was already on COPD therapy, and we found an additional thing. So we have, because it was a correctable thing. HFpEF you cannot treat it permanently. COPD you cannot treat it permanently, but if a PDA is there, that you can treat it permanently, and you can give that.
If there is shunt is more than 1.5 or more than 2, LV is indirectly dilated, or increased BNP level, these are the indirect evidence where we should intervene the PDA. But in this age, already patient maybe have diastolic dysfunction, maybe due to itself, due to aging process and other comorbidity. So because every intervention has some own risk, because if you confirm that this will be benefit the patient, then you have to go for the intervention. Other
Continuous murmur was audible. That's why we proceeded with further workup and further intervention.
Dr. Samsad, one question. Patient was symptomatic. After closing the PDA, patient post-op time, patient had developed more symptoms in comparison to the before operation, because afterload increases. After just you close the PDA, afterload increased, then patient require more diuretics therapy.
No,
or symptom
after
improved?
closing the PDA, it is more apt for ASD. With diastolic dysfunction, when we close ASD, then this issue is there. But when it comes to PDA, that afterload, you are reducing the afterload, because you are reducing the left to right shunt.
Just immediate post-op.
Yeah.
Not I'm asking about the long term. Just after closing the PDA, immediate after the OT, afterload increases.
No, just immediately closing the, because we are reducing the preload. We are reducing the shunt from aorta to pulmonary artery. So obviously we are reducing the preload. So after effects of reducing preload is that we will get a reduced afterload.
Pramod sir?
Yeah.
Yes.
Afterload will increase immediately.
Patient may go into further failure.
If the PA pressure doesn't rise, that means it is not clinically significant. So if the PA pressure rises, only then these things come into picture. So if the PA pressure has fallen, whatever, 10, 20, whatever it has fallen, that means the left to right shunt was significant and it required a closure.
Moreover, one school of thought, very strong recommendation actually is that every PDA, whenever recognized, should be closed because it comes under the high-risk lesions for infective endocarditis as per the classification.
Thank you, Samsad.
Thank you.
So next speaker is Dr. Ashish Jha from Heart Hospital, Patna.
So, good morning. My due respect to all my seniors. So, this is one case in which I was stuck. It was an emergency left main bifurcation stenting. 56 years old male presented with accelerated angina for last 15 days, known hypertensive for more than 5 years, smokers with strong family history of CAD. ECG showed valence T-wave pattern, echo was normal, TROP-T negative, normal biochemical parameters. Underwent coronary angiography outside, which showed 99% osteoproximal left anterior descending artery stenosis, minor lesion in distal LCX, and normal right coronary artery. So this is the LAO caudal view which we have started. So the plan was to do, because of a single vessel lesion, the plan was to do osteoproximal left main to LAD stenting. And the LCX osteum we can see was looking good. Distal LCX was having some lesion, so we thought that left main to LAD stenting with provisionally we thought we might do the LCX if there is any pinching or anything. But just after crossing the wire, patient had means a component of ACS. There was slow flow in the LAD that we can see. And we dilated the osteoproximal part. We didn't go into the left main. And just after this dilatation, there was, we can see a chunk of thrombus and the flow stopped in both left LAD, there was no flow, and LCX, it was completely stopped. So the first priority in this setting is to preserve LAD because that is what saves life. So we immediately took the stent, 4x20 synergy stent. We placed it there and we dilated it. Gave lots of anti-Z, adenosine, BP was good, means he was holding BP, so gave anti-Z, adenosine, and then intracoronary tirofiban. And then flow improved in the LAD, that we can see that there is almost a good flow, almost TIMI2 flow. And then immediately wired, took almost 2 minutes to wire this LCX through left main stent. Took a 1.25 mm balloon, crossed, dilated the stent strut so that I thought that there is a plaque rupture and it might be a plaque shift also. So we just took this thing, thrombuster, and did the thrombosuction. But what we got on this thrombosuction is not a red thrombus, but a white thrombus, and a lot of white thrombus. So then we just, this is what, after the thrombosuction, this was the picture. We, sorry, this thing is not visible here. We then took a 2 mm balloon and we just dilated the strut, and then we found this, still there was some lesion. We saw the flow in LAD, which was good, but still there was some slow flow. So what we decided was to do, to put the patient on tirofiban and to see whether it is a thrombus which might dissolve with tirofiban. We kept him for 2 days. Flow was good in both LAD and LCX, so we decided to do it after. इसको थोड़ा सा आगे कर दीजिए, ऐसे कर दीजिए, fix है, ये हमको नहीं दिख रहा. So इसको थोड़ा सा आगे दीजिए, दिख नहीं रहा है। So this is after 2 days, we can see that LCX is still having the same lesion. The flow is good, but again, there is the lesion is still there. So we did, thank you, thank you. So we did the IVUS of this LAD. We decided to go for this. This is the IVUS run of LAD. This is the distal part where there is 180 degree of circumferential calcium. And we have not put the stent there. We went into the normal part, means that day we didn't do the IVUS. So now this stent starts, almost good apposition. We have not done the post dilatation that day because of slow flow. So there is some mal apposition in the proximal part, which so this is the IVUS run, which was and now we are coming into the left main, which was good. So proximal landing zone was good. And then this is the IVUS run of LCX we did. From LCX, we wanted to know what this thing is. So we did the IVUS run of LCX. I will show you the IVUS run. And then we just we initially dilated the LAD stent because it was not post dilated. We dilated the LAD stent. And then this is the LCX run. The LCX, which was appearing quite normal on angiography, this is diffusely diseased vessel. This is the OM going, then we can see the diffusely diseased vessel. Although the caliber was not great, but there was not a good landing zone where we can land a stent. But this part appeared to be relatively better. But why? Sorry. This is distal, sir. So I will show you the proximal where there is a large chunk of lipid pool and there is a plaque rupture with blood spicules. This is what I just want to stop it. No, just proximal to this. Whole artery is diseased. Yeah, on angiography it looked almost normal. So, and the lumen size is good. So yeah, there we can see just. I just want to stop it at a point osteal LCX where there is a large lipid pool. Here we can see this is a large lipid pool, and then there is a just proximal to this. Again, now it's not running. I don't know, it's not. Calcium भी है sir, yeah. Some calcium is there, but not great. Means LAD distal had a huge chunk of calcium distally, but not significant lesion at that point. पॉइंट पे रोकना है और फिर स्टार्ट करना है. एक मिनट यहाँ मैं बोलूँगा, मैं रोक तो दूंगा भाई. या दिस प्लेस here we can see the blood spicules with a large lipid core and then यहीं पर स्टार्ट करना है. नेक्स्ट चला जाता है. Anyway, so then we decided to stent it because it was having a significant lesion, and then we did crossed this thing because we had initially dilated the stent struts, crossed this thing with a 2.5 16 mm synergy stent, dilated it, and this was the post dilatation. This was the post dilatation LAO caudal view. Then we initially did the sequential dilatation of the LCX at 16 to 18 with 2.5 into 16 mm balloon, and then there with a 4 into, that is 4.25 in fact, 4.25 at 16 atmosphere, and then did the this kissing balloon inflation at 12 atmosphere. This is the final result, and this is the LAD flow, so it was good. This is the final LCX run post stenting. There was some malposition in the proximal, in the left main part. Again, we dilated it with a 4.5 mm NC balloon. Distal LCX, we left it because lumen size was good. We decided not to stent the distal part. We just took care of the proximal, osteoproximal portion of the LCX. Yeah, this is the stent part. Looks well opposed here.
What was the size of the stent?
2.5 16. LC. Yeah, we dilated at high pressure with a 2 point, we post dilated with. But we post dilated with a 275, not 275, not with 3. And then this comes into the left main part.
So it was a tap technique?
Yeah, it was a tap technique. We could have done internal crust, but or reverse crust, but I think this was the better.
Internal crust, no. In these situations, either tap or a reverse kilo.
Reverse kilo, that also. So this is. So always beware of LCX compromise due to plaque shift or plaque rupture due to balloon inflation causing injury to native carina, especially if it has a large lipid pool. LCX may provisionally be wired to act as a guiding path, but sometimes you have to cross it. Means even in provisional cases, LCX has to be rewired through left main stent struts. Be prepared to do tap or internal or reverse crust. CAG may be misleading, as was in this case where LCX was diffusely diseased on IVUS. Securing flow in LAD should always be the first priority in case of acute vessel closure. Generous use of intracoronary tyrosine anti-Z adenosine is always useful. Thrombosuction can be useful. Had it been an acute rupture red thrombus, then it might have been useful. And you should always be confident of yourself in salvaging patients from these complications whenever you are doing left main to LAD cases. Thank you.
Ashish, you have managed the complications beautifully after arising during ostial LAD angioplasty. Ostial LAD angioplasty is a very common problem we all are doing. What steps you have taken to prevent the complications? Just give us the take-home message. What other things could have been done to prevent such complication during ostial LAD angioplasty?
We could have kept wire in LCX, sir. I don't know anything other what I could have done, because we could have kept wire in LCX. We do left main to LAD so many cases, and we have found sometimes these complications, especially in acute MI cases, STEMI cases where the thrombus is very high. We could have done the LCX wire, but in this patient had an accelerated angina. His drop was normal. Angiography was done some 1 week outside. So I was not expecting it, but.
Do you have some role with, ACT? During ACT, you have to keep ACT in optimal range?
I don't do routine ACT because we usually give 10,000, 8 to 10,000 of heparin to all patients. So I don't think ACT was the issue.
Size of balloon, inflation, size matters?
We always pre-dilate with 2.5 to 3 mm balloon. This vessel was almost 4. So, and we have kept a 4 stent and post-dilated with 4.25. And I kept the balloon tip just distal to the ostium of the LAD. But still there was, because there was a significant lesion in the LCX ostium and there was some injury to the carina, so maybe plaque has ruptured with large lipid core, maybe vulnerable plaque which has ruptured due to its injury. In
So
this
if
case, LCX appeared to be completely normal, ostial LCX angiographically.
So that's the beauty of doing an imaging before you do it.
Yeah.
Before you proceed with the procedure, especially these technically challenging and with very dire consequences. So if you had done an imaging, you would have known exactly whether the LCX ostium is diseased. See, you should take it as a, I would say that 100% truth that if there is an osteal disease, the distal left main and the osteal circ will always be diseased.
Yeah, that.
So whatever is the angiographic finding, it's a fact which everyone has to accept. So if you had done an imaging, you would have known that what should be your strategy. You would have known also that whether there was any thrombus sitting at the ostium of the LAD or not. That would have again helped you to make sure that you wire the circ before you proceed with the procedure, isn't it?
Yeah. But again, whenever we wire, again we have to cross it through the stent struts only.
So doesn't matter. But you know, if LCX was a bigger artery, you would have been in real trouble.
Yeah, LCX would have been bigger. Then we should have wired the LCX.
So if it's an osteal lesion, acute lesion, it's safer to do an imaging before you start the procedure, so that you can actually plan. The beauty of imaging is it helps you in planning your procedure.
Putting wire first will help you to recross the wire easily, because you have a landmark.
Sometimes.
Landmark
most of the times,
where to cross, how to cross.
You did a very good. Yeah, actually in ACS situation and left main intervention, always be ready for these things.
Yeah.
Always be ready for 2-wire, no reflow, management of hypotension, bifurcation stenting is very important. You should expert in doing wiring and doing the bifurcation. Always mentally be ready for the bifurcation. Many times we are facing this problem.
Thank you, Dr. Ashish, for the wonderful case. So next I invite Dr. Vipin Kumar for presenting his case.
Good morning, everyone. So after nice coronary cases and structural case by Samsad, I will be going to present some peripheral cases and few cases of visceral artery aneurysm. So among the visceral artery aneurysms, the most common comes with a splenic artery aneurysm, and these patients sometimes is very huge aneurysm and presentation is devastating and life-threatening complications. So this is a case of 30-year-old female was having abdominal pain, and it was undiagnosed earlier, and ultrasound showed some suspicion of vascular structure along with hematoma, and then CT angiography confirmed it is as a splenic artery aneurysm. And you can see this is a lateral view. Yes. So yes, when we engage celiac artery, first we engage in a lateral view, and then we take an anterior view. So actually the aneurysm was very huge. I could not take the CT picture because yesterday only I made this slide. The size of aneurysm is only this cavity, but apart from that there was a thrombosed part all over this side. This is a AP view of DSA, and then we passed the normal glide wire with a 4F JR, and then exchanged with a thermo stiff wire, and then we took a long sheath here in the aneurysm, and this is an angiogram of aneurysm through the long sheath. And because there was no distal vasculature seen in this splenic artery, so we wanted to close this aneurysm, and if required from backside later on to undergo splenectomy. So this was closed with a 10 mm vascular plug, Amplager vascular plug 2. So you can see here it is closed, and then the common hepatic artery was now visualized from the celiac artery. So this was the final angiogram. So in this case, the splenic artery itself was closed with vascular plug. So again, another case, 80-year-old male is a patient of CKD and again presented with abdominal pain, and he had severe anemia, hemoglobin of 4 despite multiple transfusions. And again, the similar thing, ultrasound suspected it and CT angiography confirmed it. And there was multiple aneurysm of the splenic artery, and there was a leaking, one aneurysm was ruptured, leading to a large hematoma. So you can see the smaller multiple aneurysms. So in this case, distal vessels was seen. So the plan was we cannot close with a vascular plug because from the opposite side the aneurysms again will continue flowing. So we plan to exclude the aneurysm, that bleeding aneurysm with a graft stent. So similarly, we kept a stiff wire beyond that leaking part and with a long sheath and a stent graft, fluency stent graft was deployed. There's still some leak through that part, but actually the size I would have taken a little better, bigger size, but availability is always an issue, was what I expected. So this was 1040 vascular graft. And again I saw a third case. This is an aneurysm of proximal splenic artery, and this was a little difficult one because it was very tortuous. You can see in this view the splenic artery arising from the it's a aneurysm of proximal splenic artery, and continuing to the distal part is almost 360 degree. So again, so here always when we are closing visceral artery aneurysms, we have to first plan both sides. You need closure, because from the other side vascularity is always there and it will keep flowing. So we cannot close the proximal part only, we need to see the distal part. So in this case distal part was closed with a vascular plug first. It was little difficult because of that severe 360 degree angulation. So here I have closed distal part, distal splenic artery, distal to the aneurysm with a plug, and the proximal part was little easy. Just across the celiac common hepatic axis, we have placed a vascular graft, fluency plus 1040. So the celiac artery, common hepatic artery patency was maintained with a vascular graft, and distal part was closed with the. So in this case, this aneurysm was totally excluded. Earlier two cases, what I have shown, only the proximal part was closed. Distal part, in the first case was very huge aneurysm, so distal part was not closed. In that case, we have planned that if there is a still bleeding or hematoma is there, then patient will go for surgery later on. So this was the after 1 month CT angiogram of the patient. So splenic artery aneurysms are rare abdominal artery aneurysm and usually incidental finding, but rupture in cases of large aneurysm carries substantial mortality, and usually surgeons are very reluctant to touch these patients. Transcatheter treatment is feasible and preferable over surgical management, and as for any visceral artery aneurysm, need to close from both proximal and distally as far as possible. And for all interventional cardiologists, we should be aware of all these techniques, using wires, exchanging the wires, using stiff wires, exchanging the catheters, and taking long sheath, and all these devices always take inside the long sheath. So we should be aware of these techniques. Thank you.
Actually, very few doctor is doing this type of intervention in Bihar. He is doing lots of peripheral interventions. He has a large experience. Very good case.
Thank you. This.
Thank you so much, all wonderful speakers. And now may I now request our chairperson to felicitate our speakers. First of all, I would like to call Dr. Ashish, kindly come up on stage. And all the speakers, Dr. Saukat Ali, Dr. Vipin Kumar sir is on stage itself, Dr. Siddhant Singh, okay, Dr. Shamshad sir, and Dr. Vineet. All name was, okay. Dr. Ashish. Give them a applaud, definitely. Their presentation was wonderful. And our next session is management of chronic coronary syndrome. And our chairpersons are Dr. Arvind Kumar, Dr. B.B. Bharti, Dr. Om Prakash Arya, Dr. C.B. Chandan, Dr. Aman Sinha, Dr. Nishu Singh, Dr. Amit Jha, Dr. Amit Kumar. I would request all the chairperson to chair. Thank you so much. Thank you so much, sir. And the chairperson are of our next session, Dr. Arvind Kumar, Dr. B.B. Bharti, Dr. Om Prakash Arya, Dr. C.B. Chandan, Dr. Aman Sinha, Dr. Nishu Singh, Dr. Amit Jha, Dr. Amit Kumar, and Dr. Abhinav Bhagat, Dr. Rajiv Krishna, Dr. R.P. Srivastava. Sir, please come up on stage and join us to chair. A round of applause for our wonderful chairpersons, ladies and gentlemen. And our first speaker of this session is Dr. Manish Shankar Pandey, is from Patna only.
Good morning, respected seniors, dear colleagues, and I would like to thank organizing committee for giving me such a wonderful opportunity. And my topic of discussion is management of refractory angina. Refractory angina is diagnosed in 5 to 15% of CAD patients, and the survival is similar to those with a stable coronary artery disease, and mortality is low, but they have debilitating symptoms, high rate of hospitalization, and poor quality of life. With improved survival and an aging population, refractory angina is emerging as a major clinical problem, and patients with refractory angina have either marked limitation of physical activity and they are unable to perform any ordinary physical activity without any discomfort. And according to 2090 ESC guidelines, refractory angina is defined as it is a clinical condition characterized by angina, long-lasting symptom more than 3 months due to objectively reversible ischemia, and evidence of ischemia as demonstrated by exercise, treadmill testing, a stress imaging study, or coronary physiological studies. And angina unmanageable by optimum medical therapy, including second and third line anti-anginal agent, and surgical or percutaneous revascularization, and also including percutaneous revascularization of chronic total occlusion. And the prevalence of angina increases in elderly populations, and there is 3 distinct phenotype of refractory angina, and one is coronary anatomy unsuitable for revascularization, like severe diffuse coronary artery disease, poor distal target vessels, multiple coronary restenosis, and collateral dependent myocardium and degenerative venous grafts. And high-risk patients like advanced age, frailty, CKD, multiple coronary that have increased risk of revascularization, and microvascular angina. Management of refractory angina includes the pharmacological management like beta blockers, CCB, and second and third line anti-anginal agents. Non-pharmacological having non-invasive options like EECP, cardiac shockwave therapy, and invasive non-pharmacological management are coronary sinus reduction surgery, CTO complete revascularization, and transmyocardial laser revascularization, therapeutic angiogenesis and neuromodulation by spinal cord stimulation, and transcutaneous electric nerve stimulation and subcutaneous electric nerve stimulation. This is the management strategy of refractory angina, and where you starts with risk factor reduction like smoking cessation, regular exercise and rehabilitation, and healthy lifestyles, including management of comorbidity like hypertension, diabetes, and dyslipidemia, along with evidence-based management of stable therapy for stable angina. And specific therapy for refractive anginas are ECP, spinal cord stimulation, transmyocardial laser revascularization, coronary sinus reduction surgery, and extracorporeal shockwave therapy. This is the enhanced external counter pulsation. This is class 2 recommendation for refractive angina, and must ECP trial shows significant increase in exercise time and significant improvement in time to more than 1 mm ST segment depression in ECP groups. An international ECP patient registry also showed the CCS angina class improved by 1 class in 78% and 2 class improvement in 38%, and improvement was sustained in 74%. ECP was safest, non-surgical, USA FDA approval treatment for chest pain and heart failure, having no pain, no surgery, no need of hospitalization, cost effective. And in ECP, we were used 3 cuffs, one in calf muscles, and second one is lower thigh and upper thigh, third one upper thigh, and they inflated ECG guided sequential inflation in diastole, and then sudden deflation in systole. During sequential inflation, they cause an increased diastolic pressure, which increasing the intracoronary perfusion pressure and increase myocardial perfusion. And also, they increase the venous return, increasing the preload, and increase cardiac output. And in simultaneous deflation, they decrease the systemic vascular resistance, decrease cardiac output, decrease myocardial O2 consumption, and decrease afterload. It is OPD basis treatment for chest pain and heart failure, and treatment given 1 hour per day and 6 days per week, and total 35-hour session given. And the contraindications are patient on anticoagulation, those with arrhythmia, severe peripheral artery disease, and venous disease and COPD. Cardiac shockwave therapy, it is non-invasive and well-tolerated treatment, delivered acoustic energy 10 times less powerful than that used in lithotripsy, and it creates acoustic cavitation and generate localized shear stress on the cell membrane, causing upregulation of vascular endothelial growth factor, recruiting of endothelial progenitor cells, and promoting angiogenesis, resulting the inflammatory response, inhibiting the apoptosis and fibrosis. And the echo-guided shockwave were delivered in the ischemic area in diastole, and 3 sessions over 3 weeks for 3 consecutive months are given. And meta-analysis of approx 1,000% demonstrate improvement in angina, quality of life, myocardial perfusion, and exercise capacity. Here we can see a shock wave generator was placed over the chest, and shock wave delivered by echo-guided shock wave delivered to ischemic area, which increases the which induces potentially the neovascularization from the healthy region to ischemic area. Coronary sinus reducer. It is also class 2 recommendations, and it is balloon expandable stainless steel hourglass shaped device designed for percutaneous implantation in the coronary sinus. It creates a focal narrowing leading to increased pressure in the coronary sinus and eventually relief of angina. Elevated coronary sinus pressure induces recruitment of the coronary collateral flow by a sinusoidal gradient and create a backward reduction in subendocardial capillary resistance, which allow redistribution of the coronary blood flow to underperfused myocardium. And COSIRA trials confirmed the safety of the procedure and reported a significant improvement in angina with reduction of at least 2 class in 35% patients. Right jugular vein is the preferred access route, and implantation site must be chosen carefully to maximize the effect and minimize the risk of device immobilization. And importantly, the reducer is effective only for the treatment of angina due to left coronary artery lesions, as the venous drainage of the right coronary artery drains into the coronary sinus near its ostia or directly into the right atrium. And increase in coronary sinus pressure causes endothelial activation will increase the myocardial protection and regeneration, and also it increases the flow redistribution, causing increased perfusion to ischemic segments. Transmyocardial laser revascularization, FDA-approved invasive treatment for refractory angina, relatively new technique that attempts to improve the blood supply to ischemic myocardium by using a high-powered CO2 laser to create a multiple transmyocardial channels. This new channels brings blood from the ventricular cavity directly into the myocardium, and the 25 to 40 channels are made 1 cm apart in all the ischemic area noted from the system scans. Approx 6 studies have been done which shows the improvement in symptom and having no survival benefits. Therapeutic angiogenesis. Regenerative therapy using genes, cytokines, and progenitor cells have been extensively investigated for refractory angina. Cell therapy promotes neovascularization and myocardial perfusion, leading to increased myocardial contractility. And stimulus of angiogenesis are exercise, proangiogenic therapy, ischemias, which causes a healthy angiogenesis or therapeutic angiogenesis, but in infarction and regeneration, there is unhealthy angiogenesis having inability to respond to metabolic demands. Neuromodulation. It is an interruption of nociceptor signals using mechanical, electrical, or chemical means at any level from the periphery to the central nervous system in order to modulate the perception of cardiac pain. Approach of neuromodulations are spinal cord stimulation, transcutaneous electric nerve stimulation, subcutaneous electric nerve stimulation, and is a safe and effective treatment modality for management of refractory angina. A spinal cord stimulation is a class 2 recommendation, and it is minimally invasive and reversible, FDA approved management for refractory angina, and low intensity electric stimulation by electrode inserted in the epidural space, and electrode is connected with the pulse generator. And phase signal neuromodulation reduces the effective sympathetic activity with reduced heart rate and systemic blood pressure, leading to endothelial mediated vasomotor functions. And here we can see nerve stimulation causes inhibition of the spinothalamic tract, which increase the regional cerebral blood flow area of the pain perception and cardiovascular controls, which decrease the myocardial oxygen demand and increase the angina class. Multidisciplinary approach, a concept of angina clinic. It involves the specialists including cardiologist, pain specialist, psychiatrist, psychotherapist, and yoga instructor. And it has been found that a multidisciplinary approach to refractory angina improves the quality of life, exercise capacity, and reduce hospital admission. Use of anxiolytic and citalopram, yoga and psychotherapy helps in reducing mental state in ischemia, and self-management training is another evidence-based treatment for refractory angina. Here you can see when a patient of refractory angina comes in OPD, review or perform imaging testing for ischemia, And if ischemia more than 10% of LV myocardium or more than 3 segment of stress-induced hypokinesia, please do a coronary angiogram with FFR guided. And your obstructive disease suitable for revascularization, please do CABG and PCI, including CTO PCI. If obstructive disease not suitable for revascularization and left coronary and disease involving left coronary system, coronary sinus revascularization is an option, and in disease involving right coronary sinus, ECP and neuromodulation is an option. And refractory angina was often called as no option CAD, and in-stage angina pectoris is refractory to conventional medical therapy and not amenable to either CABG or PCI, represent a truly disparate and frustrating condition. Management involving various pharmacological, non-pharmacological and novel technique has improved both symptom and long-term survival, and the choice of treatment should be mainly based on careful assessment of balance between the benefits for the disabling symptom of the patient and risks associated with treatment of option. Thank you.
Thank you, Manishankar. Nice elaboration. But just wanted to when to use this non-pharmacological modality, and which group of patients are suitable for this indication, because they are class 2A or class 2B indications. So in which group of patients should we use, and how cost effective these are?
When a patient comes with ischemia, comes with angina, having ischemia, and ischemic myocardium more than 10%, then we perform coronary sinus reduction surgery or redo CABG or even CTO PCI.
Thank you, Manishankar. The next speaker is Dr. A.K. Jha. He will be speaking on Management of Chronic Coronary Syndrome 2023 guideline.
Yeah, good morning again. My warm regards to all my seniors. So this is a clinical update. Most of these, almost all of these slides are from ACC AHA 2023 guideline. Most of these things we know, so I will be talking only about the things which I have learned from after reading this guideline. So chronic coronary disease, what comes under the definition of chronic coronary disease? Any patient who has been discharged after acute coronary syndrome or after coronary revascularization. So what is the duration of this acute coronary syndrome and coronary revascularization? There are different studies. Some say that 2 weeks, some says 4 weeks. So we can take 4 weeks. After 4 weeks, patient comes into a category of chronic coronary disease from acute coronary syndrome. Then second group consists of left ventricular systolic dysfunction and known or suspected coronary disease, or with established cardiomyopathy and which has been diagnosed of ischemic origin. Stable angina, which comes classically under the definition of chronic coronary disease. Angina symptoms and evidence of coronary spasm or microvascular angina. And diagnosis based solely on result of screening test. For example, now many a times we encounter patients coming with a CT angiography not recommended by any doctor. They have done it by themselves and it shows some 30–40% lesion. So that also comes under a definition of chronic coronary disease. So evaluation, the thing is we have to go for an evaluation specific for chronic coronary disease only when the patient is refractory to guideline directed medical therapy. If the patient is asymptomatic, nothing is needed specifically for chronic coronary disease. I am talking about the ischemia tests which are directed to see the ischemia, for example, stress echo or intracoronary angiography. Do it only when patient is symptomatic after guideline directed medical therapy. If patient is asymptomatic, nothing is required. So whenever patient symptoms persist after, despite ZDMT, we can go for a stress echo, which is available in our case. PET CMR is also class 1 indication. Coronary angiography is class 1 indication to guide the therapy for decision making and improve symptoms. Whenever we are doing PET or thallium study, PET is better. Exercise stress test has a class 2A indication, and CT coronary angiography has also a class 2A indication for bypass graft and for patients who have undergone stent. Now again, there is a caveat in this that stent CT angiography is not a very good test. So only with a stent size more than 3 mm, we should do the CT angiography to know the patency. For stent less than 3 mm, CT angiography is not a good test. So what are the risk stratification? We know that there are different variables, demographic variables, social variables, medical variables. So there is a validated risk available. We should do that, we should do risk stratification in most of the cases. And regarding treatment, optimize guideline-directed medical therapy, which we'll be discussing later, that is a class 1 indication. Intracoronary angiography to assess anatomy and revascularization in any patients who have developed reduction in LV ejection fraction or who had developed symptoms of heart failure. It is not indicated in patients without LV systolic dysfunction or heart failure or without patient is stable on medicines. Angiography is not indicated. So these are the features associated with high risk of MACE. We know age, gender, poor social support, poverty, lack of healthcare access. In Indian condition, female sex are more prone for having higher risk of major adverse cardiovascular events. Then there is a medical history, elevated BMI, previous acute coronary syndrome, patients with heart failure, atrial fibrillation, diabetes, dyslipidemia, CKD, smoking history, concomitant peripheral arterial disease. Depression is a very major association, so we have to screen all these patients for this. And patients who are poorly adherent to therapy, they are also at high risk of MACE. What are the biochemical markers? If there is a troponin positivity or even BNP, if it is positive in patients with angina, then it is a marker of higher risk of major adverse cardiovascular events. And on testing, patient inability to exercise, angina with stress, and if it is a stage 1 high, strongly positive TMT, or if the baseline ECG shows left bundle branch block, or if there is a high resting heart rate. Now, what is high resting heart rate? High resting heart rate has been defined as rate more than 80 in resting condition. So anything more than 80 is not good. It should be resting heart rate should be less than 80. If on echo we see reduced LVF or LVH, exercise stress test, we know that high Duke treadmill score, high resting heart rate, and whenever we are doing the exercise stress test, if there is a peak rate pressure product, we know normal is 25,000 to 35,000. But if it is less than 15,000, then that is also a marker of higher risk of MACE. So on CT angiography, high calcium score is a very good indicator. At the same time, there is a napkin ring sign, which if we see on CT angiography, that is also a marker of unstable plaque, which might go for an acute coronary syndrome. So the goal of treatment, we all know, to reduce cardiac death, to reduce non-fatal ischemic event, to reduce the disease progression, and to improve the symptoms and functional limitations. Patient education, as Dr. Manisankar said, patient education and shared decision making is very important, and we should always respect patients' decision. If they are saying that we are not willing for angiography, it's good. Let them be on medicine. The social determinants, which we have already discussed. Now, what is the nutrition? We know most of these things: vegetable, fruits, legumes, nuts, whole grains, lean protein, complex carbohydrate, dietary fiber, monounsaturated fat should be less than 20% of daily calorie. PUFA should be less than 10%. Avoid baked, fried fruits, hydrogenated or oil shortenings. All these things should be avoided. Now, what is there are some studies which have shown benefit of vitamin D supplementation. Although there are no trials, randomized trials, but some studies have shown, small studies have shown vitamin D deficiency association with chronic coronary disease. But larger studies have not shown any benefit of vitamin D supplementation or, for example, vitamin E, beta carotene, or calcium supplementation. This is very important. All these patients should be screened for depression, and psychologists or psychiatrists' opinions should be taken in case of depression associated with chronic coronary disease. Tobacco cessation is very important. Behavioral intervention, pharmacological therapy, and nicotine replacement therapy all are class 1. Varenicline specifically should be preferred over bupropion, and that is a class 2A indication. Now, the dose varenicline is available. Online it is available. The dose is very important. Whenever we start varenicline, we start 1 week before smoking cessation. And the dose has to be 0.5 milligram twice daily for 1 week for 3 days, and then 0.5 milligram once daily for 3 days. Then from day 4 to day 7, it should be 0.5 milligram one tablet twice daily, and from day 7 till 24 weeks, it should be 1 milligram twice daily, and it should be continued till 12 weeks after the smoking cessation, at least 12 weeks after the smoking cessation. Varenicline is a very good drug, and that is a class 2A indication, preference over bupropion, and all these three are class 1 indication. We all know cocaine, opioid, marijuana avoided, should be avoided. Limit alcohol drinks, less than 1 drinks per day in female, less than 2 in male. This is also very important, especially very important after patient with acute coronary syndrome or patient who underwent myocardial revascularization. All these patients should be counseled regarding their sexual health, and it has been said that if a patient after ACS or after stenting achieves a metabolite of 5.8 meds, then he is fit for sexual activity. So the lipid management in patients with chronic coronary disease, patients who are not at very high risk, high intensity statin goal to reduce LDL more than 50% is class 1 indication. If it's not tolerated, then and LDL is still more than 70, ezetimibe may be reasonable. It is class 2B condition in patients not at very high risk. Patients who are at very high risk of having any MACE, they should be given high intensity that remains class 1. But ezetimibe here becomes class 2A indication if LDL still remains more than 70, and if even after ezetimibe supplementation LDL remains more than 70, then PCSK9 inhibitor should be used, and that is a class 2A indication here. BP management class, we know that if the BP is 120 to 129, diastolic is less than 80, weight loss, DAS diets, reduce your salt intake, physical activity, reduce or minimize your alcohol intake. If it is more than 130 by 80, ACE inhibitor or beta blocker, if compelling indications are present. We will go through the slides regarding beta blockers and all these drugs. Add CCB, thiazide or MRA if not at goal. SGLT2 and GLP-1. Now this is very important in any type 2 diabetes patients with chronic coronary disease. GLP-1 receptor agonist and SGLT2 inhibitor are class 1 indication. If heart failure is present even without diabetes, less than 40% SGLT2 is class 1, more than 40% is class 2A indication. Weight management is very important. You have to keep your obesity under control. If pharmacological therapy is indicated, then GLP-1 receptor agonist can be beneficial, and for this indication, semaglutide is preferred over liraglutide, and that is a class 2A indication. In general, obesity in which weight loss goal have not been met, referral for consideration of bariatric surgery is also class 2A indication, and avoid sympathomimetics. So cardiac rehabilitation program should be there. We should avoid exposure. Now this is a DAPT without anticoagulant. DAPT should be continued after PCI for 6 months, that is class 1 indication. And after 1 to 3 months, we can change it to single antiplatelet, that is a class 2A indication. So we can skip this in view of time. So this is the duration of this thing, antiplatelet therapy. Then the recommendation for beta blocker. The LVEF is 40%, it is class 1 with or without MI. If LVEF is less than 50%, it still remains class 1. But if EF is not less than 50%, patient is not having angina or arrhythmia or uncontrolled hypertension, then it is class 2B indication. If no previous MI or LVEF less than 50%, then it becomes that is a class 3 indication. Again, ACE inhibitor, ARB is a class 1 indication, especially in a patient with EF less than 40%. Colchicine has a class 2B indication. This is one new development in patients. For secondary prevention, it is a class 2B indication.
You have 1 minute left.
Immunization, we know it's a class 1 for influenza, class 2A for pneumococcal vaccine. Medical therapy, beta blocker, CCB or long-acting nitrates for angina relief. If no symptomatic relief, other drugs should be added. Ranolazine is recommended who remain symptomatic, class 1 indication. Sublingual nitrate for immediate relief is also a class 1 indication. Now, this again is one new thing. Adding ivabradine to a standard anti-anginal therapy is potentially harmful, and that has become a class 3 indication because there is a trial with 19,000 patients. It has increased incidence of MI. So this was a new thing, so we can skip the guideline thing. And revascularization, CABG should be, is indicated if there is a left main involvement with high complexity CAD, that is a class 1. And diabetes mellitus, again with a proximal LAD, bypass should be done, that is a class 1 indication. Multivessel disease with syntax score more than 33, it is a class 2A indication. PCI, if poor surgical candidate, diabetes with left main stenosis, and low to intermediate complexity CAD, that is defined by a syntax score less than 33, that is a PCI is class 2B indication. So I can skip this thing. So we can go to this is a
just
closed
conclude
topic. Just 10 points, which is a top 10 message. Emphasis is on team-based, patient-centered care that considers social determinants of health, cost, and shared decision-making. Non-pharmacological therapy is very important. Patients who are free from contraindication are encouraged to participate in physical activity, cardiac rehabilitation for eligible patients. SGLT2 inhibitor and GLP-1 receptor has got a new indications. New recommendation for beta blocker use in patients with chronic coronary disease at more than 50% EF. It's not required if patient is asymptomatic. Statin remains the first choice for lipid therapy. Shorter duration of dual antiplatelet therapies are safe and effective in many circumstances, particularly when the risk of bleeding is high and the ischemic risk is low to moderate. The use of non-prescription or dietary supplement is till now not indicated. Some studies have shown benefit of vitamin D supplementation. Routine periodic anatomic or ischemic testing is not recommended if patient is asymptomatic, although e-cigarettes increase in the likelihood of successful cessation compared with nicotine replacement therapy. Because of lack of long-term safety data, it's not indicated. With this note, I would like to thank you all.
Thank you, Ashish, for your excellent talk and overview of CCFA. May I request you to please stay back?
And to felicitate our speakers, I would request our chairperson, Dr. Mani Shankar, sir, I request you to come up on stage. Our chairperson are presenting the shawl to our speakers, a beautiful moment for all of us. And our next session is CVD and comorbidities. And our chairperson are Dr. Om Kumar, Dr. Shekhar Kumar, Dr. Pankaj Hans, Dr. Preet Pal Singh, Dr. Shoibal Gupta Guha, Dr. Shubhas Kumar, Dr. Arvind Kumar, Dr. Ranjit Kumar Singh, Dr. Om Kumar, sir, please join us. Dr. Shekhar Kumar, Dr. Pankaj Hans, Dr. Preet Pal Singh, Dr. Saibal Guha, Dr. Subhash Kumar, Dr. Arvind Kumar, and Dr. Ranjit Kumar Singh. And our first speaker is Dr. Harshvardhan, sir. I request Dr. Gyan Prakash, sir, please join us.
So we will start this session, and the first speaker is Dr. Harshvardhan. He doesn't require any introduction, and currently he is a senior nephrologist at prestigious PMCH Patna. He has been trained at SGPGI Lucknow, and he has been pioneer in starting kidney transplantation at IGIMS and then in big hospital, Apollo Hospital Patna. So I will request him to deliberate on a very important topic of AKI associated with decompensated heart failure. And I know that he will discuss the most important thing about the crosstalk between heart and kidney, and especially whether the various drugs like ACE inhibitor, ARBs or ARNI or SGLT2 or MRA, they should be continued or discontinued whenever AKI episodes occur in the setting of acute heart failure. So over to Dr. Harshvardhan.
Very good morning to you all, and at the outset I would like to thank the organizer for giving me this opportunity to present this important topic in front of you, and thank you, Chair, for that warm introduction. So in 10 minutes or so I'll be discussing acute kidney injury and acute decompensated heart failure. Well, the common setting is that acute decompensated heart failure with rise in creatinine, AKI which occurs with heart failure, and there are systemic illness which causes both AKI and heart failure, like many sepsis and other conditions. Let's begin with a typical case which we are normally encountered almost daily. That is a 52-year-old man admitted with AHF with ejection fraction of 20% and worsening edema, SOB orthopnea, with blood pressure 136 by 80, bilateral rails at lung base, creatinine increased from 1.2 to 1.8, and he's on ramipril 5 milligram per day. So two clinical questions are whether to hold diuretics or hold ramipril. So outline of my talk would be epidemiology of AKI in heart failure, pathophysiology of AKI in heart failure, AKI versus worsening renal function, and outline of treatment. If we look at the renal dysfunction, which is pretty common in heart failure, with almost more than 50% having low EGFR, and more so in decompensated heart failure. And it is dangerous too. We clearly know that renal dysfunction and mortality have a linear correlation, and impaired renal function is a stronger predictor of mortality than LVEF and NYHA class in advanced chronic heart failure. We have multiple meta-analysis, and we all know that if you have heart failure and renal dysfunction, the outcome is poor. If we look at the mechanism of acute kidney injury in heart failure, it is basically multifactorial. It is most commonly hemodynamically mediated, exogenous factors, contrast, and other mechanisms as well. Let's see the traditional paradigm, which is what causes acute kidney injury in heart failure. The traditional paradigm is that you have a decreased cardiac output, you have decreased renal perfusion, and you have renal failure. This is the classical paradigm. But then a lot of questions has been asked about this paradigm. This was a paper which showed that irrespective of the cardiac index, almost EGFR remained stable. And there was no correlation between cardiac index and change in EGFR during hospitalization with acute decompensated heart failure. So absolutely there is no linear correlation. So there is something else which is happening. So venous congestion. So now venous congestion is the very important factor for worsening renal function in heart failure patients. And it all started way back in 1988 when this paper in Lancet which showed that as congestion increases, there is a fall in GFR. So probably it is the central driving force. Then comes the famous Bousma renal tamponade hypothesis. That is, there is something which is called congestive nephropathy, which is happening. So it is both at the intracapsular level, perirenal level, and intra-abdominal pressure. All these contributes to rise in pressures and a choking kidney. So we all know AKI is bad, and renal congestion is more important than forward flow for renal function decline in ADHF. Two concepts which I would like to introduce here is acute kidney injury and worsening renal function. So any rise in creatinine in setting of heart failure is your worsening renal function. But is it true AKI, that is true worsening renal function, or is it pseudo AKI or pseudo worsening kidney function? Well, pseudo kidney function is something which is happening because of diuretics, because of the drugs which we are given. So it is something which is called permissive hypercreatininemia, which is there. And it is differentiated from acute kidney injuries, which is really bad. Though it is very difficult, but these are two important things which we must know, and the talk is all about that. So for cardiologists, we know you have a marker in change in function, which is left ventricular ejection fraction. Then you have an injury marker, which is troponin. But we nephrologists still are looking for that ideal injury markers. Change in function marker is the creatinine. But ideal injury markers, the search is still on. And in the setting of heart failure, the search is still very difficult because all the novel urinary biomarkers have a poor they are poor predictors of AKI in acute heart failure setting. Two molecules which has been tried is TIM2 and IGF-BP7 and KIM1. till now, KIM1 is the biomarker for early detection of AKI in the setting of acute heart failure. Then there is something which is called dilution effect. Once you start giving diuretics, your ECF, is basically getting reduced. So there is rise in creatinine. So basically there is a formula to calculate that, but this is a setting which normally, because of the dilution effect, when you give diuretics, there is a rise in serum creatinine, which happens. So conclusion is that if you have induced AKI, outcomes is better. When you have spontaneous AKI with all the comorbidities, it is bad. So the clinical context why we are discussing is that because of the fear of AKI, we are not treating congestion aggressively. You have a sinking heart, but we are afraid that this might lead to rise in creatinine, hence we are not diuresing. And interestingly, if you see, most of the acute heart failure syndrome, you have more elevated systolic blood pressure. So less of the people with heart failure, they present in cardiogenic shock. Most of them are congested with raised pressures. And lot of literature, this EDA registry trial was also there, which suggested that decongestion is not adequate in ADHF. And congestion at discharge is frequent and recurs and associated with worst outcome. So what are the barriers of acute decongestion? Poor renal function, can't give more diuretics, stop diuretics as creatinine has bumped, and diuretics are nephrotoxic. If you look at this typical figure, which we read in our medical school, if you see, it is here where diuretics are nephrotoxic, that when you are hypovolumic, this is the optimal place of diuresis. So you can keep on diuresing, because if somebody is volume overload, the chances of AKI is less in setting of diuretics. And interestingly, worsening renal function is associated with improved survival in ADHF if it occurs in the setting of hemoconcentration. That is when you are giving diuresis and there is a rise in hemoconcentration. And even post-hoc analysis suggests that this goes beyond 6 months. So benefit is even beyond 6 months. So WRF, that is worsening renal function, is not a bad prognostic sign if accompanied by a hemoconcentration. RAS blockade in setting of ADHF with renal dysfunction. This was a post-hoc analysis of SOLVE-D, which suggested that ACE inhibitor is associated worsening renal function is not deleterious. So ideally, it should be continued. And even early worsening renal function in aldactone arm in Rails trial was also not associated with harm. And even this paper looked at the discontinuation. So compared with continuation, withdrawal of ACE or ARB during heart failure hospitalization is associated with higher rates of post-discharge mortality and readmissions, even after adjustment of severity of illness. So that should not be discontinued. So rise in creatinine with RAS inhibition is not deleterious in the setting of isolated acute heart failure. So this is a guideline which helps to guide physicians how to go about, that is change in renal function associated with drug treatment in heart failure guideline, what to do, when there is a fall in GFR, what to do when you are hyperkalemia. Because of paucity of time, I'm not discussing this chart, but it's all there on the net. If you look at the diuretic strategies in acute decompensated heart failure, this was the unload dose trial, which was classically suggested that there was no significant difference in patient with global assessment of symptoms or in change in renal function when diuretic therapy was administered by bolus as compared with continuous infusion or at a high dose as compared with a low dose. So post-hoc analysis of 198 patients pooled from 3 trials, that is dose HF, Caris HF, Rose HF, compared a urine volume goal-directed stepwise diuretic algorithm and standard diuretic therapy. So there is an algorithm which helps the clinician to guide about the preferred diuretic dosage protocol. Then the role of ultrafiltration, as we all know, when you have a diuretic resistance, when you have refractory edema, when the lungs are, getting wet, when you have hyperkalemia, there is a role of ultrafiltration. There are a lot of trials which are there, SAFE, Rapid UHF, Euphoria, Unload, Caris HF, Avoid HF. And the benefit of ultrafiltration is that there is a predictable removal of sodium and fluids, restoration of diuretic responsiveness, no change in electrolyte, particularly potassium and magnesium, and more effective decongestion or fewer heart failure events compared to loop diuretics. There is improved GFR and efficacy and outcome. So if you look at the drug therapies which have been tried to improve renal failure and heart, there are a lot of drugs which have been used, rolophylline, nesiritide, then ultrafiltration, all these have been used in heart failure. But still now the data is not as robust, so to give them a class 1A indication, and still we require large long-term data and a larger population of patients. So drug effective, bottom line is, among all drug, SGLT2 is beneficial in patients with improving renal outcome in heart failure. Now what happens long term? We all know AKI is bad. So if in the setting of acute heart failure, you have acute kidney injury, what is the long-term effect on kidneys? So you have a scoring system. You can see you have a scoring system, and more the score, there is more likelihood of development of chronic kidney disease long-term. So we have to be cautious. We have to be very, particular about the clinical context in which we are dealing. Somebody who's having AKI with multiple factors like sepsis, like drugs, like hypotension, you have to be cautious in managing those patients. So a suggested protocol is that if you have ADF, ADHF and congestion, if you have a stable or improved renal function, go ahead with your therapy, give high dose diuretics, add metolazone to block distal convoluted tubule for diuretic resistance. If you have a worsening renal function, which is there in around 20 to 40% of the patients, if there is some worsening in eGFR but decongested decline, deal with it. But if renal function keep on worsening and you are getting other indications of dialysis, proceed for dialysis. Thank you.
So few comments and questions from the floor. Yeah.
Thank you, Dr. Harshvardhan. It was a very insightful presentation. But one question, because our cardiology guidelines, especially on acute heart failure, and as you said that it is very necessary to continue ACE inhibitors or ARBs along with MRAs. So American literature, the recent one, says that even when potassium goes up to more than 5.5 millimoles per liter, instead of stopping MRA, because it is helpful in improving the long-term prognosis, instead we should have some newly introduced potassium binders. So in India, are they available other than the sachets what we use, the K-bind? Are there some new molecules available which can be used in this context?
So your question is oral potassium binders?
Yeah.
No, it is not yet available in India.
Thanks.
Internationally it is available and it is being used.
Yeah.
Patiromer, and they are available in US but not available in the country.
In the name of low kelma, it is available.
Yeah, because we don't find them here. So
That
that's
is not
why-
available in our country.
So thank you, Dr. Harsh, for bringing very important points of differentiating of ACE inhibitor in this setting. Thank you, Dr. Harsh.
Our next
So, thank you, respected chairperson, for kind introduction, and good morning, everyone. So, my topic is, first I would like to thank organizers, especially Dr. Anoop, Dr. Arvind sir, and whole organizing committee for considering me as a speaker. And my topic is chemotherapy and cardiac side effects. So, I would like to say in the beginning that it is less studied. We don't know much about chemotherapy and cardiac side effects, because in most of the cardiac trials, the patients who have received chemotherapy were excluded. So we exactly don't know how to treat patients who develop cardiac side effects with chemotherapy. So I would like to start with a case, real case, 30 years old male. He was diagnosed as acute myeloid leukemia in 2015. And he received 3+7 induction chemotherapy, that is 7 days of cytarabine and 3 days of donomycin, that is anthracycline. And after 1 month, we assessed for remission. He was not in remission, so same induction was, as per protocol, it was repeated. That is again 3+7 induction chemotherapy. And this time he went into remission. After that, he received 3 cycles of consolidation with cytarabine, and he was in remission for 8 months, but unfortunately he relapsed. Sorry. So he was again evaluated, and he was found to have normal cardiac function with LVEF of 60% with no structural disease. And this time he received HAM induction chemotherapy, that is high dose cytarabine and mitoxantrone. Mitoxantrone is again an anthracycline. So this time he went into remission, and as per protocol, all relapsed AML should be transplanted. So he had match with a younger sister. So allogenic stem cell transplant was planned, but during pre-BMT checkup, his ejection fraction was low, it was 40%. With this case in background, I would like to start my presentation. So with improvement of early diagnosis and better therapy in cancer, many patients, they are surviving, they are getting long life. So they are having all sorts of long-term side effects as well as acute side effects of chemotherapy that they receive. So these are all terms which is important. What is chemotherapy, immunotherapy, cellular therapy, targeted and small molecule inhibitors. Then these are the gross classification of chemotherapy or groups that we use, like alkylating agents, antimetabolites, plant alkaloids, anthracyclines, topoisomerase inhibitors, and many more are there. These chemotherapy are important for cardiovascular manifestations like anthracyclines, 5-fluorouracils, taxanes, cyclophosphamide in high doses, they can lead to cardiomyopathy, trastuzumab, tamoxifen, bevacizumab, and COX-2 specific inhibitors. How chemotherapy, they lead to chemotherapy-induced cardiotoxicity. So these are proposed mechanism like direct cellular toxicity, effect on coagulation system, arrhythmogenic effects, hypertensive effects, and myocardial and or pericardial inflammation. So they lead to reduced myocardial repair, and there is more myocardial damage leading to cardiac damage. And there are 2 types of chemotherapy which can lead to cardiotoxicity, like type 1, like anthracycline-like, they lead to cell death, they are cumulative, and they lead to permanent heart damage. Type 2 are trastuzumab-like, like they lead to cell dysfunction, they are not cumulative, and they are reversible. And depending upon agents, like there are some agents like anthracyclines, they affect cardiomyocytes, alkylating agents, they affect cardiomyocytes. Then coronary arteries, fluoropyrimidines and platinum compounds, they affect the coronary arteries. And there are some agents like anthracyclines, taxanes, platinum, gemcitabine, they lead to cardiac conduction abnormality. So settings can be, it can be acute. When you use chemotherapy, you develop some, you are having patients with cardiac dysfunction, and there can be long-term sequelae where patient has received chemotherapy and after 10 years developing cardiomyopathy or some problem. So as I have said, the guidelines, they are not there because they have not included patients who have received chemotherapy in their trial, so we don't know exactly how to address them. So we need better tool as per as coordination with a cardiologist. So the field of cardio-oncology is growing nowadays. So how to diagnose? So these are usual modalities. We start with ECG, 2D echo, and radionuclide ventriculography is gold standard, but it has limitations. PET CT, cardiac MRI, I don't know much. We have separate talk on these modalities. Biological measurements like troponin, genomics, proteomics, B-cell repertoire are there. But the major challenge is to diagnose them early or subclinical cardiac dysfunction. So in all the cancer guidelines like NCCN guidelines, they suggest that one should have cardiac evaluation. Like NCCN guideline is international guideline for cancer treatment. You can see there is cardiac evaluation is required before starting chemotherapy. Now coming to principles of treatment, so how to prevent. So for anthracycline-induced cardiac damage, there are some drug like dexrazoxane is there which we can use to prevent cardiac damage, but it is still in trials, not for common use. I personally don't use dexrazoxane to prevent cardiac damage. And there are some agents like they can target the key pathogenic mechanism like RAS pathway, ACE inhibitor, ARB. They are also not well studied in preventing cardiac damage. These are all trials, I will not go into detail, but the crux is that they are not clear that whether adding ACE inhibitor or ARB prevents or dexrazoxane prevents cardiac damage or not. Now coming to treatment, so there can be anthracycline related damage. So one clinical scenario can be where patient is asymptomatic and they are receiving anthracycline and there is drop of ejection fraction. So there we can stop the chemotherapy, and once they recovers we can consider restarting, or if there is further reduction of ejection fraction, we can stop the chemotherapy forever. Here we can use ACE inhibitor, and if it is contraindicated, ARB is an option. There is no role of cardioprotective agent based on only biomarkers, because patients who receive chemotherapy, they can have falsely high biomarkers. Then clinical setting 2, where symptomatic patients with a significant baseline reduction. So if ejection fraction has dropped to 40 to 50%, we can take cardio consultation. We can decide depending upon whether how aggressive is the cancer and how important is to continue chemotherapy. If ejection fraction drops to less than 40%, we have to stop it, and heart failure treatment should be started. Then another agent which is mostly used in breast cancer, fluoropyrimidine induced cardiotoxicity. They mostly target vascular coronary artery toxicity. So around 1 to 18% of cases can develop coronary artery toxicity, and here we can use vascular dilators like nitrates, calcium channel blockers, and ranolazine. Cardiac arrhythmia, about 1/3 of patients can develop. QT prolongation is common. Torsions de pointis is also important. Whenever we as an oncologist, we see that QTC prolongs to more than 500, we stop the drug and we evaluate. Then there are some non-chemotherapy agents like trastuzumab. Here some studies are there, manticore studies there, where using ACE inhibitor or ARB can benefit. Then immune-related cardiovascular effects, they are rare. They can lead to all sorts of cardiac damage like myocarditis, cardiomyopathy, and treatment is use of immunosuppressants. TKI, we use imatinib, dasatinib for CML patients. They have cardiac potential, cardiac toxicity. BTK inhibitor like ibrutinib or acalabrutinib we use for CLL. They can lead to atrial fibrillation in about 11% of cases, where we have to stop ibrutinib due to these side effects. So whenever we have cardiovascular risk factors, we start with biomarkers of susceptibility. We try to prevent them. If there is early damage, we start early intervention like risk factor control, ACE inhibitor. If there is LVEF reduction, then we may have to stop the cancer drug and we have to start the heart failure treatment. These are all ongoing clinical trials. These are all modalities. We have to use primary prevention, secondary prevention, tertiary prevention, and quaternary prevention. So what happened to our case? We took cardiology opinion, and the ACE inhibitor was added, and he was cleared for a stem cell transplant under moderate risk. And he received fludarabine melphalan conditioning, which is non-cardiotoxic. He underwent HSCT. He is cured of AML. Last follow-up was 6 months back. He is married recently, and his also ejection fraction improved to almost normal range. So to conclude, with rapid introduction of newer agents, all sorts of chemotherapy, immunotherapy, cellular therapy, more and more cancer patients are getting cured. They are surviving for long, so they are developing all sorts of complications, end organ damage, cardiotoxicity. Cardiac side effects are a significant problem encountered in clinical practice, but it is rarely represented in large clinical trials of cardiology, so we don't know how to address them. We need strategies to prevent, to detect early, and treat cardiac problems to provide patients long-term quality life. Thank you.
Thank you, Dr. Avinash, for a wonderful talk and describing in very simple language the cardiac complications of chemotherapy, the interactions between the drugs used in chemotherapy and the drugs used in cardiology, and the precautions needed to be taken before initiating cardiology. I would like to take this opportunity to thank the organizers for putting in such an important but less talked about topic. And this will increase the noise level about cardiac precautions before starting chemotherapy. And now the topic is open to the House for any discussions, comments, and queries. For those who don't know, Dr. Avinash is a brilliant hematologist, and we are lucky to have him in our state to serve our patients. I think there are no more queries, so we can...
Thank you, sir.
Thank you again. Okay. The next talk is how to deal double whammy MI with stroke. And we have none other than Dr. Sanjay Kumar to talk on this. Dr. Sanjay. In this array of brilliant speakers, Dr. Sanjay is another budding another prolific neurologist in the city. So the dais is yours, Dr. Sanjay.
Should I start? Respected Chairperson, sir, my teachers, friends, and my students. I really are very thankful to all these to all my organizers to giving such a topic where we have, if you are going to search any literature on this very particular topic, you will not find one or two or three, more than one things about this very particular topic, which is dealing with both the MI and stroke together. What's the problem? नहीं आ रहा है वहाँ तो आ रहा है नहीं पेन ड्राइव कौन घुसाएगा दूसरा नया पेन ड्राइव इस पर नहीं घुसाएंगे मेरा ठीक है फिर भी
हाँ till the time this technical snag is solved, I would like to request the next speaker, the renowned diabetologist of the state, Dr. Ajay Kumar sir, to take the dais. Ajay sir is famous both as the international, on the international podium as well as a prolific speaker and an excellent diabetologist. He will be talking on critical analysis of cardiovascular outcome trials in type 2 diabetes. Over to you, Ajay sir.
Honorable chairpersons, dear colleagues, my greatest pleasure coming this morning is that sitting there, I have been asking the person sitting next to me that who is he, and who is he, and who is she? Because if we don't have meetings like this, we, the older generation of physicians, fail to identify the young budding cardiologists, nephrologists, and such intelligent people who are bringing laurels to our state. So thank you, Arvind, for having me here. And because time is very short, I will straight away move to my topic. And when we talk about the journey of anti-diabetic drugs, it started with the discovery of insulin more than 100 years ago. And for the next 5 to 6 decades, it was a very slow journey. We had only two other molecules, metformin and sulfonylurea. And then suddenly, after mid-80s and 90s, we had a spurt of discoveries of anti-diabetic drugs. And by the year 2010, we had so many drugs that we started feeling very privileged
that we are at the threshold of providing the optimum diabetes care. But unfortunately, that doesn't happen. In spite of so many drugs, such wonderful insulins, we are still not able to get more than 25% of our patients of type 2 diabetes to the target, and the consequences go into the hands of the cardiologist and the nephrologist. So with that background, I start my topic, and I don't need to tell this audience the association between diabetes and cardiovascular disorder. And because of this strong association, and for another reason that I will talk very shortly, it is mandated that we need to understand the risks associated with any anti-diabetic drugs towards the cardiological and renal complications. So what happened over that period of time, the entire glucocentric approach of management of type 2 diabetes changed. Previously, we were only focusing on controlling the blood sugar. And then suddenly we realized that's not enough. We need to control the blood sugar and avoiding hypoglycemia and avoiding weight gain. And then finally, we moved on to a situation where we started talking about preventing complications and particularly giving benefits in terms of cardiovascular outcome and renal outcomes. And this is the strong association of cardiovascular disease and diabetes. These statistics are extremely very well known to you, but more important, rosiglitazone came into the late 90s in our armamentarium, and then Steve Nishan in 2006 or 7 wrote a meta-analysis castigating rosiglitazone as one anti-diabetic drug which increases the risk of myocardial infarction. And that led to all the regulatory agencies across the world like the FDA and the EMA and everyone that for any new drug discovery in diabetes, it will be mandated that you have to demonstrate cardiovascular safety. And that opened the Pandora's box. And when I say you have to look for the cardiovascular safety, what exactly we are talking about is the 3-point MACE, which means cardiovascular death, non-fatal myocardial infarction, and non-fatal stroke. But because of the pathogenesis, we also know that irrespective of atherosclerotic cardiovascular disease, diabetes can directly lead to diabetic cardiomyopathy, and heart failure is also an important outcome which has to be taken into consideration. And at the same time, we quickly realized that these cardiovascular outcome trials will also give us an opportunity to understand that what exactly is happening with the renal outcomes. So we got the double benefit of doing these cardiovascular outcome trials. We knew about the cardiovascular safety, which eventually translated into cardiovascular benefit with SGLT2 inhibitors, of course. And then that also gave us huge insight into the renal outcomes associated with anti-diabetic drugs. So there are so many drugs, but I shall be focusing on 7 or 8 drugs which we use right, left, and center in our clinical practice on a day-to-day basis. Now I'll start with the most innocuous of them, which is DPP-4 inhibitors, which has now taken the center stage in the management of type 2 diabetes. And to start with the 3 topmost anti-diabetic DPP-4 inhibitors, the sitagliptin, the saxagliptin, vildagliptin, and so many of them came in the market. And just in one line, I can conclude that DPP-4 inhibitors were neutral to the cardiovascular system. No benefit, no harm. You can use them with impunity without worrying about the use of DPP-4 inhibitors. Then what happened, a new DPP-4 inhibitor came, linagliptin, and the makers of linagliptin thought that our DPP-4 inhibitor is the best. And therefore, they took up 2 challenges. First challenge was that they did the usual cardiovascular safety trial called Carmelina trial. Unfortunately for them, fortunately also that it showed cardiovascular safety like sitagliptin or whatever. But then they ventured to compare it with sulfonylurea glimepiride. They thought that we will establish superiority of linagliptin over glimepiride, but unfortunately that did not happen. Linagliptin was as safe as glimepiride, and glimepiride, as you know, the entire world was talking that sulfonylurea should not be used because they will increase the cardiovascular outcome. They also lead to hypoglycemia and weight gain, and therefore they should be completely replaced by DPP-4 inhibitor. But this trial put a death knell to this hypothesis that glimepiride, or for that matter gliclazide, should not be used in our therapeutic armamentarium. And then moving on, from DPP-4 inhibitors, we moved on to GLP-1 analogs. And GLP-1 analogs are the very robust molecule, as you know. They have beyond, their anti-diabetic effect, a lot of pleiotropic benefits. And you can see here that we have started getting the positive outcomes. Liraglutide and semaglutide provided positive cardiovascular outcome, not only neutral, they started showing cardiovascular benefit. The first one, exenatide, whether given daily or weekly, as you can see on the two extreme, did not provide any benefit, but liraglutide and semaglutide did. And this is the leader trial result. The first trial, we showed 13% 3-point MACE reduction, and that was followed by 26% reduction by semaglutide, which was largely driven by stroke, not by myocardial infarction. And that was followed by albiglutide. Unfortunately, Glaxo, which was the maker of albiglutide, did not proceed with the marketing of this drug. And then again, huge benefit with dulaglutide, again showed superiority. So all the GLP-1 analogs, which were human GLP-1 analogs, they all showed benefit. The one prepared from the exendin base like exenatide or lixisenatide, they did not show superiority. So that is the outcome with the GLP-1 receptor agonist. And then last year, we suddenly have a revolutionary drug. For the first time, injectable GLP-1 could be reproduced for oral GLP-1, oral semaglutide. And what did that show? The Pioneer 6 study, which was the CV safety study for oral semaglutide, that demonstrated non-inferiority. So safe, but that did not show superiority. Why? Because it was not designed to show superiority. It was a safety trial, a small number of patients, a small duration of a study, and therefore it did not show superiority. But if you analyze this study, the cardiovascular death and the total mortality had a huge reduction. Look at 51% reduction in cardiovascular death and 49% reduction in all-cause mortality, which clearly tells you that the SOUL study, which is a dedicated cardiovascular study for this particular drug, is definitely going to show huge result. And only 2 days ago, I was in Denmark, where we got the result of the SELECT study, 2.4 milligram of semaglutide, huge cardiovascular superiority. So semaglutide is going to be the future of treatment of type 2 diabetes because of its robust pleiotropic benefits and cardiovascular benefits as well. SGLT2 inhibitors were the first class of drugs, empagliflozin, which established that an anti-diabetic drug can be cardiovascular superior, not only neutral but can be superior. And we all know the wonderful result of the EMPA-REG study with empagliflozin and canagliflozin study. And what about dapagliflozin? Dapagliflozin did not show superiority in terms of 3-point MACE reduction. But why? You have to look the inclusion criteria. Dapagliflozin did not have 99% patients with established myocardial infarction or established vascular disorder. They had 60% of the patients, which are like garden variety of patients of type 2 diabetes. They are not very high risk patient. And therefore, it did not reach this superiority in terms of 3-point MACE reduction, but it did reach statistical significance with a huge margin for reduction of heart failure hospitalization and death. And therefore, all three SGLT2 inhibitors became established superior drugs in terms of cardiovascular and renal risk reduction. This is the data that I was talking about, heart failure hospitalization with multiple risk factors and established cardiovascular disease. Then coming to the oldest drug, sulfonylurea. Should we use in our clinical practice? I showed you the data with glimepiride versus linagliptin, and this is a huge meta-analysis showing that we have been extremely unfair to sulfonylurea. Look at the data. Even the glipizide was neutral and glimepiride. And look at gliclazide. Gliclazide stands out as the best sulfonylurea which you can use. Look at the risk reduction here. And gliclazide is a wonderful drug which you can use with impunity without thinking about any adverse cardiovascular outcome. And pioglitazone. Once again, pioglitazone is another drug which is extremely safe in terms of cardiovascular outcome. In fact, it gives you positive outcome in terms of stroke risk reduction. And therefore, you can compare sulfonylurea and pioglitazone, and both are equally good, equally safe. All that you need to do is the contraindication of a particular drug, and then you will never do any harm to your patient. Metformin, of course, is quite established that it does not lead to any adverse cardiovascular outcome, but it does not have any dedicated cardiovascular outcome trial, and therefore you cannot say that it is truly a beneficial drug, because whatever we recommend is based upon a subgroup analysis of 239 patients from the UK PDS study, that's all, and nobody is now going to do a dedicated cardiovascular outcome trial with metformin. So I would like to conclude my talk by telling you that the recent guidelines, the ADA guideline, and all the other, even the European Society of Cardiology guideline now tell you that in type 2 diabetes management, if you have established cardiovascular disease or established renal disease, irrespective of the use of metformin, you can start treatment with GLP-1 receptor agonist and SGLT2 inhibitor, because that will give us a lot of benefit, not only in reducing the cardiovascular risk and renal risk reduction, but also weight loss and multiple other pleiotropic benefits. And therefore, drugs like SGLT2 inhibitors, oral semaglutide, injectable semaglutide are the future of treatment of type 2 diabetes. Having said that, this is the entire list of drugs that I talked about. Each one of them addressed a specific pathogenetic mechanisms of type 2 diabetes. The widest canvas is for the GLP-1 receptor agonist. As you can see in the red, it has got, in the blue, which has got the biggest coverage, targeting 7 out of 8 pathogenetic mechanisms of type 2 diabetes. But for a clinician, what is important that you should not worry, and particularly the cardiologist, about the risk. But if there is established cardiovascular disease, established renal disease, you must opt for GLP-1 receptor agonist or SGLT2 inhibitor. Thank you very much.
Thank you, sir. Thank you, Dr. Ajay Kumar, sir, for a wonderful and concise presentation on cardiovascular risk factors related with diabetes treatment. So, session is open for the question. Any question, please? I think we have a very wonderful presentation, so we don't have any question to ask. So we are moving on. We have next session. Our speaker is renowned neurologist, Dr. Sanjay Kumar. We welcome him for the presentation. Thank you.
Thank you again. So this is why my topic is a problematic topic. Whenever there is the time of presentation, there's a problem because the things are brain and heart doesn't move together. When they start moving together, the problem starts. But here my topic is when both are jeopardized simultaneously, what to do. So if you will see, what's the problem? The problem is the same pathophysiology is occurring for both brain and the myocardium. There is a obstruction in arterial blood flow, a critical decrease in the blood supply causing ischemia and necrosis of the brain tissues and the myocardium. And the answer is one, that there is restoration of anterograde blood flow, that is reperfusion therapy, and that is the panacea for both of them. But what's the problem? The problem is that should be within a time frame. If the time is lost, time is brain, time is heart. So this the time is lost, then the problem, even if whatever therapy you are giving, you are not getting benefit out of it. But what's the problem? The problem, if you see the management of MI, we have got plethora of things on the internet and in the practical point of view. If you see acute ischemic stroke as a treatment point, you will again see there is so many recommendation, evidence-based recommendation there. But if you combine together simultaneously, you will find you are not get a single study till date on the world's medical field. So this is the problem. Why this is? Because you cannot prefer one over other. If you say theoretically that I'm going to treat the MI and then we'll look for the acute ischemic stroke, I have said that time is brain, time is heart. You are going to lose one for other. So what is the study. So I sought it from a very in a prominent way, and I found only one study, that was Grace's study. That was a acute coronary syndrome registry that was formed by Jonathan Kitt and Mr. Goyer. And that was a 10-year study, 1999 to 2009, where the incidence in acute coronary setting, the chances of acute ischemic stroke was 0.9%, and mostly with the STEMI as compared to the non-STEMIs. And a 3-year prospective study for the geriatric patient group, the prevalence of, that was a prospective study, and the prevalence was 12%. So, a new name was given, that was cardiocerebral infarction by Omer et al., and it was given in 2010. And that was given purposefully because we need to address this very dynamic situation when both of the heart and brain is simultaneously affected. What may be the causes? The first, second, and third important cause is a myocardial infarction causing a left ventricular thrombus, then the cardioembolic infarct causing this. There are less common causes like type A, aortic dissection, paradoxical embolism, especially the patent foramen oval, hematological disorder, antiphospholipid syndrome, and vasculitis. These are the important possibilities which can lead to the cardiocerebral infarction. So, we have certain things in common and we have dissimilarities. Why we are in a problem with managing both these situations simultaneously or together? Because we have got certain common thing in between us, but we have a great amount of dissimilarities also. So there is a problem in management both simultaneously. So we have seen this. What are the similarities? The pathophysiology, 90% of the cases there is arterial occlusion, ischemic necrosis. And this is nearly true in nearly 50% of the cases of cerebral infarction. Clinical feature, both are acute, prognosis, high mortality, and in the case of a stroke, there is high mortality associated with high morbidity also. Effective treatment, reperfusion therapy. Differences. If you see the etiology of myocardial infarction, this is a plaque which is ruptured and in situ thrombus formation in more than 90% of cases, 95% of the cases. But if you see the acute ischemic stroke, it is multifactorial. It can be cardioembolic, it can be arterioarteric, it can be thrombosis in situ, it can be a lacunar infarct which is lipo due to a lipohyalinosis, and it can be cryptogenic. So we are not sure the next 50% of the patient that is going to, a particular treatment is going to have a proper benefit. Arterial occlusive thrombus visible for catheter based, that 95% chances in MI you will have a proper answer. But this very particular thing is applicable in only 40 to 45% patient of the ischemic infarct. Time window, we can extend it up to 12 hours if you are considering PCI. But it is only 3 hours in the European studies, it's 4.5 hours. And if you are considering a MRSI, a mechanical thrombectomy, it can be extended to 8 hours. So there is a discrepancy in the time frame. Reperfusion therapy is only theoretical, clinically reperfusion is beneficial. But reperfusion damage is a problem in the cerebral infarct. Clinical feature. What's the clinical feature? How the people from since childhood, heart attack is supposed to be the important thing, a cause of death. Even in the movies, in the things, we are very particular. Why? Because it presents with the positive symptoms and a mindset that it is a problem. But when you see a patient is having a difficulty, a focal neurological deficit, one hand is not working, okay, it's a negative symptom. We will see, it will come back. That is a mindset of ours. So, the presentation we see that patient present very early as compared to the patient who is having a focal neurological deficit. Diagnostic method, simple ECG and a clinical symptom is more than sufficient for a diagnosis of MI. But suppose a patient is having monoplasia or hemiparesis, yes, the most common cause is a stroke, but there are other causes like a problem of the even the cervical spine can have the problem. A brachial plexus can have a problem, and the patient when present with the same neurodeficit. So without a CT scan, you are not able to say, yes, this is a stroke. Why? Because the first thing you have to diagnose, and second thing, you have to exclude an intracranial hemorrhage. So time is much in for diagnosing an acute ischemic stroke. Laboratory diagnosis, there is troponin, but not yet available for the acute strokes. Contraindication, catheter-based intervention. For any contradiction, MI, there is usually no, but the mechanical thrombectomy, we have to see there is no ICH, or we have to see there shouldn't be any big ischemic infarct. Established infarct should not be there. If the infarct is already established, there is no benefit of a mechanical thrombectomy. And what is the chances or HMIs? So if you see, you want a PCI in Patna, you have got multiple center of you available for a patient for the MI. If you use, you want a cerebral vessel to be thrombus free, we are very least chances that you will get a center. And if you want both together, you want a cardiologist to be married to a neurologist, then only you can get this combination together to have this treatment simultaneously. And the last point, if you see the cardiac vessels the vessel is occluded, being restored, and if you see the cerebral vessel, the tortuosity in the cerebral vessel is much more. The tortuosity index is 5 times more in the cerebral vessels. So the catheter-based thrombus removal is a difficult thing in the cerebral vascularity due to the tortuosity. So management, there is no clinical trials till date which addresses this dynamic situation. And number 2, there is no evidence-based guidelines for the sequence of management of these two together presenting simultaneously. So what are the management options? Let us see this. The first is acute symptomatic management with secondary prevention for acute ischemic stroke and PCR for MI. What exactly this is being done today. So a patient is coming with both of this. Yes, try to restore the heart and have a symptomatic management. This is what exactly we are doing nowadays because we don't have options. The second option is IV thrombolysis for both arterial territory. The third option is IV thrombolysis for acute ischemic stroke and PCI for MI. And fourth is mechanical thrombectomy for both arterial territory. But the problem is it. If you see the indication of thrombolysis, you will find the relative contraindication list. The first list says that the acute MI within the previous 3 months is considered a relative contraindication for therapy with ultra-leverage or any intravenous tissue plasminogen activator. Why this is? Because this is a theoretical possibility of a fibrinolytic, a thrombolytic agent breaking the myocardial infarction fibrin and causing a myocardial rupture. And the second, during the PCI, the concurrent use of anticoagulant and antiplatelets are going to cause a hemorrhagic conversion of the ischemic infarct if it is thrombolized. So this is the two-way problem. So what is the current scenario? The inclusion of MI as a relative or absolute contraindication of IV RTPA in acute stroke is not evidence-based. If you see the percentage is less than 1% of the patient, we can have a cardiac tamponade or rupture. So why this first was? Because there were certain factors. In 2001 when a study came, there was important factors which was responsible in an IV thrombolized patient where with the myocardial rupture, the factors were age, a big interval MI, more time elapsed on the time of onset and thrombolysis, the female gender, and infarct size, transmural extent, and pericardial involvement. But a 2018 study showed that apart from age, no other factor is significantly associated with increased cardiac rupture in a patient who has been treated with IV thrombolysis. So that was a great news. And after that, my personal single experience with this case. A 44-year-old banker with a past history of binge drinking and heavy smoking since childhood presented to the emergency department the history of sudden onset of focal neurological deficit, and it was started 1 hour previously. Neurological examination was having a focal neurological deficit. There is a scale in neurology which estimates the neuro deficit at the time of presentation, that is known as National Institute of Health Stroke. That was around 11. Thrombolysis is indicated between 5 to 22. The focal list things should not be thrombolized, or major things also should not be thrombolized, because in the first thing that is not required, and in the major thing there is chances of hemorrhage. His general examination was unremarkable. He also complained of intermittent vague ache in the anterior thoracic region. That is true story from Patna. And left shoulder, which had been present for the preceding 48 hours. The patient electrocardiogram was convenient with the inferior IMI and with the 2:1 heart block. The troponin was elevated. Emergent bedside echography showed the presence of inferior wall hypokinesis with good left ventricular systolic function. Computed tomography showed early signs of ischemia in the right middle cerebral artery. We will show. The thrombolysis was done, the NHS scored from 11 to become 4, but approximately 10 hours after thrombolysis, they developed persistent bradycardia, hypotension, and recurring treatment of volume expanders. Echocardiography revealed expansion of the MI to the right ventricle without cardiac tamponade and depression systolic function. Brain CT was repeated after 24 hours and showed the presence of ischemia in the cortical territory of right middle cerebral artery. See this. If you see this, and give me 5 or 10 more seconds. This is the real picture of the ECG. All experts are sitting here. Yes, MI, which is to one block. But see, the first, when thrombolysis was done, if you see, this is the insular ribbon sign. If you see this CT scan, the first A CT scan, you will find the insula. Insula is this very area, particular area. Sorry. क्या मॉस हो जाएगा So if you see this area, this insular area, this is a ribbon put on a baby's head. And if you see this, this is a small, this is early insular ribbon sign of ischemic stroke. That is a very early sign. The thrombolysis was done. Even if the thrombolysis, the stroke is evolving, and the recurrent ventricular fibrillation and arrhythmia causes a hemodynamic instability. You can find that, yes, the thrombolysis was there, but still we are getting new, two new ischemic area in the posterior cerebral artery. These are watershed zone infarct, which is due to hemodynamic instability, not due to the thrombus formation. So, after 6 months, of the discharge, the patient is, as he was a banker, he is working in this SBI branch. You can go and see that, but he is now able to join all his activity. So, the things are, a practical approach of this very particular scenario where the world authority is not very authoritative in saying this is the way to go for the simultaneous management of cardiocerebral infarct. A multidisciplinary team must be there for the proper management of this. And that must include neurologists, neuroradiologists, and cardiologists. Most they have the proper experience of intervention and stroke management. IV thrombolysis should be done in appropriate clinical setting in cases presenting within 3 hours. A mechanical thrombus removal and PCI is simultaneously by 2 different teams. Working simultaneously on the same team promises the best success rate with the fewer complications if the patient is between 3 to 8 hours. If it is presenting more than 8 hours, you don't have to do anything special. You have to manage the acute ischemic stroke symptomatically. The secondary prevention should be started, and you should better manage the myocardial infarction and save the patient. Thank you for your patience.
Thank you, Dr. Sanjay. This was like an extremely challenging case explained so simply. So session is open to
very exciting. Sanjay, I've been listening to you for so many years now. And what I've realized that you have got, a lot of force and potential. Thank you very much. But my only thing is there any dedicated stroke center in the city? I don't know. I am working in Medantara. My neurologist, Deepa, often I hear that she has thrombolized somebody and the neurological recovery was superb. But then, do you have a dedicated center here in Patna?
Till date, sir, the answer is no, but you people are working in Vedanta, are having a very good team of neurology, because the problem is not having a dedicated stroke center. The problem, my particular topic is concerned when the cardiologist and neurologist should marry. Yeah. Because they should be in house 24/7. Then only we have got a proper answer of this.
But I have to tell you one thing.
Yes, sir.
the coronaries and the cerebral both cannot marry. Both are different.
Yes, different people marry, sir. Different people marry,
Physiologically,
sir.
anatomically, and pathologically.
Yes.
They cannot marry. So the behavior of, you cannot extrapolate your results with that of cardiology.
Yes,
And
yes.
cardiologists cannot extrapolate their results with that of brain stroke.
Yes, sir.
So both are different.
Yes.
So there's no point. I tell you one example quickly, just I'll take half a minute. My very close friend, which he is known to many people, Gopal Pandey. Gopal Pandey, twice he had acute MI while we were in Paras, the early morning, 5 o'clock, once and second time also. Twice he had acute MI, LAD, proximal, almost like ostial. Somehow it was opened and we gave him a flowing artery. But what happened? Third challenge was, after some time, he had a stroke. And there, my competence of, what is his name? Our neurologist in Paras, Abhishek, was beyond doubt, for me at least. I depend on him. And he thrombolized. And thrombolysis was done within 20 minutes, I'm telling you. That quickly he was taken to a CT scan and Abhishek was there, he said, we'll thrombolize to give the best results. So right time, right opportunity, right neurologist, everything was perfect. The guy is left with hemiplegia and aphasia. So this is a very sorry situation.
Yes, sir.
That is what I am telling you, that behavior of cerebral circulation, anatomically, physiologically, everything wise, they are different.
Yes,
so
sir.
we have to consider that. Thank you.
Thank you, sir.
In practicalities, both cerebral impact as well myocardial impact occurs in the different frame of times. Suppose after 12 hours, 36 hours like that. And suppose many of the patient has a past in which the window of intervention and thrombolysis has been passed. So in some situations there is a different type. Suppose there is a large impact and we have to give anticoagulation for that, for the LV thrombus also. So what is your recommendation and what is practical approach of giving dual antiplatelet drugs for the MI and anticoagulation for the thrombus and managing infarctions in acute settings, sir, when the window for the thrombolysis and the intervention for the mechanical thrombectomy has been gone?
Yes, I have put that very thing in the last one. Whenever it's more than 8 hours elapsed, yes, we can do a mechanical thrombectomy for the cardiac patient can extend their things. But in neurology, it is after 3 hours, no thrombolysis. The mechanical thrombectomy is also a problem for them because chances of ICH increases. The best thing is to have a conservative management. Yes, if you are having a dilated atrium or ventricle, anticoagulation is the choice of the blood thinner. And if you don't have, then double antiplatelet is the answer with the rehabilitation therapy for the stroke. That is the answer we have to. Because becoming more strong for the management can do more harm to the patient also. Because a patient is having a big ischemic infarct. If you have given something, if there is a hemorrhage, then there is a problem. Then it's become a big problem for this. Then the mortality also increases with this. So better to be a conservative management in these cases when the time is not with you.
Thank you, sir.
Thank you.
Thank you, sir. Now session is considered to be closed. All the 4 speakers has done a wonderful job. Thank you.
One of the most interesting yet meaningful session by our wonderful speakers on various challenging cases. One of Dr. Prashant, one of the most prestigious nephrologists of city, and Dr. Avinash had discussed chemotherapy and cardiac side effects. And a special thanks to Dr. Sanjay and Ajay Kumar for their insight. Now I would request all the chairperson to felicitate our speakers. A little clap will make more beautiful this moment. So I request you all for applause. I request all the chairperson to felicitate our speakers. And before announcing our next session details, there is an important announcement to our registered delegates and all the faculty who are participating in today's event. It's a request to all of you after lunch, please kindly collect your delegate kit with coupon from registration counter. It's a request to all the delegates and all the guests. Thank you so much, everyone. Thank you so much, distinguished guests. Thank you so much. And may I now request our next speaker, next chairperson, Dr. S.K. Didwania, Dr. A.N. Rai, Dr. U.S. Prasad, Dr. A.K. Jha, Dr. Sudhir Kumar, Dr. B.B. Bharti, and Dr. Nishant Tripathi. I request all of you, all the respected chairperson, kindly come up on stage to chair. And now, a wonderful speaker, one of the most hard doer of CSI, Dr. Arvind Kumar, sir. A huge round of applause for Dr. Arvind. Definitely is one of the most hard doer of CSI. And I would request Dr. S.S. Chatterjee also. Kindly join. Okay, thank you, sir.
Good morning, everyone. Now we have a presidential oration, and the topic for this oration is current guidelines in the management of dyslipidemia by none other than Dr. Arvind Kumar. All of us know him. Dr. Arvind Kumar is a senior cardiologist of Bihar. He is also the president of Bihar branch of CSI. He is a very polite person and always involved in academic activity. Regarding the topic, dyslipidemia is a very common problem. It concerns all physicians, all cardiologists, and it has got a strong association with coronary artery disease, diabetes, hypertension, NAFLD, etc. In Indian population, about 25 to 30% of persons in the urban area, they are suffering from dyslipidemia, and slightly less percentage in the rural population. So now I request Dr. Arvind Kumar for his presentation on the current guidelines in the management of dyslipidemia. Sir.
Thank you, Chairperson, sirs, my teachers, my seniors, and dear friends. I will try to finish my talk within time, and my lecture will basically be helpful for the general physician and cardiologist how to manage dyslipidemia, because our previous speaker, especially yesterday, our president, Mr. Dr. B. Bhang, has already covered so many things regarding management of dyslipidemia. As you know, dyslipidemia is a major modifiable risk factor for the development of atherosclerotic cardiovascular disease, which is called ASCVD. And dyslipidemia has been strongly associated with the pathophysiology of coronary artery disease. What is dyslipidemia? It is either lipid overproduction or deficiency due to abnormal lipid metabolism. Typically, dyslipidemia means increased total cholesterol, LDL cholesterol, triglyceride, and no HDL cholesterol. But the most important is LDL cholesterol, as several epidemiological and other studies have shown that raised LDL cholesterol is associated with increased CV events, and its loading by various lifestyle modification and various medical strategy lower CV events. But you also know that despite achieving LDL target, there remains residual risk for atherosclerotic cardiovascular disease, which is seen in our Indian population much more. So therefore, LDL loading, which is the primary target of lipid lowering therapy, is not enough. Several newer risk factors, lipid biomarkers have been developed to assess residual risk factor. Asian Indian around the globe have higher incidence of atherogenic dyslipidemia, which is typically seen in obesity, metabolic syndrome, insulin resistance, type 2 diabetes mellitus, and is due to poor physical activity, high carb and saturated fat diet. Typically, atherogenic dyslipidemia, which was defined by Austin et al., is low HDL, high TG, and high small dense LDL particles. But subsequently, two other markers has been identified, that is triglyceride-rich VLDL particle and apolipoprotein B also play a critical role in the development of ASCVD. ICMR India study has shown the prevalence of dyslipidemia in India. The prevalence is around 79% of the population have at least one type of lipid abnormality. You can see low HDL was seen in 72%, high TG was seen 26%, and high LDL was seen only in 11%. So Asian Indian phenotype, the TG is a very concern, and this pattern of dyslipidemia is different from the Western population. Similarly, the Body 2 study has shown that higher TG was associated with higher severe risk in diabetes patients, and pre-DMIDE study also shown that high TG, low HDL was associated with 44% high risk of CV events. So after appealing the data, let us go when and how lipid profiles should be tested. As an universal screening, it has been recommended that every people at the age of 18 should have a standard lipid profile, which include, earlier lipid profile should be done if you have a strong family history of premature CVD or history of familial hyperdyslipidemia, then early should be done. Next is whether fasting and non-fasting. So fasting lipid profile is not essential. Even non-fasting lipid profile is enough provided TG is not very high. If TG is very high, then fasting lipid profile should be done. The standard lipid profile doesn't give you all answer. So ESC guideline has recommended extended lipid profile, which included 3 additional things: non-HDL cholesterol, apolipoprotein B, and lipoprotein little a. What is non-HDL cholesterol? It represents total cholesterol minus HDL cholesterol in all atherogenic lipoprotein. It is calculated by subtracting HDL from total cholesterol. It is very strong predictor of CAD, and it should be done in patient with high TG, diabetes, obesity, and very low LDL-C. Goal I will discuss later on. Second important, rather most important, is ApoB analysis. It is very sensitive indicator for atherogenic risk, and it is even preferred over LDL cholesterol if it is available, and it is should be used as an alternative to LDL cholesterol. And it is also recommended in people with diabetes, metabolic syndrome, very high TG, very low HDL-C. And inter-heart study have shown that ApoB was associated with higher incidence of myocardial infarction. Quite earlier, it was demonstrated. The third is lipoprotein little a. Recently, it has been identified as a very important risk factor, and various guidelines, European guidelines says that at least every person's lifetime, it should be measured at least once to identify patient having high level of LPA, which may have the same risk as a patient of heterozygous familial hypercholesterolemia. Besides, it should be measured if the patient has family history of premature CVD, and it to reclassify whether patient belongs to moderate and high risk patient. Here, Lipid Association of India has recommended that if the level is above 50, it means patient belongs to high risk. It is between 20 to 49 moderate risk group. So, and there is no interventional trial which showed that any intervention, if reduces LPA, will help in reduction of CV outcome. And many drugs have been tried, niacin have been tried, recently PCSK9 inhibitor have been shown to reduce LPA level, but it is not recommended in any guideline. Then how to achieve goals, how to measure dyslipidemia, atherogenic dyslipidemia. You all know about lifestyle modification and what to eat, what not to eat, how much exercise do you need, all this you know. Coming to directly to the lipid loading agents, this slide shows that various LDL cholesterol drugs. The first is statins, then ezetimibe, then PCSK9 inhibitor, inclisiran, and the most recently is bempedoic acid. One by one, statins, most powerful agent, primary drugs for the management of atherogenic dyslipidemia. Two atorvastatins have been used in clinical practice, atorva and rojuva, and two types of doses we have been using. One is moderate intensity statin and is high intensity. Moderate intensity statin means atorva 10 to 20, rojuva 5 to 10. High intensity statins means atorva 40 to 80, rojuva 10 to 20. And several trials, both primary and secondary prevention have trials shown that statin-based strategy reduces LDL cholesterol, otherwise all primary and secondary events significantly reduced with the statins. Statins should be used early. Why? Early initiation of statins not only reduces LDL cholesterol, but because of pleiotropic effects, it restores endothelial functions, reduces inflammations, decreases ischemic episodes, stabilizes vulnerable plaques, and ultimately cardiac events. And the rosuvastatin, which is superstatins, in addition to above, it also significantly reduces triglyceride and improves SDL. So it is the drug of choice. After statins, the second drug is ezetimibe, which acts on NPC1L1 receptors in the intestinal mucosa and reduces the absorption of cholesterol. It is highly expressed in diabetes patients. So ezetimibe is highly effective in diabetes patients. The evidence came from improved trials. When ezetimibe was added to simvastatin in ACS patients, there was significant reduction in LDL cholesterol as well as primary endpoint, which was composite of death, MI, stroke. And this was best seen in diabetic patients. Also, IVA study shown that when ezetimibe was added to atorvastatin, there was a significant regression in the atheroma, plaque atheroma, as was seen in precise IVAS trial. Then comes PCSK9 inhibitor. This basically prevents downregulation and destruction of LDL receptors, thereby reducing LDL cholesterol. And two monoclonal antibodies are available. FORIAL trial have used evolocumab versus placebo when it was given to high intensity statins in patients with established ASCVD when LDL cholesterol was more than 70, non-SDL was more than 100. And there was a significant reduction of LDL cholesterol along with primary endpoint, which was composite or MS. Similarly, Odyssey trial used another monoclonal antibody, which is called alirocumab, when it was given in ACS patient on high dose of intensity with LDL more than 70, but target is not achieved. APO target was 100, more than 100, and apolipoprotein which was more than 80. Significantly, there was significant reduction in LDL cholesterol along with all measured primary and secondary targets. So after this PCSK9 inhibitors, then comes inclisiran. This basically inhibits formation of PCSK9. It is a small interfering siRNA, and this Orient 10, 11, and other trials have shown that significant reduction in LDL cholesterol and major events. Then the latest molecule is pempidoic acid, which is ADP citrate lyase inhibitor. It acts one step higher, the site where HMG-CoA reductase inhibitor acts. So it is acts in upstream. And there was a significant reduction in the LDL cholesterol when it was given alone or with ezetimibe. So the only two precautions with pempidoic acid, it increases uric acid, so you have to be cautious in gout. And the most dangerous is tendon injury, rupture of tendon injury. So any patients, a dose is 180 milligram once daily, it can be given. When it is approved in three situations. First, in statin intolerant patient. Second, when there is a history of hereditary familial hyperdyslipidemia and established ASCVD who requires additional LDL loading despite ezetimibe, statins, then in alternate to PCSK9 inhibitor. PCSK is very costly, so this molecule will help us as a third line drugs after statins and ezetimibe. And this is the showing when to use, when not to use. Only precautions when patient, the age is above 60 years, taking corticosteroid or fluoroquinolone with renal injury and history of tendon rupture or joint pain, swelling, etc. You should avoid these molecules. And the evidence came from clear outcome trial. The objective was to evaluate effect of bempedoic acid on CV outcome in a statin intolerant patient. And you will see that the LDL reduction was significantly lower, and the CRP, C-reactive protein level was significantly decreased with these molecules, suggesting that it helps in the reduction of inflammations. And the composite primary and secondary endpoint was CV death, non-MI, and stroke and coronary leave class was significantly lower, 11.7% versus 13.3%. So another meta trial analysis, everyone showed that there is a significant positive outcome with this bempedoic acids. Triglyceride reducing agent, you know about fibrates, fenofibrate, but the most important drug is icosapent-ethyl. The reduce-it trial is the first trial which showed that in high-risk patients, when after using statins ezetimibe, if LDL targets have been achieved, but still triglyceride is very high, then you can add icosapent-ethyl alcohol. It's significant, not only reduces triglyceride, but coronary events. So how much LDL reduction has been achieved by different drugs? Very famous trial. Use of moderate intensity statin reduces 30%, high intensity 50%, high intensity plus ezetimibe 65%, PCSK9 inhibitor 60% reduction. And when you combine it with a statin, 75%. And you combine it, all the three drugs, 85%. Here, bempedoic acid was not approved 2019. So ESC guideline did not mention about bempedoic acid. And this is the most important slide. Every patient has to be classified into 4 groups: low risk, moderate risk, high risk, very high risk, depending on the presence of comorbidity, CKD, diabetes duration, etc. I'm not going to detail. But you must remember the target of LDL cholesterol. If it is low risk patient, target should be 116. Moderate risk, target should be 100. But most important, high risk, very high risk. The target should be less than 70 and less than 55 plus 50% reduction from the baseline. These 2 points to be remembered, because like guideline, Lipid Association of India guideline has given some lower value rather than European guideline. And the secondary target, you must remember, LDL target is not enough. Secondary target is non-HDL. Simple to remember, add 30 figure to the LDL goal. If the LDL goal is 70, it is 100. LDL goal is 55, it is 85. So for non-HDL cholesterol, it is 85, 100 and 130 for very high risk and moderate risk. Similarly, apolipoprotein, just add 10 to the LDL goal. For high risk, moderate risk, it is, and very high risk, 65, 80 and 100. So these figures is easy to remember. 830 for non-HDL, 810 for ApoB. And so these are the secondary targets. Triglyceride target should be less than 50 and A1C should be less than 7. Now, if the patient develops recurrent coronary events, the target is further lowered, as ESC guideline says, that is 40. So even European guideline says that in very, very high risk patient, the LDL target should be less than 40. And triglyceride, again I have already told you, coming to diabetes mellitus, the indication, dose, goal, same, diabetic in non-diabetic patients. Acute coronary syndrome, patient coming to emergency, even if patient is taking statins, you must give high intensity statins as a bolus dose. And check 4 to 6 weeks, if goal is not achieved, then add ezetimibe. After 4 to 6 weeks, goal is still not achieved, you can add PCSK9 inhibitor or bempedoic acid in ACS. Then, while patient is going for angioplasty, even if patient is on statins, you must load the patient high intensity statin in the cath lab to prevent coronary events. Stroke and peripheral vascular disease, the indication, dose, goal same. If the patient has history of stroke, peripheral vascular disease, because they belong to high risk patients, recurrent evidence is much more higher, so high intensity statins is always indicated in these situations. Women, the indication, goal, target is same in women as in men, except in childbearing age and pregnancy, it is contraindicated. Except if the patient is having familial hyperlipidemia, then you can use bile acid sequestrant or you can go for lipid LDL apheresis. For elderly patient, same indication as in young, except above 75 years of the age. If the patient is having renal impairment, take some caution and use low dose of statins in elderly patient. Valvular heart disease, dilated cardiomyopathy, heart failure without CAD, no role of statins in aortic stenosis or congestive heart failure without associated CAD. In chronic kidney disease, again, contraindication is only one. Dialysis dependent CKD patient free from SVD, statins are not indicated, otherwise statins are indicated. Similarly, about side effect, show when to use say no statins if SGPT is raised. Up to 3 times normal, statins should be continued. If it is more than that, reduce it, check SGPT, try to rule out other causes of SGPT, and restart either with the low dose, with the change of statin, or with decreasing the frequency. Similarly, this is with CK. CPKMB again, if it is more than 4 times, do not start. But it is less than 4 times, you start, monitor CPKMB if symptoms are there. Routine measurement of CPK is not indicated. If symptoms are there, then you can titrate the dose, change the statin, reduce the dose, or can go for the alternative day statins. Similarly, A1 should be monitored in patients with high risk of development of diabetes and high dose of statins. That's some chances of development of new onset diabetes. That's what this has been recommended. So coming to the LAI, Lipid Association of India guideline, what is the difference? They have created a new category, which is called extreme risk category, again divided into A, B, and they said that extreme risk category, the LDL cholesterol should be less than 30, less than 30. Europeans say less than 40 or 55, it is less than 30. So what does it mean? Even whatever low level it is, statins are safe. There is no harm in reducing LDL cholesterol. As earlier we thought that beyond that we should not lower the LDL cholesterol. Because why? Indians they manifest CAD earlier, they have severe form of disease, high mortality. So we have to be very aggressive in our approach to decrease atherogenic dyslipidemia. And what the guideline says, even after lifestyle modification, high intensity statin, if LDL goal is still less than 50 as ezetimibe, still goal is more than 50 as bempedoic acid, then PCSK9 inhibitor as per the LAI guideline 2020. About triglyceride, same high risk patient, LDL target try to achieve, then triglyceride is high, then you add icosapent ethyl in the high dose, which is available in India nowadays. And if you compare these two guidelines, I have already said the LAI guideline, what is the target, primary target, secondary target. So LAI guideline I have already explained, and LAPA, and even RSDDI 2020 have advised you must try to target triglyceride Indian population if it is more than 200. Similarly, ADA 2020 recommendation of primary intervention, statins should be used, no doubt. This is the evolution of dyslipidemia management. LDLC main target, secondary target is non-HDL and ApoB, and LPA is the new targets. So to conclude my talk, screening for the lipid, universal screening at the age of 18 years or earlier if there is a family history of premature ACVD or familial hypercholesterolemia, along with BMI, blood sugar and blood pressure. Non-fasting lipid profile will do. Fasting only required when TG is more than 400 or during follow-up. Lipid profile screening should include total cholesterol, TG, HDL, LDL, and non-HDL cholesterol. Direct LDL cholesterol estimation is preferable. In individual with obesity, diabetes, metabolic syndrome, and high TG, low HDL, high risk, ApoB1 should be estimated whenever it is possible. On treatment, ApoB is more reliable indicator for residual risk. Assess ASCVD risk. This gives an opportunity to discuss with the individual and make a shared decision in instituting therapeutic and identifying lipid target. Low density lipoprotein is the primary target, non-HDL, and ApoB is the second target. ApoB has to be estimated in certain situations. Therapeutic lifestyle is the first and integral component of management of dyslipidemia. Statins is the first line of drugs, not goal is then ezetimibe, bempedoic acid, and PCSK9 inhibitors should be added. Consider icosapent acid in high-risk individual if the LDL goal is reached but the TG is not reached, after excluding secondary causes and ensuring strict lifestyle modification. So insurance adherence. So the ultimate dictum is that lower is better, earlier is better, and longer is better, because longer exposure of patient is exposed to LDL cholesterol for a longer period of time, it will give more harm. And the new dictum which I have added, think beyond statin and think beyond LDL cholesterol. Thank you.
Thank you, Dr. Arvind Kumar, for excellent presidential oration. Since it is oration, presidential oration, any oration, no question answer is allowed. Just I want to ask, which drug you will prefer if the statins cannot be tolerated?
some of the patient, we have got some patient where statin cannot be tolerated. Which drug would like to? Would you like to bempedoic
Yeah,
acid?
I would, yes, azitimib will be first choice. If it is not LDL target, then bempedoic acid will be added, as shown in clear outcome trial.
Is there any role of SGLT2 inhibitor, Dr. Arvind Kumar, in dyslipidemia?
As such, there is no role. It decreases CV events in high-risk patients by the other mechanism,
Thank you once again.
Thank you, Dr. Arvind, for this beautiful lecture. But besides this lecture, I just want to thank him for all he is doing for the CSI conferences for last 10 to 15 years. I would say that he is the heart and soul of all the conferences, whether he is in an executive position or not. And I must compliment him for all this. And I know that now that he is president, he will do more and more for the CSI Bihar chapter. Thank you.
Actually, Dr. Arvind was the backbone of the cardiology society of Bihar. And without him, we can't do anything. That's like academy. He is always 24 hours ready to help to other cardiologists. Thank you, boss.
So definitely he needs your love, your blessings and your appreciation. So I would request all the respected chairperson to felicitate our wonderful speaker, Dr. Arvind sir. And our next session is cardiac radiology and nuclear medicine. For that, I would request our chairperson to chair, Dr. Ranjan Chaudhary, Dr. Achyutanand Jha, Dr. Sanjeev Devedi, Dr. Rishikant, Dr. Pranav Santhalia, and our first speaker is Dr. Chinmay from Paras. Sir, please join us.
Now moving on to the next session from cardiology to cardio-nuclear imaging and cardioradiology. I now introduce Dr. Chinmay, who is consultant in Paras HMRI, who will deliver lecture on viability assessment by SPECT and PET. Now over to Dr. Chinmay.
First of all, I would like to thank the organizers for inviting me. Thank you, Chairperson, for the kind introduction. So we will be talking about the role of nuclear medicine in assessment of viability. So the objective of this talk is not to say which imaging is better, like on current present day FDG and cardiac MR both are the heavyweights when you are trying to say determine whether the myocardium is viable or not. And the objective is also not to give the indications of when the cardiologist should be referring for viability test. Primary objective of this short talk is to give a working knowledge on the method and interpretation what we do in a nuclear cardiology lab. So we will be describing some terms, and we will be describing, if time permits, we will talk about 3 relevant trials. So if you see the American literature, they talk about viability as if they are talking about hibernating myocardium. But I would like, and in European literatures and logically speaking, viable myocardium should simply means alive myocardium. And it is a larger set which includes the subset of the normal healthy myocardium and the partial thickness, such as subendocardial scar or hibernating or stunned myocardium. So this is a chart, I modified it from this review article by ESC. So you can see that the stunning early hibernation, advanced hibernation, these are also known as jeopardized myocardium by some. And earlier it was thought of that, it was like they were thought that these are distinct entity, but rather it should be considered a spectrum which begins from, let's say, a single episode of stunning, then frequent multiple episodes of stunning, to early hibernation, to advanced hibernation, and finally, if not intervened upon, maybe scar. So in stunned myocardium, we see that both in stunned and hibernating myocardium, there is contractile dysfunction. But in stunned myocardium, it is acute, the dysfunction is for acute and short period. And in hibernating myocardium, the dysfunction is, it is a chronic dysfunction and it is a long-term dysfunction. And from an imaging, at least from our imaging point of view, from that metabolic and perfusion studies of viabilities, we classically described hibernation as the mismatch sign, that is a reduced perfusion and having preserved metabolism. However, I would like to point the fact that even if there is normal perfusion, it can be a hibernating myocardium, but the only criteria is both hibernating and stunned myocardium have reduced CFR, coronary flow reserve. So these are the markers of viability which can be tested by different modalities of imaging. We will be talking mainly about perfusion and metabolism. The next speaker, Ranjan sir, will be talking about MR. So this is a old data from 2007 where by this author Sinkel, and here in this study, particular study, Sahabuddin Rahimullah was also an author who made this hibernating myocardium term concept famous. So here it is pretty 15 years old study. Here you can see that the FDG PET is most sensitive and the dobutamine is most specific. However, I agree that a lot of changes, improvements have been made both in MRI and PET scanners. So coming finally to, first I would like to show this slice. Like yesterday we saw Anil sir describing in dobutamine stress echo how myocardial segments, the alveolar myocardial segments are divided into 16 segments. In nuclear medicine, we follow the AHA guidelines, and classically this is a convention we always describe in 17 segment model, where this is the apex and these are the anterior, the basal, and the segments which are divided into 3 parts, the apical, mid and basal. However, the septal and lateral parts are divided into 5 segments. So this is a way when after these images are obtained after a lot of hard work, like after the lot of the acquisition, then processing, then creating the slices. So the first image is the line is the perfusion image, and this perfusion image is acquired in a SPECT machine. See, SPECT machine is a different machine, it is a gamma camera, and PET machine is a different machine, it is a PET scanner. So we do this test in 2 different days. On one day, either of one can be done prior. So on one day we do the perfusion study, and another day we do the FDG PET study. So these are the axial short axial sections, where when we are going from left to right, we are going from apex to base of the heart. So these segments will represent the apical segments. Then as we go along, we reach the mid, and later we will reach the basal segments. And these are the vertical long axis view, where again we are proceeding from septal side to the lateral wall of left ventricle. And here, according to the software, it can be from anterior to inferior or inferior to anterior, this horizontal long axis. So the one thing I would like to say that ideally the ideal situation should be both PET perfusion and PET metabolism study. But for PET, doing a PET perfusion study, you need to have an on-site cyclotron, which is not feasible in, at least it is not done anywhere in India in a private setup. So when we report in the form of, actually the reporting is very simple. Like first we see the perfusion, always see the perfusion scan first. Wherever there is a perfusion defect, if the perfusion is normal, forget about it, that myocardium is viable. If there is a perfusion defect, we have to look at those defects and see whether then those defects, it has FDG, preserved FDG uptake or not. If those defects shows preserved FDG uptake, that is a classic mismatch and it is called a hibernating myocardium. If those defects are matched by having, like this is a hibernating myocardium. If those defects in the perfusion also has congruent defects in metabolism like FDG study, those are scarred myocardium. So we see the severity. It is a visual scoring. It is aided by CAD, artificial intelligence, but primarily it still remains a visual scoring where we score on 4 points like mild, moderate, severe and negligible. Those are 4 points. And we say the extent depending on the number of segments involved. So each segment corresponds to 6% because there are 17 segments, 100 by 17 is 6. And then we see whether it is a scar or hibernating myocardium. The other findings we see for lung uptake, which might represent a reduced LV ejection fraction, or even it can be seen in infiltrative lung diseases. Then RV uptake can possibly represent pulmonary hypertension. So though we cannot, there are a lot of variability as we all know in those coronaries, but approximately these anterior segment apex and the apical anterior and anteroseptal segments, these represents the LD territory, these segments represent the RCA and these represent LCF. There is a very approximate, crude approximation. So few cases, I'll be quick. So these are the short axis images where you can see there is severely reduced to negligible, that is score 3 to 4. Perfusion defect in the, these are the perfusion images, okay, in the apical, adjoining portions of the apical segment and the apico-anteroseptum segment. So, and in FDG image, exactly those areas shows, these areas correspondingly shows increased FDG uptake. So what I told that the areas which are showing in normal perfusion, we don't care about those areas. We only see the areas which shows reduced perfusion. If they are showing preserved FDG uptake, this is classic mismatch or the hibernating myocardium. So these are hibernating myocardium, and in the polar plot again you can see, but always it is recommended that it is an aid and just to confirm your findings which you have interpreted in the slices, both this short axis HLA and VLA. Another case, similarly we find this area of negligible perfusion involving apex, adjoining portion of apical anterior, apical septum and maybe mid anterior segment, which corresponds to around 12 to 14% of LV myocardium, and exactly in those corresponding areas we can see, these are the perfusion images, these are the FDG images, we can see a presence of FDG uptake, that is the mismatch. So this is a very prominent, like the extent of viable myocardium, sorry, I should be saying hibernating myocardium is extensive, where you can see that in the perfusion images, apart from maybe let's say a little bit of lateral wall, almost all the myocardium and in basal inferior wall, see in the basal inferior wall, almost all the myocardium, LV myocardium is having negligible perfusion, and all those areas shows lighting up of FDG uptake. So this involved the entire septum, the apex, that is 5 plus 1, 6%, and the apical anterior, apical inferior segment, like 7 plus 2, 8, and parts of mid anterior segment. So almost 9 segments are involved here. So this corresponds to a viable myocardium of hibernating myocardium of 56 to 58%. So these are few trials where the Stitch trial, they showed that there is no interaction between viability status and treatment assignment. So just I want to say that in Stitch trial, they had nothing to say about hibernation. They were just saying about substantial viability and no substantial viability. And in the same example, this is our example which we just saw. In this example, there were apparently 9 viable myocardium segments. So according to Stitch criteria, it would have been a non-viable, like without substantial viability. But we can see that it was definitely a hibernating myocardium, and this was definitely wrongly included in the, such a case would definitely have been wrongly included in a different group. Another type of mistake that this criteria would have done is a scarred myocardium being included in a substantial viability group. However, this PAR 2 study suggested that whenever there were 2 arms, one was FDG assisted, one another standard of care, when this FDG assisted arm was considered and the PET CT recommendation was adhered, there was a significant reduction in the primary cardiac composite events. However, to contradict this again, there is another revived BCIS 2 study where the management was decided depending on the presence of viable segments, more than 4 segments, and they found that there was no difference in the outcome. when PCI was compared with optimal medical therapy. So to conclude, I don't want to give a guideline, I don't want to quote any guideline that when it should be indicated or not. And I don't want to fight with MR that which my modality is better, your modality is better. The thing is, if you go through literature, some say, if the hibernating myocardium is 6% to 38%, there is chance of recovery. Now the the criteria for recovery in these studies are also different, like increase in ejection fraction, decrease in mortality. So finally the decision to either revascularize or not has to be taken by the cardiologist, considering these findings as well as the clinical parameters in question. Thank you.
Thank you, Dr. Chinmay. Dr. Chinmay is ready to take any questions. No question. Okay, thank you, Dr. Chinmay.
Hey, Dr. Chinmay.
Sir.
What is the percentage of myocardial viability on a SPECT that we can assess that this patient will definitely benefit after the revascularization? Suppose a patient having 5% area of myocardial is viable or 3%. Overall, any guideline that particular area of?
No, sir, but the usual dictum is it says at least 4 segments should be hibernating. Matlab 24% maybe. 24 segments.
Normally what we cardiologists do, that if a artery is 100% occluded, then before revascularization we advised for myocardial viability test. Okay. And preferably I advised SPECT with PECT.
It is the dictum, sir. It's always, it should be advised SPECT plus PET.
Plus PET.
Both should be advised.
Then who will decide? We cardiologist, that urologist, that this patient will definitely get benefit after the revascularization. That is some, because generally we see that some reports are that 5% area is viable, 5% is ischemic. Then we became totally confused what to do. Then what will be the next step? Any idea?
Like, sir, it has to be, I think both
decided by us,
as a team,
according to the symptom.
Yes, it should be decided as a team. Matlab, the final decision has to be the cardiologist decision.
Okay. Thank you.
Thank you, Dr. Chinmay, for excellent talk. Now we are going towards another non-invasive cardiac imaging, because the most common problem with these PET and SPECT is that spatial resolution is very bad. And so cardiac MRI is very important nowadays, apart from the conventional indications like complex cardiac diseases, congenital cardiac diseases, and pericardial diseases, myocarditis, all that. Even in viability imaging, due to development of actually LG, late gadolinium enhancement, T1, T2 mapping, as well as diffusion weighted images, and role of AI in image acquisition as well as post-processing. Now cardiac MRI, I think, is going to be the most indispensable imaging, non-invasive imaging in the cases of AI. Dr. Ranjan, the head radiologist, Medanta Patna, he is going to enlighten about the cardiac MRI, role of cardiac MRI in cardiology.
First of all, good afternoon, everyone, and thanks, Chairperson, for kind introduction. Thanks to organizers for inviting me and giving us the opportunity to participate in this conference. So, my time, I think, is allotted very less. So, I'll try to be fast and try to complete on time. So I'll be discussing about role of cardiac MRI in day-to-day practice. I'm not going into detail of any particular disease, but we see, and I'll try to show you the real case scenario of common diseases. One slide on practical aspect. It doesn't matter the MRI is 1.5 Tesla or 3 Tesla. And we have to give gadolinium in these patients so renal function is in normal limit. One scan takes 45 to 60 minutes and breath hold of 10 to 15 seconds is required for multiple times. It is important for getting better image quality. Patient has to lie flat, non-compatible pacemaker and claustrophobia are contraindications, absolute contraindications. Why MR is a diagnostic tool or investigation of choice for cardiac diseases? It has no radiation, no, non-invasive, multiplanar imaging, cine imaging, functional imaging, 3D imaging, T1, T2 mapping, flow quantification, edema imaging, early and late gadolinium enhancement imaging. These all make MRI diagnostic tool for ischemic cardiac disease in terms of viability and scarring. Non-ischemic cardiomyopathies, cardiac masses, thrombi, 4 pericardial diseases, arrhythmia evaluation, valvular assessment, and mediastinal vascular diseases. So come to the ischemic cardiomyopathy. Where does CMR stand? Dr. Chinmay has described right now that PET-CT is considered to be a gold standard for viability assessment. So CMR stands closest to the PET-CT and far ahead to the echo aspect in terms of sensitivity and specificity. I'll try to show you the real case. CMR has to give the answers of few questions regarding the ischemic heart disease, whether there is ischemia or not. If there is ischemia, which territory is involved? If there is ischemia, the segments are viable or not? If it is viable, inducible ischemia is present or not? What is the function of the ventricle, because CMR is gold standard for ventricular function. And then identification of complications of MI like aneurysm, thrombus, valvular regurgitation. And by all these answers, we give a roadmap for deciding whether the revascular surgery or non-surgical treatment is sufficient for this patient. This is a patient, 60-year-old male, case of coronary artery disease, suspected thrombus in LV on echo. It was sent to me for cardiac MR, and you can see, what is the pointer? No. Yes. I'll try to show the video, cine images. These are the cine images, four-chamber view and short axis view. You can see there is marked thinning of the basal and mid cavity, anterolateral and inferolateral wall. These segments are akinetic. So we see how does it look on LGE. These are the LGE short axis images. You can see there is transmural or near transmural enhancement. This is the normal myocardium, which is black. And this is the enhancing myocardium, almost transmural enhancement, anterolateral, inferolateral wall. So these segments are akinetic, thinned-walled, and transmural enhancement. So these three things indicate that these segments are non-viable. Come to the thrombus, which was suspected on echo. This is the late gadolinium opposite phase images in high TI value. There is hypointense, non-enhancing layered thrombus in the aneurysmal part of the LV. So it's a aneurysm, thrombus, and non-viable segments. CMR is very good at picking viability and non-viability segments. There's the same case. I'm skipping this. Coming to the non-ischemic cardiomyopathy, cardiac MR is indicated in hypertrophic cardiomyopathy, first presentation of dilated cardiomyopathy, then inflammatory and infiltrative cardiomyopathy, myocarditis, which can present as acute chest pain with normal coronaries, RV cardiomyopathy, and iron overload. In these cases also, MRI has to give answers to a few questions like there is thickening of the myocardium or not, which ventricle is involved, ventricle is a smaller or dilated, single ventricular involvement or biventricular involvement, and if there is hypertrophy, then HCM mid-cavity type, then there is aneurysmal dilatation of the apex or not, and SAM evaluation in HCM. And what are the enhancement pattern in LG of myocardium so that we can narrow the differentials. Come to the real case, we did 2 days back, this patient sent from Mediversal. Dr. Vikas Singh had sent this case, 32-year-old female, dyspnea on exertion, 8 to 10 years, episodes of palpitation, even at rest. On echo, LV hypertrophy was there, diastolic dysfunction on echo. We did MRI, and you can see there is marked concentric hypertrophy of LV. And there is a hypertrabeculation in lateral wall. We gave the contrast, and on LG, you can see there is extensive mid-myocardial, nodular, and patchy enhancement in anterior, anterolateral, inferolateral, and inferoseptal wall. This is the normal myocardium. This is the mid-myocardial enhancement. Black is the normal, bright is LG enhancement. On 4-chamber view also, there is mid-myocardial enhancement. So this is typical enhancement of HCM, hypertrophic cardiomyopathy. One differential was on echo. It could be amyloidosis, but this is not the pattern of LG of amyloid. So this is hypertrophic cardiomyopathy with a bulk or large volume of scar. And more than 15% of scar burden has bad prognosis for this HCM. This is a apical variety of HCM showing again a scar. This is a bright thing, mid-myocardial enhancement on LG, but the scar is not very high. Come to the another case, another cardiomyopathy, 43-year-old male patient, severe LV dysfunction, sent for MRI. Last week we did this MRI, and you can see there is dilatation of the LV, global hypokinesia, and these are the images of LG. So the very beautiful, dark, normal myocardium, because there is no enhancement. So it's a non-ischemic dilated cardiomyopathy, no enhancement, no scar, nothing. Another case, 26-year-old male patient, recent onset dyspnea, 1 month, swelling of feet, bilateral dilatation of atria on CT chest. CT chest was done due to breathlessness. Dr. Abhinav had sent this patient to me for cardiac MRI, and you see there is marked biatrial dilatation suggestive of restrictive physiology, and you can see this is the SORT axis, LG images. There is mid-myocardial mild enhancement in anterolateral and inferolateral wall. So this could be a deposition or infiltrative cardiomyopathy most likely. Another case, 31-year-old male patient presented with acute chest pain. Other tests are non-specific, ECG, echo, and angio are non-specific. You see this is the edema imaging, stir SORT axis view showing bright edema in lateral wall. This is the hyperemia imaging. Hyperemia means early gadolinium enhancement imaging. There is enhancement in the lateral wall. This is the late gadolinium enhancement image showing subepicardial enhancement in lateral wall. You can see these are the patchy enhancement on 4-chamber view, suggestive of granulomatous myocarditis, could be tuberculosis. With another case, young patient, palpitations, shortness of breath, atypical chest pain, patchy edema, and on SORT axis and 4-chamber view, you can see there is enhancement, RV side of the septum, and there is patchy enhancement in the lateral myocardium, subepicardial enhancement. So most likely it's a sarcoid, because in sarcoid, the septum is commonly involved. It's a very interesting case, 51-year-old male patient. On echo, it was there was suspicion of RV cardiomyopathy, RV dysfunction was there. Echo was done in our hospital, biatrial dilatation, thickening of the myocardium involving RV and LV. So it's a restrictive physiology. Low voltage waves on ECG, we did cardiac MRI. You see there is a concentric LV hypertrophy. on both short axis and 4-chamber view, mild pericardial effusion, biatrial dilatation, mild pericardial effusion. How does it look on LG? You can see this is the LG image, diffuse enhancement, subendocardial enhancement involving both the ventricles, LV and RV on 4-chamber view also. So biatrial dilatation, restrictive physiology, pericardial effusion, subendocardial enhancement, pleural effusion, all these things are suggestive of amyloid. Another interesting case, you can see, again it's a biatrial dilatation, restrictive physiology on echo. On lab test, there is very high eosinophil percentage, almost 60%. And we did MRI, and you see, there is thickening of the myocardium more on apical side, obliterating the apex, involving both the RV and LV, smaller RV, obliteration of the apex, severe valve, mitral regurgitation, biatrial dilatation, mild pericardial effusion. So see how does it look on LG. You can see there is a subendocardial enhancement in both the ventricles and mid-myocardial enhancement in the septum. So this is the typical feature of eosinophilic myocarditis or endomyocardial fibrosis. It is associated commonly with the LV thrombus, but in my case, the thrombus was not there. I have taken the image from net. There is thrombus in this case. Thrombus is the hypointense with subendocardial enhancement. So this is the LV thrombus. Thrombus was not with my case. CMR is very good at quantification of iron overload in the myocardium, and it is used for diagnosis, monitoring, and follow-up. Come to the T1 and T2 mapping. What is mapping? Mapping is just assigning a value to each pixel of myocardium, like in CT scan we give density in HU value. And by assigning we characterize the myocardial character, whether there is a disease or not, without giving contrast. So in renal disease patient, it is very useful, and nowadays it is widely used in picking up the diseases in very early stage, even in subclinical stage. So this is a hypertrophic cardiomyopathy, the patchy increase in the T1 values suggestive of fibrosis or a scar in the myocardium, even it has not appeared on LGE. These are the few cases where the T1 is very low, like lipomatous metaplasia, iron overload, and they are very increased in amyloid. And just I'm finishing this case. Tumor and thrombus is also differentiated by cardiac MR in terms of, it's a very interesting case, sarcomatous mesothelioma, left lung. So for me, for cardiac MR, and you can see there is a large mass in lung, and their extension into the left atrium. You can see this mass is extending through the pulmonary vein into the left atrium and appear as a left atrial mass. It's a very rare case. Few cases has been reported. This is the very, my favorite slide, 45-year-old male, occasional sweating and palpitation. Came for cardiac MR, you can see, and on echo it was suspicion of mass lesion at RVOT, and on cardiac MR you can see there is aneurysmal dilatation of the right coronary sinus of Valsalva, and with thrombus inside causing obstruction to the RVOT. There is no enhancement on the on LGE, and surgery was done by Dr. Sanjay, our CTVS surgeon, and patient went well in his life. Cardiac MR is very good at picking pericardial disease. We can see this is a case. You can see there is a pericardial effusion, biatrial dilatation, restrictive physiology. Come to the LG, you can see there is a diffuse enhancement of the visceral and parietal pericardium, so it's suggestive of constructive acute pericarditis. Arrhythmia evaluation, cardiac MR is very good, because if you want to place your ICD or RT placement, so to evaluate the culprit of the arrhythmia, there is a scar in the anterolateral wall. So MR is good at picking a scar and even functional assessment. For pediatric also, we are CMR is indicated for follow-up and monitoring. For valvular assessment, we do the functional flow quantification to exact evaluate the quantification of the flow in through the valve and through the vessels. So I am finishing my talk. These are the indications for cardiac MR. CAD with LV dysfunction to assess the viability, chest pain with normal CAG to exclude myocarditis, ischemia assessment in intermediate CAD. CMR is very good at mass detected on echo for evaluation, first presentation of dilated cardiomyopathy, complex congenital heart disease, identification of a scar site, ventricular function, anatomical abnormalities in arrhythmia evaluation, and follow-up for valvular pathologies. Thank you very much.
Thank you, Dr. Ranjan. Any question? One question from Dr. Ranjan. Have you any experience of diffusion and DTI in cardiac imaging?
No, boss. I'm not doing diffusion, but yes, diffusion has an important role of picking up whether the myocardium is active or dead or live. But the reality, I have not.
And this T1 and T2 mapping you are doing?
T1, T2 I am not doing. Few cases I have done because software is very costly. We are planning to take it in near future, but on cloud based, some vendor has provided us to export our cases, and they will calculate the T1, T2 mapping and send back to us.
Okay, thank you. And one last question, you are using AI in image acquisition as well as in post-processing or not?
Post-processing, like that software is equipped that they just within like 2 to 3 minutes.
You are using that or not?
Give all the parameters by AI, like contouring of the endocardium and pericardium and giving the ventricles function.
Thank you. Nowadays, most of the patients are on pacemaker. So just for your information, nowadays all pacemakers are MRI compatible. So patient go for MRI even if implanted permanent pacemaker, because most of the pacemaker are MRI compatible.
Yes, right. But for particular cardiac MRI, if pacemaker is there, there is a lot of artifact in the myocardium. So it's very difficult to evaluate the myocardium. But for other MRI, other parts of the body, it can go. It's a pacemaker is compatible.
That is what I wanted to know from you. Whether pacemaker patients are suitable for cardiac MRI?
No, sir. No, sir. Few sequences are available to reduce the artifact nowadays. But frankly saying, artifact is still there. Thank you, sir.
Any more questions? Thank you, sir. It was such a good presentation, very good images we saw. I think we can conclude our session.
Thank you so much, sir. May I now request our chairperson kindly felicitate our speaker. I request Dr. Chinmay kindly come up on stage. And our next session is Potpourri. For this session, I would request our chairperson to join us, Dr. B.C. Jha, Dr. Rajiv Ranjan sir from Chhapra, Dr. Ravi Kirti sir, Dr. Rohit, Dr. Sushil Kumar, Dr. Shreyash Trivedi, Dr. Navneet, Dr. Anupam Bambani, Dr. Anil Kumar Singh, Dr. B.K. Singh, IGIC. Thank you so much, all the speakers and all our respected chairperson. And our first speaker of this session is Dr. Birendra Kumar from Bhagalpur.
Our first speaker is Dr. Birendra Kumar from Bhagalpur. He will speak on pre-operative evaluation of cardiac patients undergoing non-cardiac surgery. This topic is very important nowadays. I request Dr. Birendra Kumar to continue his talk.
Thank you, respected chairperson. Thank you all the teachers available in the seminar hall, all my colleagues and juniors. So we are done with all those diagnostic and intervention modality for the cardiac illnesses. And now it's time to evaluate the cardiac patient for non-cardiac interventions. Being such an important topic, we have to deal and declare all those aspects of the non-cardiac surgery undergoing in the cardiac patient. So going ahead with the presentation, I'm Dr. Virendra Kumar. So why this topic is so important? We know we have a huge population of the cardiac population in our country, and those cardiac patient needs non-cardiac surgery day in, day out, and these non-cardiac surgery in cardiac patient have definite risk of complication, and worldwide this non-cardiac surgery is associated with a complication rate of up to 10% and mortality of up to 1.5%, and of those complications, most of these, almost half of these are caused by cardiac complications. So cardiac complications are there in non-cardiac surgery if the patient is cardiac, and these can be a patient-related risk factor. This depends on the type of surgery and the circumstances we are taking, the surgery is taking place. So what are the hemodynamic changes during surgery? Every operations have some stress response. This can be induced by tissue injury, sympathetic vagal imbalance, fluid shifts in the compartment during surgery, and the imbalance between the prothrombotic and fibrinolytic factor potentially resulting in the increased coronary thrombogenicity. Stress-induced increased myocardial oxygen demands is also there. So these factors together with the patient positions, bleeding, and type of anesthesia may contribute to the hemodynamic derangement leading to the myocardial ischemia and heart failure. So how to deal with, how to evaluate pre-operatively? So we have a step-wise approach. First of all, we decide the urgency of surgery. Then we decide whether there is active or unstable cardiac condition is there or not. Then we go ahead with what is the risk of surgical procedure he is supposed to undergo. Then we decide what are the functional capacity of the patient, and at the fifth stage, in the patient with moderate or low functional capacity, we consider the risk of surgical procedure in details, and then go ahead with the cardiac risk factors, and finally, if the need is there, the non-invasive and invasive tests. So going ahead with the presentation, the first step is urgency of surgery. We have some major traumatic surgery, perforated viscous there. In urgent or emergent surgery, the role of cardiology consultation is to provide recommendation on the perioperative management rather than the risk evaluation only, and minimization of the cardiovascular risk and surveillance of the cardiovascular event, usually without performing additional tests to avoid the undelayed in the surgery. So the role of cardiologists here is to do not delay in surgery, rather assist the surgery so that the minimal cardiac complications occurs during the perioperative or during the surgery and post-surgical period. There are few surgery which are time sensitive, where delay of 1 to 6 weeks can be done for further evaluation, and there are surgery which are electively done, procedure can be delayed up to 1 year. So depending on the urgency of the surgery, we can decide. What the guideline says, in patient who require emergency surgery, your role is to, pre-operative evaluation role is to assist the surgery, minimize the risk of complication during perioperative. In patient who require urgent or semi-urgent surgery, they recommend the undertaking operative cardiac risk assessment only if the patient history and physical examination suggests that the potential undiagnosed severe obstructive cardiac intracardiac abnormality, severe pulmonary hypertension, or unstable cardiac condition. So in emergent or urgent situation, you have to look for briefly, or you can say the quick look for those possible causes within the heart, whether there is obstructive severe AS is there, pulmonary hypertension is there, or patient is having unstable coronary symptoms. Then depending on that, you go ahead with the algorithm of the evaluation. In patients who undergo elective non-cardiac surgery, who are 55 years or old, or those who are below 45 and above 18 years of the age and known case of cardiovascular disease, we recommend they undergo pre-operative cardiac risk assessment thoroughly. So coming to the step 2, we look for the unstable cardiac condition. Here we look for the unstable or severe arrest angina or a new onset severe angina, or there is a recent MI within 1 month, or ongoing symptoms of ischemia, there are symptoms of overt heart failure, there is any underlying severe arrhythmia or overt severe arrhythmias or severe valvular disease. If these are not there, go ahead with the stage 3, or if these are present, we postpone the procedure and treatment option to be discussed in a multidisciplinary team involving all the perioperative physicians, including anesthesiologist, surgeon, and the cardiologist. So here is a, if you are doing cardiac evaluation and urgent surgery is the need of the hour, the surgery outweighs the risk evaluation thoroughly. If you are dealing with an unstable cardiac patient, the cardiac situation overweighs the surgery. Stage 3 is the type of surgery. We know all those non-cardiac surgery either fall in the one of the 3 groups, and we can definitely evaluate the risk involved with the surgery rather than the only cardiac condition. So superficial surgery, breast surgery, dental surgery, endocrine, thyroid surgery, most of the eye surgery, reconstructive surgery, most of the asymptomatic carotid surgeries, and minor gynecological and orthopedic surgery, and urological minor like a TURP. These are low risk surgery. On the other hand, there are very high risk surgeries like aortic and major vascular surgery, open limb revasculation or amputation or thromboembolectomy, duodenal pancreatic surgery, or the liver resection, bile duct surgeries, esophagectomy, repair of the perforated bowel, adrenal resection, cystectomy and pneumectomy, and pulmonary and liver transplant. All others fall in the intermediate group. So we are, if you are dealing with a low risk, the algorithm changes, and if you are dealing with an intermediate or high risk surgery, algorithm altogether changes. So if you are dealing with a low surgical procedure, identify the risk factor, provide recommendation on the lifestyle and medical treatment, and go ahead with the surgery post-operatively. If you are dealing with the intermediate or high risk surgical procedure, then algorithm slightly changes. You evaluate the functional capacity of the patient. If patient can do can walk at least for the 100 to 200 meters on the level ground, it's his mates, the meta, you can say the functional capacity is in between the 1 mates to the 4 mates. Ideally, you would like to have a functional capacity more than 4 mates. And the easiest question you have to ask is whether the patient can climb 2 flights of stairs or walk uphill or run a short distance. If he is able to do that activity, he is definitely having a functional capacity of more than 4 mates. Any exercise which is heavier than that is swimming or doing the household floor activity or swimming, basketball, any active sports that will have mates of more than 4 mates, and these are the good functional capacity to have for any patient undergoing non-cardiac surgery. So these are the metabolic mates quantifies the metabolic demands at rest, and once you have quantified that the patient is able to do any activity more than 4 mates, requiring more than 4 mates, you are assured that the sufficient functional capacity is there. Inability to do that definitely have a lower mates. So when capacity is high, prognosis is excellent even in the presence of stable ischemic heart disease. Any patient who have stable angina and the functional capacity is 10 or more than 4, almost 10, his prognosis is going to very good even if done elective surgery in this patient with up to the intermediate risk of surgery. Majority of patients with stable heart disease can undergo low and intermediate surgery without additional evaluation if his functional capacity is very good. So evaluation of the functional capacity, at least clinically, if not possible by non-invasive means, is very important. So functional capacity assessment in intermediate or high risk surgery. Those patients who are undergoing non-cardiac surgery, which is very high risk or intermediate risk, if he is not able to climb 2 flights of stairs or run short distance, if he is able to go ahead with the surgery, not able to evaluate further. When functional capacity is poor, you go ahead with the further evaluation. What are those further? First of all, look for the RCI score. If there is previous MI, angina, diabetes mellitus requiring insulin, or renal insufficiency with creatinine more than 2, history of a stroke or symptoms of heart failure with raised BNP or anti-proBNP, these are the risk factors you have to look for. And if any two of these present, or if none of them present, RCI score is 0. And if his meds is more than 4, you can go ahead with the surgery. If the RCRI score is more than 1 or more than 1 and meds are less than 4, these are the situation where you have to evaluate further or defer surgery if possible. Serum biomarker, electrocardiogram, ECG, non-invasive imaging, these are to be done in any patient who have RCRI more than 1 or meds functional capacity less than 4 meds. Echo definitely have to do in this patient, and all those patients echocardiography is not recommended. So coming to the stress testing, those have a moderate or high risk of the low functional capacity and high risk surgery. Imaging stress testing is a class 1 recommendation before high risk surgery in patient with definitely less than 4 minutes of functional capacity. Imaging stress is a to be classification, recommendation for those patients who are undergoing intermediate or high risk, and those having low risk, you do not have to do these tests. Preoperative testing, stage 5 is the cardiac stage. If there is extensive ischemia, you will go ahead with the ischemic guideline, and if there is no or moderate stage-induced ischemia, class 1 indication, you proceed with the procedure with a statin and low-dose titrated beta blocker. If systolic LV function is low, definitely ACE inhibitor to be added. Anti-proBNP definitely has a role in those evaluation. Emergency surgery, no role, no evaluation is needed. Only perioperative ECG and the biomarkers of the perioperative ischemia is recommended. Other situation, you will go ahead with if the risk of the surgery is high or the patient's functional capacity is low. Coronary angiogram, recommendation of coronary angiogram will guided by the coronary status of the patient, not by the surgery he is going plan to undergo. So indication of coronary angiogram remains the same whether the surgery is low risk, high risk or intermediate risk. So recommendation or indication of preoperative coronary angiogram remains the same as the non-surgical or surgical patient. Urgent angiogram is recommended in cases of STEMI or high risk non-ST cases, and all those having class 4 heart failure patients or unstable ischemia patient should undergo coronary angiogram evaluation. These are guided by the coronary situation, not by the surgery he is planned to undergo. So these already I have described the flow chart of the patient. You have to go stepwise depending on the surgery he is planned to undergo and the functional capacity and the cardiac status he is having. Specific diseases, arterial hypertension, class 1, class 2, grade 1, grade 2 hypertension, you can definitely go ahead with the surgery with a proper management of the hypertension. You have to avoid the fluctuation in the hypertension in a perioperative period. Mitral stenosis, valvular heart disease, aortic stenosis, less than severe, you can go ahead with the low risk surgery. Any severe stenosis, you have to first do BMB or PTMC and then go ahead with the surgery. Aortic stenosis, severe aortic stenosis, definitely go ahead with the valve surgery first, then only plan the surgery if the surgery is intermediate or high risk. MR, aortic regurgitation or mitral regurgitation, any non-significant aortic regurgitation or mitral regurgitation, if the procedure is low risk or intermediate risk, you can go ahead with asymptomatic patient. In symptomatic patient, still you can go ahead with the surgery. If patient is having non-severe or non-severe MR or AR, you can go ahead with surgery, but with some additional risk. In patient having low ejection fraction and symptoms of heart failure or the valvular lesion, you definitely have to defer surgery and reevaluate. Heart failure, definitely you will evaluate for the symptoms of heart failure, optimize the treatment, and then only can plan. All patients with heart failure who are scheduled for the non-cardiac surgery should be treated optimally according to the recommendation. Pro-BNP, we know that we have to go. So non-urgent surgery, you have to defer. Antiplatelet, I would like to, briefly I will conclude, this is the important one. If patient is on dual antiplatelet, if you can continue aspirin and then you can stop clopidogrel, that P2Y inhibitor, can be stopped. If bleeding risk is low, you can continue aspirin and go ahead with stopping the clopidogrel, ticagrelor, or any other P2Y inhibitor, and go for the surgery. If patient dual antiplatelet therapy undergoing elective non-cardiac surgery, DAPT, ideally post-MI, you can, if possible, defer the surgery for 6 months. If not possible, at least 1 month of DAPT is necessary if intervention is already, PTC is already been done. So ACS at index PCI, if any patient had MI and PCI done and then need for the non-cardiac surgery is there, stopping of the dual antiplatelet before 1 month is definitely a risk for the thrombotic occlusion of the stents. Beyond 1 month up to 6 months you can stop, and beyond 6 months definitely you can stop and go ahead with the surgery. What are the duration where you can stop P2 inhibitor? If you are using prasugrel, you have to stop 7 days before the surgery. In case of clopidogrel, you will stop 5 days before surgery, and ticagrelor 3 days before surgery, and restart accordingly. For anticoagulation, if patient is on anticoagulation for the prosthetic valve, atrial fibrillation, DVT or pulmonary embolism, stop anticoagulation, start low molecular heparin or unfractionated heparin next day, check for the INR daily. Surgery can be done when INR is less than 1.5, that is 1.4. Omit the last dose of LMWS 12 hours before, or if you are using heparin 4 hours before, and restart low molecular heparin 1 day after surgery along with the oral anticoagulation, and once the INR is achieved, stop the LMWS. Now for newer anticoagulation, you have to look for the half-life of that particular agent. You will stop 2-3 times half-life of that agent before, at least prior 3 half-lives prior to the surgery. And in cases of the normal bleeding, or if the bleeding is high, you have to stop 5 times of the half-life before the surgery for that. Choice of anesthesia, inhaled is better. So take home message, I'm concluding, the judicious pre-operative cardiac evaluation should be done in all patients using simple flow chart explained. It will save unnecessary time delay and avoid unnecessary investigation, ensure the patient safety and will doctor safety for the medical legal proceeding. Thank you.
Thank you. The question and answer will be taken in the last. The next speaker is Dr. Dinanath Kumar, and he will talk about infective endocarditis management dilemma.
Respected chairpersons, respected teachers, and my dear friends. So there is really a dilemma in treating infective endocarditis, because I think it's the most difficult disease in our cardiology. So because there are variable clinical presentations, so there is a diagnostic dilemma, and infective endocarditis should be considered in all patients with sepsis or fever of unknown origin in the presence of risk factor. So these are the risk factors: cardiac risk factor, non-cardiac risk factor, and there should be very high index of suspicion, low threshold for investigation to avoid delays in diagnosis. So endocarditis treatment is really a teamwork. Only cardiologist cannot treat a patient, so you have to involve cardiologist, cardiac imaging expert, surgeons, infective disease specialist, microbiologist, so as to do a teamwork and treat the patient. So this is how we evaluate a patient with infective endocarditis. You have to take the blood culture and imaging, and then after you have diagnosed the patient as infective endocarditis, according to the microorganism, you have to start antibiotics, assess for complication, and then deal accordingly. So this is the latest 2023 ESC modified diagnostic criteria for infective endocarditis. You all know that the diagnostic criteria. Just to update that there have been 2 updates in this guideline. First is Enterococcus faecalis is acknowledged as typical bacterium regardless of the place of acquisition. So this has increased the diagnostic efficacy by 30%. And second most important thing is, initially we used to see anatomic lesions, but now they have considered metabolic lesions also, like lesions which are detected by FDG PET-CT or WBC SPECT-CT. So this newer diagnostic modality has increased the diagnosis of infective endocarditis irrespective of the time of surgery, from interval from the time of surgery. So before you have got the report of the culture, so you can start antibiotic empirically by looking at the condition of the patient. So if the patient has got native endocarditis or late prosthetic endocarditis, in that case you can start with ampicillin, ceftriaxone, and along with that you can give gentamicin. But if the patient has developed endocarditis less than 12 months after prosthetic valve implantation or nosocomial endocarditis, in that case you have to start with vancomycin along with gentamicin and rifampicin. So as per the culture report, you have to modify your antibiotic regime. So for streptococcal infective endocarditis, standard dose is 4-week duration regime for native valve and 6 weeks for prosthetic valve. So in this, preferably you give ceftriaxone 2 grams per day in single dose. Now for those patients who are allergic to beta-lactam, you can give vancomycin 30 mg per kg per day, IV in 2 divided doses for 4 weeks. And for prosthetic valve, you have to add gentamicin for another 2 weeks. For staphylococcal, for native valve, if the patient is susceptible to methicillin receptive streptococci, you have to give cefalozilin for 4 to 6 weeks. And for prosthetic valve, you have to add rifampicin and gentamicin also. For methicillin resistant staphylococcal infection, for native valve, you have to give vancomycin, and for prosthetic valve, you have to add rifampicin and gentamicin also. For enterococcal, if the patient is susceptible to aminoglycosides, in that case, you have to give ampicillin or amoxicillin along with that ceftriaxone and gentamicin for 2 weeks. For beta-lactam resistant enterococcus, you have to give vancomycin, along with that you have to give gentamicin. For vancomycin resistant enterococcus infection, you have to give daptomycin, and along with that you have to give some beta-lactam like ampicillin or ertapenem. So now this is most important addition in the current guideline. So initially we used to think that infective endocarditis can be managed only in hospital. But now you can initially stabilize the patient with IV antibiotic in hospital, and then you can manage the patient in outpatient setting either by giving IV antibiotic at home or oral antibiotic. So this is the latest addition that is called outpatient parenteral antibiotic treatment or step-down outpatient oral antibiotic treatment. Should be considered only in those patients who have got left-sided infective endocarditis caused by only 4 species: Streptococcus, Enterococcus faecalis, Staphylococcus aureus, and coagulase negative streptococci, who were receiving appropriate IV antibiotics for at least 10 days or at least 7 days after cardiac surgery, are clinically stable and who do not show signs of abscess formation or valve abnormality. So these are the general recommendations that patients should be stable, home environment is stable, preferably patient is self-reliant or home health care can be provided, and there should be no contraindication like heart failure, severe valve regurgitation, vegetation more than 10 mm, neurological involvement, renal impairment, malabsorption, and people with injectable drug addict. So in these patients, you can, after giving initial 10 doses of IV antibiotic, you switch the patient to either IV antibiotic at home or oral antibiotics. So the oral antibiotics which have been studied in POET trial, POET POET trial, they have given these combinations of antibiotics which can be given orally after initial 10 days of IV antibiotics. Now the most, the headache of cardiologist is CID infection, that is cardiovascular implantable electronic device related infective endocarditis. This is defined as evidence of CID infection with clinical signs of pocket infection and or imaging findings of lead vegetation. Either lead vegetation or you can do positive, or you do FDG PET, you get positive FDG PET on the generator or the leads. So that's why to prevent infective endocarditis in this subset of patient, we give antibiotic prophylaxis covering the Staphylococcus aureus before we are doing any electronic device implantation. Now, if you are suspecting CID infection, you have to do both transthoracic as well as transesophageal echo to detect the disease. And if you have confirmed CID infective endocarditis, the treatment is complete system extraction without delay. With under initial empirical antibiotic therapy, and after the culture report, you have to modify your antibiotics. Now, if you are planning to reimplant the CID in this type of patients, then it is recommended to be performed at a site distant from the previous generator as late as possible, once signs and symptoms of infection abated, and until blood cultures are negative for at least 72 hours in the absence of vegetation and negative for at least 2 weeks if vegetation were visualized. So after that, you can reimplant the CID in those patients. Surgical treatment dilemma is also there, but the main indication for jury infective enteritis only three. First is heart failure. The patient has got a severe aortic regurgitation or obstruction, and along with that refractory pulmonary edema or cardiogenic shock. In that case, you have to do urgent surgery, emergency surgery. Second is uncontrolled infection. That is recommended in locally uncontrolled infection, abscess formation, false aneurysm, fistula, enlarging vegetation, new AV blocks. And third is prevention of embolism. If the patient has got aortic or mitral native valve or prosthetic valve endocarditis and persistent vegetation more than equal to 10 mm after one or more embolic episodes. So important point to consider in this is urgent surgery may be considered, that is not required in case of aortic or mitral infective endocarditis with vegetation more than equal to 10, but without severe valve dysfunction or without clinical evidence of embolism. So initially, in the earlier guidelines, we used to say that if the vegetation more than 10, you have to do surgery, but this is not so in the current guideline. So unless you have an episode of embolic episode, if the vegetation is more than 10, don't go for surgery. Now there is also prophylaxis dilemma. There have been a new addition in the prophylaxis for antibiotic prophylaxis in case of cardiovascular disease undergoing orodental procedure at increases of infective enteritis. So we have learned in the previous guideline that antibiotic prophylaxis should be given for patients who have got previous IE or for surgical implanted prosthetic valve. But in the current guideline, they have also added transcatheter implanted aortic and pulmonary valve, like patient who has undergone TAVI. In those patients also, you have to give infective enteritis prophylaxis. And one more addition is patient who have got ventricular assist device. Those patients also need prophylaxis for infective enteritis. So the antibiotics remain the same as earlier. If the patient is not allergic to penicillin, you give amoxicillin 2 gram orally. If the patient is allergic to penicillin, either you give azithromycin or you give ceftriaxone 1 gram dose. So the take-home message is diagnosis and management of patient with infective enteritis should be discussed with the endocarditis team. It's not a single cardiologist approach. There should be a teamwork. And population at high risk of infective enteritis includes patients with previous IE, surgical or transcatheter prosthetic valve, untreated CHD, and surgically corrected CHD with conduit. Antibiotic prophylaxis for patient at high risk of IE undergoing oral dental procedure is class 1 indication. For all other procedures like endoscopy, bronchoscopy, it's a class 2B indication. Antibiotic treatment of prosthetic valve endocarditis should last longer, usually more than 6 weeks, as compared to the native valve endocarditis. Antibiotic treatment of IE has now 2 phases. First phase initially consists of 2 weeks of IV in-hospital treatment, and second phase, depending on the patient's clinical scenario, if the patient is stable, in selected patients, the antibiotic treatment can be completed within an outpatient parenteral antibiotic therapy or oral antibiotic program for up to 6 weeks. OPAT can only start when a transesophageal echo shows absence of local progression. Antibiotic prophylaxis covering Staphylococcus aureus is very important to be recommended for CID implantation to prevent infective enteritis. And if CID IE is confirmed, complete system extraction without delay is recommended under initial empirical antibiotic therapy. Thank you.
Thank you very much, Dr. Dinanath, for your excellent talk and finishing in time. Our next speaker is Dr. Ashish Sapre, who is going to present first 100 cases of pediatric intervention at IGIC. And he has come from Hyderabad, and he is a very eminent pediatric intensivist and pediatric cardiologist, and has experience of doing more than 200 cases of device closure at Hyderabad. Thank you.
जितने भी हमारे सम्मानित यहाँ पर अतिथि हैं, आपसे एक अनुरोध है कि आपका जो डेलीगेट किट है वो आपको लंच के बाद ही मिल सकता है रजिस्ट्रेशन काउंटर से. It's over to you, sir.
Good afternoon, everybody. First of all, thank you to CSI organizing committee to give me this opportunity to speak on this topic. All the stalwarts of interventional cardiology are sitting here, and I am going to talk on social pediatric cardiology. So I'll try to keep it as short as possible and as interesting as possible, because I know that I am standing between you and your lunch. So actually, I have made 9 visits in last 1 year to IGIC, and I have done some 200 interventions. I am going to share the experience of 100 cases first. To my understanding, is it a small step, or we are looking something at a giant leap or something like that? Let's see. I'll discuss the background of this program first. So this is the classical paper published in Lancet actually. It gives the overall status of congenital heart disease worldwide and comparison between 1990, what was the status, and what was the status in 2017. And then the second paper is published in BMJ. It tells you how to plan pediatric cardiac care centers in a developing world. So I'll go through this. So first we understand what is the burden of the disease. The commonness, it is a commonness birth defect. We all know that it is 1/3 of all the birth defects are congenital heart defects. Roughly around 10 per 1,000 live births have a CHD. But in Lancet study, it has been shown that underdeveloped countries are even having up to 18 per 1,000 live births CHDs. They are multiple factorial. I'm not going into details of that. World will be having approximately 1.35 million babies born with congenital heart disease annually. India, it is approximately 240,000 babies. If we add to the RHD additional, there is a lot of load of this. And then what is there in the Bihar? We don't have any official data on this because no study has been done as such. But as for the rough estimate, it will be around 25 to 30,000 babies are born with congenital heart disease every year. So can we afford to ignore it? Look at this map. This shows what is the distribution of So you can see that it shows what is the proportion of congenital heart disease responsible for the infantile deaths. If there is a blue color, that means it's less than 4% of the infantile deaths are because of the congenital heart disease. If you go higher in the colors range, then the red is more than 13%. And classically, if we look at India is a mixed picture. There are a lot of reasons with the blue color. That means a low percentage of contribution to the infantile death because of congenital heart disease. And if you go toward the south, the little developed states, then you'll see they are reaching up to more than 13-14% of the infantile deaths contributed by the congenital heart disease. And mind you that congenital heart disease complicates your other common causes of the infantile deaths like pneumonias and diarrheas and other malnutrition and everything. Now, it is a global index has been developed. And if we look at this and look at the age-adjusted distribution of congenital heart defects and comparison to what was in 1990 and what is in 2017, you will see that the developed world, the percentage of the common disorders like VSD, ASD is coming down, but in underdeveloped world, it is more or less the same. The complex congenital heart percentage is increasing in the developed world, but it is not increasing in the underdeveloped world. Now, what it means that this is our future. We are going to go from the blue towards the red color. As we'll move from this, because the VSDs, ASDs, PDAs, they will be picked easily, they will be treated easily, then we'll have more and more complex cases, and our contribution to the infantile death will keep on increasing. So that is the background of the care of, this is the same what is reflected in this also. So improvement in the congenital heart disease mortality has lagged behind that of the other causes because of vaccine preventable diseases, diarrhea programs, those deaths have come down, so percentage of the congenital heart disease defect related infantile deaths keeps on increasing. So why is CHD important to our health system? So you can see that CHD is more or less remaining static in the underdeveloped world in first 5 to 8 causes of the infantile death. So we cannot ignore it, definitely. Then compare, this is the disease load, then what is the facilities available? Worldwide, if you look at this, there are one center for pediatric cardiac care at 120,000 population. In Asia, it goes up to 16 million. In Africa, it is 33 million. So we are somewhere between Asia and Africa, right? There is one cardiac surgeon for 3.5 million population in developed world. In Asia, it is 25 million. So there is a lot of gap between the demand and supply. 90% of the babies in underdeveloped world, they don't get the proper care. They are not supported by the proper pediatric cardiac care centers. So this is the summary of what is the healthcare system should be. There are different levels. I'm not going into details of this slide, but I'll tell you that we are somewhere between 3 and 4 stage. We are able to screen, but we are not able to treat them properly. So we are somewhere here. Again, highlighting the same, what infrastructure and this is needed. This is the care continuum for the congenital heart disease. So what we need is a robust recognition program. We have to pick up each and every baby. And who are responsible for that? Right from the pediatricians, delivery centers, community health worker, obstetricians, everybody has to be involved in recognition of this congenital heart disease. Then we have to do a proper diagnosis and prioritization of the management plans. Then we should have a proper referral system. Then stabilization and transport from a secondary centers to the tertiary referral centers. Then we should have a treatment facilities. And then ultimately we should have a robust follow-up program because many of these patients will be having some residual lesions also. So this is the continuum of care. So what are the barriers we are facing in the underdeveloped countries? Is basically recognition. We are not able to diagnose them prenatally, what is Western world is doing. Lack of trained personnel, inconsistent well-child visits, inability to get remote consultation from high-level cardiac facilities, diagnosis. We have poor referral system, registries are not prepared, stabilization. So these are all the barriers why we are lacking. So what is the solution? Let's see light at the end of the tunnel. We have to have some innovative approach. We have to have a double track strategy. We can't wait for the things to happen. We have to make things happen. We have to develop a stepwise approach, coordinated approach for screening, referral, and the management, and focus on developing a local tertiary level PCCs, pediatric cardiac centers. So this is what some was there. I have been involved with this development of this project when I was associated with the Satya Sai Ahmedabad. And there was an initiative made from the Satya Sai Institute, and then they had a lot of discussions with CM, and then personal interests of CM Nitish Kumar ji and his administrative team. They devised this Bal Hriday Yojana, this initiative. So they had a robust screening program. Even pilot project with a digital stethoscope have been done in few districts to pick up even smallest murmurs and suspected congenital heart diseases. Eco-screening camps by experts have done. I have been visiting IGIC since last 3 years, and we have screened thousands of kids with congenital heart disease, and we have given them the plan. So we decided the management plan and referred to higher center for interventions and surgeries. So a lot of cases were done at Satya Sai by me in catheter interventions and our surgical team. So, and follow-up was done at the IGIC. But Is this the solution? Somewhere we have to start in Bihar doing the proper pediatric cardiac program. So we made some initiation with the vision of IGIC director and the whole team. They convinced me that I can come here and do some cardiac interventions, and we started doing in a small way. So it was a good team approach where the pediatricians were involved, the administrative work was there. They were collaborating with the RBSK. A lot of screening was done, and all the patients were got into IGIC. After this, we had a careful selection of the cases, and we decided we are going to do intervention in that. We looked at the infrastructure limitations, human resource limitations, and hardware limitations. And with that, we went ahead with this. So what is our case distribution was there in the first 100 cases. We did some 66 PDA. Initially, we were doing PDAs and ASDs more. Then we started doing VSDs. There is a definitely need for expansion of the scope of these interventions. We have to introduce more interventions. Yeah, there are some technical difficulties. We'll overcome that in next few months. Out of this 66 PDAs, 61 were routine, 5 were tubular. Age was 3 months to 16 years. Weight was 3.5 kg to 43 kgs. We use largest device up to 16, 18 also. So these are the videos of those cases. You can see a small PDA routine one. So whatever interventions we were doing, safety was the first criteria, because if even one untoward incidents happen, that will send a very negative signal in the public. So we wanted to be very safe. Then we started doing all complex cases also. So you can see one tubular PDA here. There are more examples. I am not going into technical details of these cases. We did VSDs, 18 perimembranous, 3 were muscular. Again, you can see the age distribution. We never had a major complication. One patient had a hematoma, which was managed conservatively, and 2 patients had low volume pulses, which was managed with the heparin. Otherwise, our cases were doing all well. These are the VSGs, how I do it. Again, I am not going into details of the technicalities. So these are all the cases we have done. Our percentage of VSD is actually gradually increasing. Different approaches, different methods of deployment of the device. We have done ASDs also. You people do routinely ASDs. We did some catheter assisted where the margins were little deficient. Again, safety was the first priority. Follow-up was done at the IGSE regular interval. No complications have been noticed in the follow-up. One VSD patient had a moderate tricuspid regurgitation, but he's doing fine otherwise. This is the current status of this Bal Hriday Yojana. Already more than 1,000 cases have been dealt with. We have done 198 catheter interventions till our last workshop. So this is the experience. It's all team effort. A lot of efforts have gone in. Case selection, anesthetist team has been trained now, and we are going through this. A lot of awareness has been created in the media, in the public, a lot of positive signals. Now patients are coming and they are telling that we want to get it done, because previously a lot of reservations were there. So because of this success, now this is there. So what is the road ahead? Training of human resources and public and private sector. This kind of programs can be utilized for the training of the health workers, the pediatricians for the echocardiography, because there is a lot of volume is there. They can be taught of timely referrals and the primary management. Even cardiologists can be trained into pediatric echos. They can be trained for the interventions. What we want is basically developing multiple centers of level 4 where we can have a proper management plan screening. Developing at least one center of level 5 where at least basic surgeries and catheter interventions can be done. We have to create a robust funding framework, both in government, public and private, corporate also can come in, and resetting goals. Ultimate goal should be universal screening for the congenital heart disease. Together, we can make, bring many more smiles. Thank you.
Thank you, sir. Thank you very much for your nice talk. Any question? I think questions will be invited in the last. Next speaker is Dr. Anup Singh from Patna. I invite him for the discussion on topic triple therapy of AF patients undergoing PTCA.
Good afternoon. First off, I thanks to all for attending this conference and making it successful. Today my topic is triple therapy in atrial fibrillation patients undergoing PCI. I will discuss about the clinical challenge in a patient during the treatment of suffering with AF with or already undergoing PCI or planning for PCI. Third, thrombotic and bleeding risk factors. Then clinical evidence and what are the landmark trials on the basis of which the guideline recommended. Introduction. Atrial fibrillation is the most common cardiac arrhythmia and it is associated with approx 30% cases of vascular disease. And global prevalence is approx 1 to 3%, and among them 20% of patients need PCI in future. And 80% of patients having atrial fibrillation require anticoagulant therapy because they have more than one stroke risk factor according to the Jacques-Vasto criteria. And the patients who have gone PCI require dual antiplatelet therapy for the prevention of thrombotic complication in coronary artery. So it is very challenged when a patient has already atrial fibrillation and underwent PCI. Antiplatelet therapy can prevent ischemic event in coronary interventions, but it is not good as anticoagulant for prevention of stroke, and just vice versa. For a stroke, anticoagulant is a better option than antiplatelet. So we have to prescribe this drug by balancing the hemorrhagic risk as well as thrombotic risk. Patient with atrial fibrillation and ACS having high risk of coronary events, stent thrombosis, MI, stroke, and that increases the cardiac mortality. So before prescribing this triple combination, it can be dangerous. So always assess the bleeding risk as well as thrombotic risk. For prevention of a stroke and recurrent cardiac ischemia and stent thrombosis, combined antithrombotic therapy is a better option, but at the cost of the hemorrhage, mainly intracranial hemorrhage. So triple thrombotic therapy using dual antiplatelet therapy, mainly ecospin and clopidogrel, along with oral anticoagulant, mainly NOAC, prevent vascular ischemic event, but at the cost of intracranial bleeding. So this is the pictorial presentation. The right side picture shows the patient having a stroke. So oral anticoagulant is a better option than the antiplatelet therapy. And the left one having patient with ischemic, mainly coronary complication, and dual antiplatelet therapy is a better option than anticoagulant in this perspective. So if a patient having both ischemic, cardiac, any cardiovascular problem, or having going for PCI and already on AF, then we should always assess bleeding risk as well as thrombotic risk. These are the very cumbersome, but these are the high bleeding risk criteria.
Left one shows thrombotic risk. If patient having diabetic, history of recurrent MI, peripheral vascular disease, premature escalated coronary artery disease, CKD, these are the main thrombotic risk for a patient. And patient is already on stent, mainly more than 2 to 3 stent, having stenting on bifurcation lesion, left main PCI, and CTO, and history of previous stent thrombosis. These are the high risk factor for the thrombotic risk. And bleeding risk, high bleeding risk is this patient is already on oral anticoagulant, having hemoglobin less than 11, severe thrombocytopenia, bleeding disorders, liver cirrhosis, all are the major risk factor for high bleeding risk criteria. These are the major and minor. I am not going into details. This CHATS has 2 score. It is mainly for assessment of the thrombotic risk factor for a patient. If score is 2 or more than 2 for both male and female, it is considered a high risk and we should start anticoagulant. While 1 for male and 1 for female, score is moderate risk and start anticoagulant. This is has blood score, hypertension, abnormal liver, renal and liver enzyme, stroke, bleeding tendency, labile INR, elderly people, drugs like NSAID and alcohol. If bleeding is, has bleed score is more than 3 or more than 3, it is considered as a high risk score. So before prescribing the anti-thrombotic therapy, mainly triple anti-thrombotic therapy, we should always assess the bleeding risk as well as thrombotic risk. What landmark trials result? These are the few landmark trials like WASH trials, Pioneer, AFPCI, Redual PCI, Augustus trial. All goes in favor of double therapy in comparison to the triple therapy. Always triple thrombotic therapy is a better option for prevention of ischemia, but at the cost of intracranial hemorrhage. So all the major trial goes in favor of dual antiplatelet therapy. And also the study has been done on elderly population, and that elderly population having also get more benefit with triple antithrombotic therapy, but at the cost of again intracranial hemorrhage. So finally, guideline, European guideline in 2020 published that if patient having ACS and already having AF and underwent PCI without any complication, then for first week, 1 week, start triple antithrombotic therapy in the form of oral anticoagulant plus ecosprin plus clopidogrel. After that, up to 12 months, continue clopidogrel plus oral anticoagulant. But in a patient with ACS having high risk of PCI, previous history of stent thrombosis of high clot burden, you can extend the triple antithrombotic therapy for 1 month also. After that, 1 month to 12 months, continue dual therapy with clopidogrel plus oral anticoagulant, and after 12 months, continue only oral anticoagulant. And second one is if patient having already chronic coronary syndrome, chronic stable angina patient having PCI, then first 1 week continue triple antithrombotic therapy, ecosprin, clopidogrel plus oral anticoagulant. But after 1 week to 6 months, only 1 week to 6 months, clopidogrel plus oral anticoagulant. And after 6 months, continue only oral anticoagulant. And same patient, if having high risk of stent thrombosis, high clot burden, triple antithrombotic therapy can be continued up to 1 month, and after 1 month to 6 months, clopidogrel plus oral anticoagulant, and after that only oral anticoagulant. This is the same. In 2020 European guideline, this is the chart which shows that by default, a patient having AF with PCI, by default, start triple therapy for 1 week. Aspirin, clopidogrel plus oral anticoagulant, mainly NOAC. NOAC has better safety profile than the vitamin K antagonist like warfarin. So first 1 week first 1 week with triple antithrombotic therapy, and after 1 week to 1 year up to 12 months, dual therapy, mainly stop the ecospin, continue with clopidogrel plus NOAC, and after 12 months continue only oral anticoagulant. But if a patient having high bleeding risk, so in this case the duration of triple antithrombotic therapy should same 1 week, but dual therapy should be cut down up to 6 months, and after 6 months only oral anticoagulant, shift to only oral anticoagulant. But third subset of patient, if patient having high ischemic risk, then continue antithrombotic therapy for 1 month in spite of 1 week. Then after 1 month continue clopidogrel plus oral anticoagulant for 12 months, and after 12 months continue oral anticoagulant only. This is the same American guideline, and this data shows that initially there was charm for triple antithrombotic therapy, but gradually it was seen that there is more, patient was more suffering with hemorrhagic complication. Then gradually guidelines shifted from triple antithrombotic therapy to dual therapy, and data also shows the safety of the dual antiplatelet therapy in this condition. So what was the final verdict? Compared with triple antithrombotic therapy, NOAC-based dual antithrombotic therapy is associated with lesser chance of bleeding, and triple antithrombotic therapy after a stent is appropriate for at least 14 days, maximum up to 30 days. So default strategy is continue antithrombotic therapy, triple antithrombotic therapy for 14 days with aspirin and clopidogrel plus NOAC. After 14 days to 1 year, 1 antiplatelet clopidogrel plus NOAC, and after 1 year continue only NOAC. So summary is arterial fibrillation with coronary artery disease often coexist and require a combination of anticoagulant and antiplatelet therapy after assessing the thrombotic and bleeding risk. And several subset of patient having high risk of ischemic and bleeding complication, like elderly, patient with CKD, patient is on already or anticoagulant. So we have to judge, we have to prescribe these 3 drugs by balancing the, we can also extend after 1 month, depend on the personal decision. And the dual therapy is considered a standard strategy. However, triple therapy can also be extended up to variable 1 to 6 months according to the patient profile. And now further evidence need to investigate new strategy for directed improving outcome of patient going PCI. Thank you.
Dr. Sumit Kumar is an intervention cardiologist practicing in Begusarai. Recently, he had organized one conference of RSDDI, CCDSI, which viewed great success.
Thank you, sir.
Thank you for coming, Sumit. Please deliver your.
Thank you, sir. Good afternoon, everyone. Respected chairpersons, teachers, seniors, and my colleague. My topic is ECG marker of sudden cardiac death, and I think this topic has been chosen just because of the low cost EG availability. But the problem is the proper assessment of ECG, because as we know, no test is completely accurate to say the risk of sudden cardiac death. But even if we touch the approx line, then it will be great benefit for the mankind, because we can treat the, we can
intervene the risk of sudden cardiac death if at right time. So by definition, it is unexpected natural death of cardiac cause, and that occurs 1 hour from the onset of symptoms. If we look for the epidemiology, it is the overall incidence is 0.1 to 0.2% per year, but the data from Framingham study shows there is decrease in sudden cardiac death over the past 50 years by 50%. And it is just because the proper management, including lipid lowering therapy, blood pressure control, use of aspirin, ICD, and no doubt by improved CPR function. The ratio of male to female is 4:1, age of the data is 45 to 75 years. Most of the event occurs in the early morning hour, but there are some exception in the sleep apnea. The events may occur nocturnally. 2/3 of the events occur during the physical inactivity of the patient. If we look for the anatomical and functional substrate and the disease burden, the coronary artery disease is the most common cause leading to sudden cardiac death. Apart from that, cardiomyopathies, primary electrical disorder, valvular heart disease, and others disease also leads to sudden cardiac death. If we talk for the myocardial substrate, it is the fibrosis, myocardium fibrosis, hypertrophy, ion channel dysfunction, and abnormal calcium handling can provide the substrate. If we look for the triggering event, then it is the heart failure, ischemia, myocardial inflammation, sympathetic innervation abnormality, and electrolyte disturbance. If we look for the predisposing factors and risk, then the repolarization abnormalities, parasympathetic nerve dysfunction, comorbidities like diabetes and renal dysfunction. If we look for the mechanism, then it is the asystole, re-entry, automaticity, triggered activity, block to cell uncoupling are the events. There has been shifting, paradigm shift from the mechanism. The VT and VF, that is even the most of the events occurred by this activity, but there is shifting from the VT, VF to increase in bradyarrhythmia and pulseless event. So the ECG for risk stratification, it has been divided as a repolarization disorder or depolarization disorder. And the repolarization disorder, QT interval or electric systole, it either in the form of prolonged or short QT interval, prolonged JT interval, prolonged QT dispersion, infralateral early repolarization or J-wave syndrome, in the form of interval from T peak to T in time, T peak to T in time with QT ratio, macrowave T wave or microwave T wave alternance. In form of depolarization disorder, there is a prolongation of QRS duration, QRS prolongation in different leads, presence of S wave in the form of more than 40 millisecond and of voltage 0.1 millivolt in lead 1. QRS dispersion, narrow and wide QRS fragmentation, epsilon waves, etc. I'm just trying to show some examples in the form of QT interval. If QT interval in case of male, it is more than 470, and in female, more than 480 is a risk marker for sudden cardiac arrest. In case of shortening, less than 330 in male and less than 340 in female is a risk marker for the sudden cardiac arrest. Here we can see how the QT interval can be calculated. Is the first Q appearance in the ECG leading to end of T wave, and end of T wave can be assessed by putting a tangential line over the maximum slope of T wave touching the isoelectric baseline. Sometimes QT interval, actually it includes both depolarization and repolarization. So in case of wide QRS or some W syndrome, QT interval are not accurate. So in that case, JT intervals are more accurate, and that can be calculated from the J point to end of T wave. It can also indirectly be derived by subtracting QRS interval with QTC interval.
So JT interval, its frame is 330 to 400, and it helps for the in that group of patients, even on long QT syndrome where baseline QT intervals are normal, JT interval will be more helpful for assessing the risk. Early repolarization variants, these are the 4 types with ST elevation, J point or J wave notching, or without ST elevation, there is a J point or with J notched. The best part is it has both benign type and malignant type. I am showing one example of benign early repolarization for a patient of 24-year-old African American professional basketball player. There is a J point elevation and early depolarization in anterior leads. Inferior leads are spared. The best part is if inferior leads are involved, then it is the better predictor for sudden cardiac death risk. The another example is malignant early repolarization pattern in a patient with having J early repolarization, both inferior and anterior leads. These are the predictor for the malignant arrhythmia. Here there is a T peak to T end time. T peak to T end time is actually the transmural repolarization time of ventricles, showing in case of inflammation, myocardial fibrosis, there is increase in timing from T peak to T end. And if it is more than 100 milliseconds in post-MI patient, it is a better predictor for early malignant arrhythmia apart from the ejection fraction. So this is, in this ECG, there is T-wave alternance. It is macro-wave T-wave alternance. There is change in amplitude and voltage. It has been artificially generated by stimulating left stellate ganglia in a patient of long QT syndrome. And this sign predicts the chances of malignant arrhythmia. This is a QRS duration. Yes, QRS duration has also some relations for the predictability of sudden cardiac death. In post-MI patient or in case of heart failure patient, there is conflicting reports. Though the patients are kept in 2 different arms, one on ICD management and one in medical management. The report says the QRS duration in more than 140 milliseconds, the patients in the group of medically managed have more chance of sudden cardiac death in comparison to patient kept on the ICD group. Or some other, in case of even this ECG shows in Brugada syndrome patient, prolongation of QRS is independent risk factor for the predictability of sudden cardiac death. This ECG shows the differential QRS duration. Differential QRS duration in V1 lead to V6 lead. If the QRS duration in V1 to V3 divided by V4 to V6 is more than 1.2, then it is a very sensitive and a specific marker for diagnosis of ARVD. This is a presence of deep S wave in lead 1 more than 45 or 50 milliseconds, and in case of atrial fibrillation, if this is seen, then it is a predictor for the malignant arrhythmia. Here we can see in this ECG there is multiple markers in the same ECG in the form of fragmented QRS, wide QRS, and presence of J wave. This combination are more lethal when present individually, and chances of malignant events are maximum in this group of patients. One more thing is Holter monitoring. Holter monitoring basically we do for heart rhythm, frequency of ectopic, average heart rate, and heart rate range over time. So in case of patient, if there is, on Holter there is a non-sustained BT, in the absence of background of structural heart disease, that prognosis may be benign, but in the case of presence of structural heart disease, then it will be malignant. Presence of a polymorphic non-sustained BT, whether a structural heart disease present or not, it is a predictor that the patient is has higher risk of sudden cardiac death. So combining overall, the key messages are almost half of sudden cardiac death victims do not have previously diagnosed heart disease, and with sudden cardiac death being the first manifestation of underlying condition, current risk stratification tools are insufficient and at predicting the majority of sudden cardiac death. Combining known sudden cardiac death risk markers may improve the risk stratification. The presence of multiple ECG abnormalities are associated with increased sudden cardiac risk in general population. And last, better sudden cardiac death risk stratification in the general population could identify subjects with high sudden cardiac risk and potentially improve sudden cardiac death in these subjects. Thank you.
So if there is no question, the session is concluded. Thank you.
I would request all the respected chairperson to felicitate our speakers, our wonderful speakers. So this is the last session of 2-day long seminar. So I request you all kindly a huge round of applause for all respected chairperson and all the eminent speakers across from nation. Since this is the valedictory session, for that I would like to request Dr. Sunil Kumar, sir, I request you to join us for this valedictory session. For this moment, Dr. K.K. Barun, sir, Dr. K.K. Barun, Dr. A.K. Thakur, sir, Dr. Anup Singh, Dr. Arvind Kumar, Dr. UN Singh, Dr. Sanjeev Kumar, and Dr. B.K. Singh.
Again, please, all delegates are requested, please stay back. This is very important part of the conference, validity functions. Basically, it is a Thanksgiving. So, I invite Dr. Sunil Kumar, our chairman reception committee, Dr. K.K. Varun, our chairman organizing committee, Dr. Anil Thakur, chairman scientific committee, Dr. Anup Singh, a very young, energetic, excellent, Dr. Anup Singh, our organizing secretary, Dr. UN Singh, secretary CSI Bihar chapter, and Sanjeev Kumar is a man behind the screen. No title, no words can be given to Sanjeev Kumar, always man behind the screen. And Dr. B.K. Singh, our HOD Pediatrics, IGIC, is he there? Okay, no. So I would request, hand over mic to Dr. Sunil Kumar to say a few words and because first of all, I must, from my side, as a CSI Bihar chapter president, I must congratulate each and every person of IGIC team for making this conference is a great success. And it is one of the best conference I have ever seen. Especially my, doctor, my बड़े भाई Dr. Sunil Kumar, I congratulate him. एकदम बहुत कम शब्दों में बोल कर शांत रह के इन्होंने सारी जो व्यवस्था जुटाई है उसके बहुत काबिल तारीफ है। वरुण सर अभी भी बिजी हैं, अभी भी देखिए कॉन्फ्रेंस का काम कर रहे हैं बाहर में, सभी गेस्ट को हैंडल कर रहे हैं, उनको स्पेशल थैंक्स, उन्होंने बहुत छोटी छोटी बातों पर ध्यान दिया। अनिल ठाकुर जी ने जो साइंटिफिक प्रोग्राम बनाने में हेल्प किया है बहुत काबिल तारीफ है। अगेन आपको बहुत बहुत धन्यवाद CSI की तरफ से। एंड संजीव जी, आप तो, आपके बिना तो कॉन्फ्रेंस हो नहीं सकता है, आप नाराज होइए जो होइए। एंड UN सिंह हम लोग के जो CSI के सेक्रेटरी हैं, इन्होंने काफ़ी योगदान दिया है। और सबसे ज़्यादा लो लास्ट में है अनूप सिंह, अल्टीमेटली ऑर्गेनाइजिंग सेक्रेटरी पर ही सारा बोझ, गाली भी उन्हीं को सुनना पड़ता है, तारीफ भी उन्हीं की होती है। नाउ आई हैंड ओवर माइक टू Dr. Sunil Kumar to say a few words.
प्रोग्राम तो खैर सक्सेसफुल हुआ, उसमें छोटे भाई अरविंद जी, वरुण बाबू, UN सिंह, अनूप जी, अनिल ठाकुर जी, सबको पूरा IGIC लगा हुआ था, संजीव बाबू लगे हुए थे, हर आदमी लगा हुआ था और बहुत बढ़िया हुआ प्रोग्राम। अब इससे बढ़िया तो कोई नेशनल प्रोग्राम हो सकता है, सब लोग यही बोल रहे थे।
धन्यवाद सर। डॉक्टर अनिल ठाकुर जी, आप हमारे चेयरमैन साइंटिफिक कमेटी रहे हैं, एक शब्द आप भी। इतने लोग जो आए, गेस्ट स्पीकर्स उन्होंने बहुत अच्छा,
ये काफ़ी अच्छा रहा स्पीकर्स का बाहर से आना, लोकल स्पीकर्स का सिलेक्शन, और सभी स्पीकर्स काफ़ी अच्छे, और हम लोगों ने परिश्रम किया और ये एक काफ़ी सफल इसको कहा जाए, सफल आयोजन रहा। आशा करते हैं भविष्य में हम लोग मिलकर ऐसा आगे भी करते रहेंगे। धन्यवाद।
डॉक्टर UN सिंह, आवर स्टेट चैप्टर सेक्रेटरी।
Thank you all distinguished faculties, खासकर particularly those who came from all the way from Hyderabad. Dr. Ashish Sapre is sitting here, and our national president, Dr. Vijay Bank, he is not here, and other faculties, and also different people or HOD from IGIMS, and of course, there is no, I am not finding any word to mention the whole IGIC team in the leadership of our dynamic chairman, Dr. Sunil Kumar, along with Dr. A.K. Thakur sir, organizing secretary Anup Singh sir, as well as our Dr. Sanjeev sir from the AIMS, who all are doing very in a teamwork and has led to very great success for the conference. I wish the CSI will be do a even better conference in the near future. Thank you.
Dr. Sanjeev, please come.
थैंक यू अरविंद। CSI बिहार चैप्टर अब नई ऊंचाइयों की ओर जा रहा है, और एज ए कार्डियक सर्जन हम लोग की तो आदत है कि कार्डियोलॉजिस्ट की बात को फॉलो करो, जो आप ऑर्डर देते हैं हम लोग करते हैं। तो इस कॉन्फ्रेंस में भी आप लोगों ने बहुत अच्छा ऑर्गेनाइज किया, और बड़ा समन्वय है पूरे बिहार में कार्डियक सर्जन्स और कार्डियोलॉजिस्ट का। ऐसा हेल्दी रिलेशनशिप बहुत कम देखने को मिलता है, और जो अरविंद हमारे फ्रेंड प्रेसिडेंट बने हैं, उनके मार्गदर्शन में इंदिरा गांधी इंस्टीट्यूट ऑफ कार्डियोलॉजी, डॉक्टर सुनील कुमार और डॉक्टर के बुरुन के मार्गदर्शन में इतना अच्छा कॉन्फ्रेंस कराया। बहुत कुछ सीखने को हम लोग को मिला, और मैं उम्मीद करता हूं कि आप लोगों ने, जिन लोगों ने भी पार्टिसिपेट किया, कुछ ना कुछ टेक होम मैसेज हर एक लेक्चर से आपको मिला होगा। आगे भी आप कोई भी एकेडमिक प्रोग्राम करेंगे, हम लोग हमेशा साथ रहेंगे। थैंक यू वेरी मच पूरी टीम को, खासकर ऑर्गेनाइजिंग सेक्रेटरी अनूप को, और बिहार स्टेट कार्डियोलॉजी सोसाइटी के सभी ऑफिस बीयर्स को 3 cheers.
Thank you, Sanjeev. Before coming, inviting our organizing secretary of Cardiac 23, I would like to invite you, any of you, if you want to say something, few words, please welcome. आप लोग आए, आप लोगों को क्या तकलीफ हुई, क्या आप लोगों ने इसमें आनंद उठाया, anything if you want to express, you are most welcome. Otherwise, I invite our Sapre Shahab. So, we are so much, indebted to you. You have come from and you have spared your valuable time. So, if you want to say.
Nothing. I love academic sessions, sharing knowledge and getting more knowledge. It was very well organized. I feel very sorry that yesterday I could not come and attend the session, but the scientific committee adjusted my lecture today and somehow I could deliver that. So thank you. It was very well organized, must say. Thank you.
Dr. Agarwal sir. सुषमा उसके बाद. आइए अनूप, आ जाओ, खड़े हो जाओ.
हेलो.
आप बोलिए. नहीं आप बोलिए, वहीं से बोलिए.
First time I have seen that every academic session was excellent. Yesterday to today, I have heard all the sessions very carefully. Everything was excellent. Thanks to organizing committee. I have given thanks to all the organizing committee.
थैंक यू सर, आपने मुझे मौका दिया बोलने का. मैं बहुत तहे दिल से शुक्रिया अदा करती हूँ अपने निदेशक महोदय और सभी चिकित्सकगण, सोसाइटी के और हम लोग कमेटी के जो भी हैं, और स्पेशली हमारे आईजीआईसी के डॉक्टर्स एंड अदर देन आईजीआईसी ऑल्सो. ये प्रोग्राम हम लोग का बहुत सक्सेसफुल रहा. कभी ऐसा नहीं हुआ कि हॉल में भीड़ नहीं दिखी, और जब मुख्यमंत्री जी आ गए तो वो 4 चांद लगा हमारे कार्यक्रम में. ये सारी मेहनतें हम लोग निदेशक महोदय के अंतर्गत हम लोग उनके मार्गदर्शन में किए, और बहुत अच्छा लगा और बहुत प्राउड फील होता है कि ऐसे आईजीआईसी संस्थान में हम तो इतने सालों से काम कर रहे हैं, और हमारे निदेशक अभी जो आए हैं हम लोगों को इतना भाव देते हैं. काम तो सभी लेते थे, बट अभी हम लोग को जो स्पेशल मिलता है उसके लिए स्पेशल थैंक्स टू ऑल ऑफ यू सर.
मैं सबसे पहले ऑर्गेनाइजिंग कमेटी को बहुत बहुत कंग्रेचुलेट करना चाहती हूँ. बहुत ही वेल ऑर्गेनाइज्ड ये प्रोग्राम था. सब कुछ टाइम से और अप्रोप्रिएटली हुआ, और इतने ही शॉर्ट टाइम में स्पीकर्स को अरेंज किया, और हमारे लोकल फॉर वोकल जो स्लोगन था उसको फॉलो किया. एंड स्पेशल थैंक्स टू आवर डायरेक्टर सर, जिनकी गाइडेंस में हम लोगों ने सबने काम किया. और थैंक्स टू डॉक्टर अनूप, जिनका आई थिंक काफ़ी कंट्रीब्यूशन था इसमें. एंड थैंक यू एवरीबॉडी.
डॉक्टर उमा शंकर प्रसाद सर, हमारे टीचर, एक्स HOD NMCH. आप हमेशा सर कॉन्फ्रेंस में आते हैं, 8-9 बजे से शाम 6 बजे तक रहते हैं. मैंने ऐसे टीचर्स को फुल टाइम. सर आपका आशीर्वाद बहुत ज़रूरी है. 2 मिनट बोले सर.
सबसे पहले तो my heartfelt congratulations to all the members of the organizing team, particularly Dr. Sunil Kumar, Dr. Arvind Kumar, the organizing secretary. So मिला जुला के जो कॉन्फ्रेंस था काफ़ी इम्पॉर्टेंट एस्पेक्ट्स को कवर किया गया, जो कि एक जनरल फिजिशियन के लिए और ख़ास करके कार्डियोलॉजिस्ट के लिए तो ये कॉन्फ्रेंस है. सो I feel that next year will be same. Thank you very much for inviting me, and I have learnt a lot from this 2 days conference. Thank you very much.
थैंक यू सर। मैं अब आग्रह करूंगा पीएमसीएच की तरफ से डॉक्टर समरेंद्र झा कुछ बोलें और आईजीएमएस की तरफ से डॉक्टर रवि विष्णु प्रसाद। प्लीज़ रवि विष्णु प्रसाद जी।
धन्यवाद अरविंद बुलाने के लिए। वैसे तो मैं हर साल ये कार्डिकॉन बहुत शिद्दत से अटेंड किया करता हूँ और हर वर्ष सीखते रहा हूँ, इस बार भी सीखा। लेकिन इस बार का कार्डिकॉन मेरे लिए कुछ अलग टाइप का इसलिए है कि हर विद्यार्थी के जीवन में जब वो मेडिकल कॉलेज में रहता है तो एक पीयर ग्रुप होता है। तो मैं जब पीजी कर रहा था तो सुनील बॉस हमारे पीयर ग्रुप में से थे, हमसे 2 साल सीनियर थे सेम यूनिट में, और अरविंद भी उसी में बाद में आया था। मुझे आंतरिक खुशी, बहुत आह्लाद हुआ इस कॉन्फ्रेंस में शिरकत करके, और मैं अपने पुराने दिनों में मानो वापस आ गया। धन्यवाद।
आप सिर्फ एचओडी नहीं हैं आईजीएमएस के, हमारे बिहार जर्नल ऑफ कार्डियोलॉजी के एडिटर हैं, और आप जो काम कर रहे हैं जर्नल पब्लिकेशन में काबिल तारीफ है।
धन्यवाद सर। सबसे पहले मैं ऑर्गेनाइजिंग कमेटी के जितने मेंबर्स हैं, सुनील सर के गाइडेंस में जितने लोग थे, उन्होंने इतने शॉर्ट टर्म में बहुत अच्छा कॉन्फ्रेंस किया, और जो साइंटिफिक कमेटी जो AK झा सर ने बनाया था उसमें सारे टॉपिक कवर किए। फ्रॉम बेसिक्स, मैं शुरू से ही था, फ्रॉम बेसिक टू सडन कार्डियक डेथ जो भी सब कवर किया, इवन इंटरवेंशन का भी सारा वो था। बहुत अच्छा प्रोग्राम कॉन्फ्रेंस था ये, और आगे भी ऐसे ये कॉन्फ्रेंस होते रहेंगे, और मैं एक बार फिर से ऑर्गेनाइजिंग कमेटी को धन्यवाद देता हूँ। थैंक यू।
हाँ सर, आप सर, आप लोग में और भी कोई अपने मन का उद्गार व्यक्त करना चाहें तो अशोक जी हमारे ट्रेजरर हैं, बिना खजाने के कुछ नहीं होता है।
और हमारा धन अरविंद सर है। तो अब जैसे कि ये कार्डियोलॉजिस्ट हम लोगों के लिए एक अपने घर का फंक्शन जैसा होता है, तो हमारा इन्वॉल्वमेंट तो अलग लेवल पे है, लेकिन इतने कम समय में, क्योंकि जैसा कुछ चेंज हुआ था नियम NMC का, उसके चलते पोस्टपोन किया गया, फिर सडनली इतने शॉर्ट टाइम में करने के लिए हमें नहीं लगता है कि कोई तैयार था। लेकिन लकीली उस दिन मीटिंग में सुनील सर आए हुए थे, और इन्होंने बेड़ा उठा लिया है कि कोई करे ना करे हम करेंगे, IGIC करेगी, और इस सोसाइटी को रीऑर्गेनाइज किया। ऑर्गेनाइजिंग सेक्रेटरी का भार अनूप सिंह को दिया गया। अनूप हमारे बहुत अच्छे मित्र हैं, मैं ही उनको कहने वाला हूँ रे होगा तो अनूप का कहना है कि भाई अब होगा तो होगा, नहीं होगा तो क्या करेंगे, लेकिन करना है तो करना है। सुनील सर बोले हैं तो हम लोग अच्छे से करेंगे। इसमें अगर कहा जाए तो लेवल ऑफ एनर्जी सबसे हाई अगर किसी का था तो अरविंद सर का। अभी हमारे अध्यक्ष हैं बिहार चैप्टर CSI पटना के, एग्जीक्यूटिव कमेटी नेशनल के भी एग्जीक्यूटिव कमेटी में हैं सर, और हर चीज़ बहुत ऐसा चीज़ जिसको आप नहीं जान रहे हैं, सब किया धरा इनका है, भले नाम किसी और का इन्होंने दे दिया है, तो A to Z हर चीज़ करके इन्होंने किया है। और आप जो नयापन देखे साइंटिफिक कमेटी में, वो देन जाता है AK ठाकुर सर का, अनिल सर का। उन्होंने सारा ये जो नयापन था साइंटिफिक प्रोग्राम में, और जो इतने ढंग से आया, आप कंपेयर करेंगे तो थोड़ा डिफरेंट था। इस बार की टॉपिक चेंज करने में उनका बहुत बड़ा योगदान था। और कोई भी कॉन्फ्रेंस कार्डियोलॉजी का या कोई भी मीटिंग, इवन छोटी मीटिंग भी होती है तो संजीव सर के बिना नहीं संभव है। तो उनका मार्गदर्शन और उनके प्रेजेंस के बिना ये हो नहीं सकता है। और सबसे अहम है योगदान जो लोग आते हैं, जो पार्टिसिपेट करते हैं, जो स्पीकर हैं, जो लिसनर हैं, जो चेयरपर्सन हैं, फार्मा पीपल हैं, इन लोगों का सब मिला जुला के इतने अच्छे ढंग से इतने कम समय में ऑर्गेनाइज हुआ कि हम लोग आह्लादित हैं कि अगले बार और अच्छा करेंगे। अभी प्रेजेंट सेक्रेटरी हमारे उपेंद्र बाबू हैं, और इन्होंने जब से कार्यभार ग्रहण किया है सेक्रेटरी का CSI का, उस समय से इन्होंने और अरविंद सर ने
एक नई ऊर्जा के साथ काम शुरू किया है। करते ही इन्होंने CPR की मीटिंग कराई ऑडिटोरियम में, और कई तरह की एक्टिविटी, महीने में 2 मीटिंग कर रहे हैं। हम सब आप लोगों से अनुरोध करेंगे कि हर मीटिंग में आप लोग पार्टिसिपेट करें और अपना भी सुझाव दे सकते हैं। मैं ट्रेजरर हूँ, इन लोगों के अंडर मार्गदर्शन में काम करूँगा। धन्यवाद।
हमारे सामने बहुत अच्छे प्रवक्ता हैं डॉक्टर AK आशु साहब, 2 शब्द बोलिए। आपकी वाणी और भाषा में एक आकर्षण होता है।
I mean, I got the privilege to speak from this podium, and thank you very much to the organizer, and particularly our director, Dr. Sunil Kumar, has proven so dynamic. He has been so dynamic throughout his directorship. We are completely unaware of his leadership prowess that he has shown during the recent time, and I am simply awed by his potential. Dr. Sunil Kumar has taken the institute to a height that has been in the glare of the whole fraternity of the cardiologists, bigwigs, even the bigwigs, you know, right from our Honorable CM, and who not. Everybody has recognized Indira Gandhi Institute of Cardiology as the seat of performance in the field of cardiology, which has escalated over the period of 2-3 years so much that RBSK program, Bal Hriday Yojana has been the glare of media as well, and is not a big thing to be in the glare of media, but we have successfully performed to the benefit of general people in grief, and you need to come to IGIC to look at the faces of relieved parents who have been relieved of the plight of their children, amounting to I think not less than 1,000 children has been, salvaged by RBSK and Bal Hriday Yojana, the dream concept of our CM. Let me tell you, I'm not directly associated with Cardiological Society of India anyway, but all of you have given me the privilege and opportunity to speak from this podium. Thank you very much. Thank you so much, Director Sahab, Dr. Sunil Kumar, Dr. Anup Singh, the organizing secretary. I'm not seeing Dr. KK Barun. He is busy. Thank you. And Dr. Arvind Kumar, everybody is on the dais. Thank you very much.
Thank you, Ashuji. My request, Dr. Rajiv Ranjan ji, a senior physician from Chapra. He has always been very active in academic activities, and has been a successful organizer of so many conferences at Chapra. Please say a few words,
Thank you, sir. मैं समझता हूँ एक कॉन्फ्रेंस ऑर्गेनाइज करना कितना मुश्किल काम होता है, और मैं पेरीफेरी में वर्क करता हूँ जहाँ पे ऑल इन वन होना पड़ता है। वहाँ लर्निंग का कितना महत्व है। मैं जो भी चीज़ें यहाँ से सीख के जाता हूँ उसका कितना बेनिफिट होता है, ये हमसे अच्छा बहुत कम लोग समझते होंगे। और मैं बहुत लेट आया आज, उसके लिए हमको खुद अच्छा नहीं लग रहा, लेकिन फिर भी मैं बहुत कुछ लेके जा रहा हूँ। इसके लिए पूरे ऑर्गेनाइजिंग टीम को धन्यवाद देता हूँ, हृदय से धन्यवाद देता हूँ।
डॉक्टर वीरेंद्र जी फ्रॉम भागलपुर, आप भी 2 शब्द बोलिए।
First of all, thank you CSI Bihar chapter for organizing such a beautiful loads and loads of information about cardiology and associated specialty. Most important thing which happened in this CSI, Cardicon, is to have so many of indigenous son of soil speakers, young cardiologists emerging good at the work and good at the academics also. This shows that the golden era of cardiology has begun in Bihar, and we hope that every transition transmits to the each and every district town of Bihar. Being a intervention cardiologist at the district level actually brings lots of challenge to you, and these challenges makes you evolve over a period of time. Hopefully, I feel very energized and hopeful about the growth and development of cardiology in Bihar. Thank you, Cardicon. Thank you, CSI.
अगर आप में से और कोई बोलना चाहे, मोस्ट वेलकम। नहीं तो मैं अंत में अपने, आपके एम्स के कोई हैं? एम्स पटना के कोई हमारे माननीय अतिथिगण? मेदांता से कोई हैं? मेदांता पटना से? मैं यहाँ से देख नहीं पा रहा हूँ, सॉरी। इसलिए अगर कोई हैं तो प्लीज़ कम एंड ब्लेस अस। नहीं तो मैं अपने ऑर्गेनाइजिंग सेक्रेटरी कार्डिकॉन 2023 के श्री अनूप सिंह जी को बुलाता हूँ। तहे दिल से उनको धन्यवाद देता हूँ। आप जो भी कहेंगे हम सब लोग के लिए एक इस कॉन्फ्रेंस की ऊंचाइयों को छुएंगे आप।
थैंक यू सर। सबसे पहले आपने मुझे डॉक्टर से श्री बना दिया, पहले तो डॉक्टर रहे नहीं। ऐसा लग रहा है कि जैसे 1 महीने से अपनी बेटी के शादी में बिजी था। और वरुण सर भी अभी तो उधर ही एक्टिव हैं, इधर आए नहीं हैं। मुझे विश्वास नहीं हो रहा है कि ये प्रोग्राम सक्सेस हो गया 2 दिन में। 2 दिनों का 1.5 दिनों 1.5 डेज़ का जो प्रोग्राम था वो सक्सेस हो गया। और मैं तहे दिल से शुक्रगुजार हूँ पूरी IGIC टीम का, स्पेशली डायरेक्टर सर और डॉक्टर के वरुण सर का, जिन्होंने इतना सपोर्ट किया। और IGIC के तमाम डॉक्टर, इवन नर्सिंग स्टाफ से लेके जितने भी और भी स्टाफ थे, सभी लोगों ने मेरा सहयोग दिया। इसके बाद और मैंने कोशिश किया कि जितने भी हमारे बिहार में पेरिफेरी में भी जो भी सुपर स्पेशलाइज्ड डॉक्टर हैं उनको इन्वॉल्व करूं। और मैंने भरपूर कोशिश की, वोकल फॉर लोकल करने की कोशिश की मैंने, क्योंकि बाहर से भी हम लोग कुछ स्पीकर को लाए थे, लेकिन 10 साल पहले इतने हमारे यहाँ सुपर स्पेशलाइज्ड डॉक्टर नहीं थे। मैंने हर डिस्ट्रिक्ट से कोशिश की, बेगूसराय, पूर्णिया, भागलपुर, गया, दरभंगा, मैंने कोशिश की जितने से जितने हमारे सुपर स्पेशलाइज्ड डॉक्टर आएँ और यहाँ बोले। ऐसे भी मुलाकात तो बहुत कम होती है उन लोगों से, सभी अपने अपने प्रैक्टिस में बिजी रहते हैं। यही एक फोरम है जहाँ हम लोग मिलते भी हैं, अपने सुख दुख का आदान प्रदान करते हैं और भी जो भी है पुरानी यादों को ताज़ा करते हैं। और मैं उन लोगों को का भी शुक्रगुजार हूँ जो डॉक्टर आए यहाँ अटेंड किए, उन्होंने आशीर्वाद दिया। मैंने पर्सनली कोशिश की सभी डॉक्टर को फ़ोन करूँ, मैंने किया भी, जिनसे बात हुई, जिनको मैं नहीं जानता था मैं उनको भी मैं यहाँ उनको आमंत्रित किया हूँ, वो आए भी हैं सर। और सबसे लास्ट में मैं ये बोलना चाहूँगा, ये कॉन्फ्रेंस विदाउट फार्मा कंपनी के सपोर्ट से नहीं होता। मैं फार्मा कंपनीज का नाम तो नहीं लूँगा, लेकिन सभी लोग जानते हैं कौन कौन से फार्मा कंपनी कितना सपोर्ट किए हैं। मैं उनका भी मैंने नहीं बोल सकता हूँ कितना मैं उनका थैंकफुल हूँ। और लास्ट में थैंक यू, और हर साल उम्मीद करता हूँ कि इस तरह का कॉन्फ्रेंस हो। और इस कॉन्फ्रेंस के कवरेज के लिए हमारे जो प्रेस मीडिया भाई लोग हैं उनको भी मैं थैंक यू देता हूं। और मैं चाहूँगा कि इस कॉन्फ्रेंस के बारे में जो जो अच्छी अच्छी बातें हुई हैं, जो भी चिकित्सा से रिलेटेड जो भी हम लोग नया जो भी ट्रीटमेंट हम लोगों ने बताया है उसको मीडिया में कवरेज दें ताकि पेरिफेरी में भी लोग इसे जान सकें। धन्यवाद। और ये होटल में जो भी स्टाफ लोग हैं, मौर्या के स्टाफ जो हम लोग के बाहर भी अभी वहाँ हैं कुछ भाई लोग जो हम लोग को सर्व कर रहे हैं, उनको भी मैं धन्यवाद देता हूँ। थैंक यू।
थैंक यू अनूप। आप लोग जाइएगा नहीं, अब एक और छोटी सी फॉर्मेलिटी बच गई है। कॉन्फ्रेंस का हो गया, वैलिडिटी फंक्शन, एक जीबी मीटिंग हम लोग कर रहे हैं, बस 5 मिनट लगेगा, एक दो इशू है। तो मैं आग्रह करूंगा रवि विष्णु जी आप कृपया ज्वाइन करें हमारे जो भी जीबी मीटिंग पे हमारे सीएसआई के जो ऑफिस बीरर हैं। हाँ, आप लोग सब बैठे हैं प्लीज़ सर।
एक सेकेंड सर, मैं इंटरप्ट करना चाहता हूँ। इस कॉन्फ्रेंस के जो पिलर रहे हैं साइंटिफिक कमेटी के, मैं बोलना ही भूल गया। मैं डेली कम से कम 2 से 3 बार सर से बात करता था मिनिमम, और सर जितना हाइपर एक्टिव होते थे हमको डर लगने लगता था। हम बोले सर अब हम छोड़ देंगे, अब हम नहीं कराएंगे। इतना सर स्ट्रेस, हमसे ज़्यादा स्ट्रेस सर में रहते थे और वो सर स्ट्रेस में रहते थे। उनका स्ट्रेस हम पे आता था, हम डायरेक्टर सर को बोलते थे और वरुण सर को हम अब छोड़ देंगे, हमको कोई इज्जत का फिक्र नहीं पड़ा हुआ है। बोलते थे अनूप ऐसे करो, नहीं होगा तो ऐसे नहीं होगा, 20 दिन का टाइम है, दशहरा आ रहा है, नहीं कुछ होगा, डरा देते थे, बेसिकली डरा देते थे।
मैं कहूँगा 25 बॉल में इन्होंने सेंचुरी मारा है, 25 दिन के टाइम में इन्होंने सेंचुरी मारा, ये वर्ल्ड रिकॉर्ड है। कोई भी पर्सन इतने कम समय में ऑर्गेनाइज नहीं कर सकता है।
नहीं सेंचुरी मारे हैं, लेकिन मुझे लगता है कि बाउंड्री का दायरा आपने छोटा कर दिया था, इसलिए सेंचुरी लग गया। आप नहीं रहते तो नहीं होता।
नहीं सर, सब सुनील जी के गाइडेंस में हुआ।
नहीं सर का तो गाइडेंस है ही, लेकिन आप जो पीछे लगे रहे साइंटिफिक कमेटी का हर एक प्रोग्राम में, हर एक किसको क्या करना है, कैसे करना है, कौन नहीं आ रहा है, ये
सबों के सहयोग से हो गया, बहुत अच्छे से हो गया।
ये शब्दों से बयान नहीं किया जा सकता।
ये एक माइलस्टोन हो गया है। अगले ऑर्गेनाइजिंग सेक्रेटरी को सोचना पड़ेगा कि इससे अच्छा कैसे किया जाए। क्या रवि विष्णु जी आप जरा, ये इंडियन हार्ट जर्नल के एडिटर हैं, और मैं आग्रह करूंगा हमारे सीएसआई के सेक्रेटरी अनूप सिंह जी से कि एजेंडा बताएं इस जीबी मीटिंग में, और मैं जैसे ब्रीफ कर दूं। आइए अनूप जी यहाँ खड़े रहिए। सॉरी यूएन सिंह, अरे अनूप सिंह यूएन सिंह गड़बड़ा जाते हैं, थक गए। यूएन सिंह हमारे सीएसआई बिहार चैप्टर के सेक्रेटरी हैं। हम लोगों ने कार्यभार 1 महीना पहले ही लिया है, और अभी ये जीबी मीटिंग कर कर हम लोग कुछ इसकी फॉर्मेलिटी पूरी कर रहे हैं। रियाज कहाँ है? रियाज जी मिनट्स ऑफ मीटिंग जरा आइए ना, पेपर लीजिए, सबसे साइन करवा लीजिएगा।
All the respected President Sahab and the dignitaries sitting on the dais and off the dais. बेसिकली ये मीटिंग जीबी मीटिंग हम लोग ऑर्गेनाइज कर रहे हैं कि आगे का, अभी हम लोगों को नियरली 1 मंथ हुआ होगा नया कार्यभार संभाले हुए, और हम लोग प्लान कर रहे हैं कि आगे क्या करना है, कैसे करना है। अभी पिछले 1 महीने में करीब हम लोगों ने 2 CME ऑर्गेनाइज किया, और पब्लिक अवेयरनेस प्रोग्राम के लिए हम लोगों ने CPR जनरल पब्लिक के लिए स्टेडियम में ऑर्गेनाइज किया था। इवन पटना मेडिकल कॉलेज में जो जूनियर स्टूडेंट्स हैं उन लोगों के लिए CPR पे हम लोग कार्यशाला कराया था, उन लोगों को ट्रेनिंग दिया था कि कैसे लाइफ को बचाया जाए। और आगे हम लोगों का विस्तृत प्लान है। हम लोगों ने रजिस्ट्री के बारे में भी सोचा है कि कैसे रिसर्च वर्क को इस प्रदेश में, बिहार में हम लोग कुछ करें, कुछ प्रिवेलेंस स्टडी, कुछ ACS रजिस्ट्री के लिए हम लोगों ने ऑलरेडी प्लान कर लिया, और उसके इंचार्ज डॉक्टर विपिन भी हैं, ऑलरेडी उन्होंने परफॉर्मा बनाया है, और आगे हम लोग उसको करेंगे। ये बेसिकली जीबी मीटिंग में ये डिसाइड होगा कि हमारे जो जनरल है डॉक्टर, उसके इंचार्ज है डॉक्टर रवि विष्णु प्रसाद, एडिटर इन चीफ। तो फंड की दिक्कत आ रही है, हाँ खर्चा उसके लिए होगा, और फंड कहाँ से आएगा उसका भी हम लोग करेंगे कि कैसे फंड आना चाहिए, क्योंकि कुछ फंड तो है हमारे पास, लेकिन ये कुछ आगे तभी कर पाएंगे हमारे पास कि जो फंड रहेगा आगे एडिशनल कुछ इनकम होते रहना चाहिए, तभी हम लोग और इसके लिए आगे प्लान हम लोगों के कम से कम एक ऑफिस होना चाहिए, बिल्डिंग होनी चाहिए, जिसके के लिए हम लोग आगे कुछ कर सकें। तो ये इसके फंडे के लिए, इनकम एक्सपेंडिचर के लिए हम लोग मीटिंग करेंगे, और आगे कॉन्फ्रेंस के लिए डिसाइड करेंगे कि कौन करेगा, क्या डिसाइड करेंगे, इस पे हम लोग बात करेंगे इस मीटिंग में।
आप लोग से यही आग्रह है कि जो भी फंड नेसेसरी होगा वो हम लोग सेंक्शन करेंगे। जीबी पटिशन से अप्रूवल चाहिए, तो आप लोग का अप्रूवल है ना? इंडियन हार्ट जर्नल हम लोग पब्लिश करें ना? यस, मैंने बिहार जर्नल सब काट लिया। दूसरा है विपिन कुमार को बनाया गया रिसर्च कमेटी का इंचार्ज, वो ACS पे रिसर्च कमेटी बनाए हैं और रिसर्च कर रहे हैं, डाटा बिहार का निकलेगा, उसमें भी छोटा मोटा कुछ खर्च होगा। तो जीबी मीटिंग से मैं आग्रह करूंगा कि इस प्रोजेक्ट को भी आप लोग अप्रूवल दे दीजिए। और एनी अदर मैटर विद द परमिशन। उसमें सबसे इंपॉर्टेंट मैटर अब है कि नेक्स्ट ईयर का जो कॉन्फ्रेंस है, नेक्स्ट एनुअल कॉन्फ्रेंस ऑफ बिहार चैप्टर ऑफ CSI, डिक्टम यही होता है कि हम लोग इनवाइट करते हैं जो भी इंस्टीट्यूट या जो भी पर्सन इंटरेस्टेड है वो एक एप्लीकेशंस दें जिसमें कि सेक्रेटरी का नाम और ऑर्गेनाइजिंग कमेटी का नाम हो। तो इस हाँ ठीक है, हाँ जस्ट मिनट। तो आप लोग जो भी इंटरेस्टेड हैं वो सब एक एप्लीकेशन देंगे, और अभी किन्हीं को कुछ कहना है, कौन इंस्टीट्यूट ऑर्गेनाइज करना चाहता है आप कह सकते हैं, लेकिन ऑफिशियली एक एप्लीकेशन हम लोग रिसीव कर लेंगे। एग्जीक्यूटिव कमेटी की मीटिंग में डिसाइड हो जाएगा कि जो सबसे सक्षम होंगे हम लोग देंगे। ऐसा नहीं नेक्स्ट ईयर मान लिया दो इंस्टीट्यूट आ रहे हैं, एक को इस बार दे देंगे, एक को अगली बार दे देंगे। सब कुछ करना है, टीम वर्क ही करना है। क्या सुनील सर? हाँ, तो ये अगला साल के लिए कौन अभी हैं जरा? इसके पहले आप उनको थैंक्स दे दिए, आप बोलिए।
आइए मैडम आइए।
हम लोगों ने एक बड़ी गलती की, हमारी सबसे जो 1.5 दिन में जिन्होंने प्रोग्राम का संचालन किया उनको मैंने थैंक्स देना हम लोग भूल गए थे।
एक्चुअली हम लोग भूल गए थे कि एंकरिंग के लिए किनको रखा जाए, ध्यान ही नहीं था। जस्ट 1 डेज बिफोर कॉन्फ्रेंस मुझे याद आया, तो अचानक मैडम 7 बजे इनसे कांटेक्ट हुआ, इनको बुलाएं और 1 घंटे में ब्रीफ कर दिया। और बहुत अच्छे तरीके से इन्होंने जो ये 1.5 डेज का जो संचालन किया वो क्या बोलते हैं, काबिल तारीफ़ है। बहुत ही अच्छा से, बहुत ही अच्छा से। इसलिए मैं इनको धन्यवाद देता हूं। हमारी पूरी ऑर्गेनाइजिंग कमेटी की तरफ से मैं इनका शुक्रिया अदा करता हूं और उम्मीद करता हूं कि हर कॉन्फ्रेंस में हम लोग इन्हीं को इनवाइट करें। अब इस बार IGIC नहीं ले रहा है सर, कोई हाथ नहीं उठाया।
और अंत में मैं ज़रूर कुछ कहना चाहूँगी कि इस पूरी सृष्टि, इस ब्रह्मांड का एक ही रचयिता है, ऑलमाइटी, हमारे ईश्वर। उन्होंने इंसान बनाया, मनुष्यों को बनाया, उन्हें दिमाग के साथ दिल भी दिया जो धड़कता है, लेकिन इस दिल की धड़कनों की हिफाजत करने वाले आप हैं। तो आपके लिए मैं आपको नमन करती हूँ और अपनी लिखी हुई 2 पंक्तियाँ आपको डेडिकेट करती हूँ कि आप ही रहीम हैं, आप ही हैं राम, देश के ओ कर्म वीरों आपको सलाम। बहुत बहुत धन्यवाद आप सभी का। और इस 2 दिन के 29वें CSI के कॉन्फ्रेंस में मुझे आप लोगों ने ये मौका दिया, तो ये मेरे लिए बहुत ही सम्मान की बात है। और इतना सब कुछ, हालांकि मुझे सेशन समझ में तो कुछ भी नहीं आए, लेकिन मुझे बहुत खुशी हुई और ये मेरे लिए एक प्राउड मोमेंट था, मेरी लाइफ का एक बहुत ही खूबसूरत एक्सपीरियंस था। थैंक यू सो मच एवरीवन।
हम लोग की लास्ट बस इच्छा थी कि नेक्स्ट ईयर का कॉन्फ्रेंस के लिए कोई बीड़ा उठाए। इफ़ एनी इंस्टीट्यूट, एनी पर्सन इज इंटरेस्टेड। 2 हैं, तो 2 एक एप्लीकेशंस हैं, एक संजीव जी हैं एम्स और एक रवि विष्णु जी ने हाथ उठाया है IGMS। हम चाहते हैं कि आप दोनों में आपस में डिसाइड कर लें। हाँ, हम लोग डिसाइड कर लेंगे और बारी बारी से दे देंगे। हाँ, तो ठीक है, कर लेंगे सर, मतलब हो गया ना, कर लेंगे आपस में जी। नहीं, पहला एप्लीकेशन आया डॉक्टर संजीव कुमार एम्स का, दूसरा एप्लीकेशन आया रवि विष्णु जी का। तो ये चूंकि हमारा अपना, हाँ हाँ यस, संजीव जी हमारे सबसे सीनियर मेंबर हैं। इनको
हमारी एम्स की पूरी टीम कार्डियक और कार्डियक सर्जरी की यहाँ थी, अभी भी हैं। डॉक्टर अनुपम अंबानी हैं, डॉक्टर प्रगति कपूर हैं, डॉक्टर लक्ष्मी सिन्हा हैं। अगर आप लोग बोलिए तो अगले साल हम रिक्वेस्ट करें रवि विष्णु से कि हमें करने दें अगले साल। और चूँकि आप IGMS 2-3 साल पहले करवाया था, 2 साल पहले, तो हमें मौका IGMS नहीं सर, ये करवाए थे सर, ICC कराए। नहीं सर, जब SN मिश्रा प्रेसिडेंट थे तो BP सिंह ने करवाया था। हाँ तो हमारा रिक्वेस्ट है, आप लोग जैसा बोलिए कि जो कहेंगे हम लोग करेंगे। हाँ, हाँ, आप लोग बोलिए।
नहीं, अच्छा, आप लोग का क्या राय है? एम्स के फेवर में कौन है? हाथ उठाइए। और आईजीएमएस के फेवर में कौन है? हाथ उठाइए। अरे ये एक वो हंसी मजाक का है, लोग उठाते हैं, नेशनल सीएसआई में भी हाथ उठवाते हैं। सब लोग इक्वल हैं, दोनों में ब्रदरहुड है, आपस में दोनों में भाईचारा है। हम लोग मिलकर डिसाइड कर लेंगे। ओके, आप लोग अप्रूव करते हैं? हम लोग मिलकर डिसाइड कर लेंगे अगली के एग्जीक्यूटिव कमेटी में और आप लोग को कम्युनिकेट कर देंगे। हाँ, आइए अभिनव भगत जी, प्लीज कम।
आपको एम्स में बुला के आपको स्वागत करने का मौका दीजिए, फिर देखिए अटेंडेंस का बस चलवा देंगे, गाड़ी दे देंगे आपको। हाँ, कोई में कुछ में कमी नहीं होगी आपको। एयरपोर्ट से एम्स नज़दीक है। नहीं, जो बाहर से आएंगे, और आप तो अपने जैसे रोड बन जाएगा या पीएमसी से, तो आप ठीक 21 मिनट में पहुंच जाएंगे। कहीं भी कंकड़बाग से यहाँ आएंगे उससे कम टाइम में आप नहीं सर, तो पीएमसी से भी तो आ सकते हैं सर अभी।
हम लोग मौर्या में ही कराएंगे प्रीडोमिनेंट जितने भी कॉन्फ्रेंस, और वर्कशॉप जो है वो आईजीएमएस में करवाएंगे। आप लोग मौर्या में ही कराएंगे सर।
अच्छा, इसमें मेरा एक सजेशन है।
सुनिए, मौर्या में कराने में तो कोई इशू नहीं। मौर्या में तो आप हमको 1 महीना बाद बोलिएगा तो करा लेंगे, मौर्या में कराएंगे। लेकिन एम्स में करेंगे, आप लोग को भी चेंज होगा। हर एक साल यहाँ आते हैं, थोड़ा पटना में जाएंगे, वहाँ भी देखेंगे तो थोड़ा एकेडमिक एटमॉस्फेयर रहेगा और आपकी हॉस्पिटलिटी में कोई कमी नहीं होगी, ये मैं एश्योर करता हूँ।
हम लोग ऐसा करेंगे, हम लोग का 2 कॉन्फ्रेंस होता है एक साल में, एक एनुअल कॉन्फ्रेंस होता है, एक मिड टर्म होता है। तो हम लोग क्या करेंगे, एक एनुअल कॉन्फ्रेंस दे देंगे एक इंस्टीट्यूट को, एक मिड टर्म कॉन्फ्रेंस दे देंगे। लेकिन ये सब एग्जीक्यूटिव कमेटी, हाँ, छोटका को दूसरे पकड़े, ठीक है। ये एग्जीक्यूटिव कमेटी में फाइनल डिसीजन हो जाएगी। आप लोगों का राय हम लोगों ने सुन लिया है और ये जीबी मीटिंग में उसको हम लोगों ने नोट कर लिया है। आपस में बैठ कर हम लोग तय कर लेंगे। इसको बहुत लंबा डिस्कशन न करें। आई थिंक टाइम भी हो गया है, सब लोग भूखे हैं, फूड्स आर रेडी। सो I invite on behalf of CSI and Cardicon to please thanks you all and please join dinner and I mean lunch is ready and वो तो के बड़ू साहब उसमें लगे हुए हैं। हमको खुद ही नहीं पता है, मेरे को खुद ही नहीं कुछ मिला है, तो के बड़ू साहब से बात करनी पड़ेगी।
सभी सम्मानित अतिथियों से अनुरोध है कि बाहर रजिस्ट्रेशन काउंटर पे जो डेलीगेट किट दिया जा रहा है, आप उसे लंच के बाद प्राप्त कर सकते हैं। आप सभी का बहुत बहुत धन्यवाद। थैंक यू सो मच एवरीवन। थैंक यू सो मच।